Started. Right. We'll get started again. So my name is Shailender Bhatia. I'm a medical oncologist, and I have been at University of Washington and Fred Hutch Cancer Center for actually over 20 years now. And I have been in the melanoma department for the majority of it. Currently, I do serve as the director of the melanoma program, and one of the visions that we have for our melanoma program is to focus specifically on developing the ocular melanoma part of our program. We feel like we already do a lot of great work, but we want to kind of take it to the next level for the benefit of our patients. And so that is the long-term vision for the program. And an important part of that vision is an event like this, because whatever we do behind the scenes is all for our patient community. And I am so pleased to see all of you. This is the second iteration of our ocular melanoma patient-oriented symposium. The last one we had was in 2023. We want to do it every year, but our Fred Hutch team has been incredibly busy organizing a lot of these events for all the disease types, all the cancer types you can imagine. So we are happy with getting a slot every other year, and hopefully every time we do this, we will have lots of exciting updates to share with you. Now, I just want to start by saying this is all for you. A lot of people have been putting a lot of work behind the scenes to get us all together. And I just want to start by acknowledging one person who has really been spending a lot of time to make this happen. Her name is Ritu. She's standing right there. And I want to start by acknowledging her contributions. And then any of this event cannot be done by just one person. So, we have a team of people, and I am very fortunate to be joined by Dr. Andrew Stacey, whom probably all of you have seen at some point, and Dr. Evan Hall. So just a quick round of applause for both of them as well, please. So this event is being recorded, as we heard. Also, this is being broadcasted for our virtual attendees who could not join us in person. So for folks who are not able to join us today, this is being recorded for viewing later as well, and it will be put up on our website, and a link will be sent to all the folks to the video whenever it becomes available. For the virtual attendees, there is an opportunity to engage and interact with our speakers. If you have a question, you can actually put it in the chat. It will not be visible to other virtual attendees, but it will be visible to the hosts, which is us, the panelists, and we'll be monitoring the chat, and we'll be trying to bring it up as is relevant and if time allows, and we want to kind of try to answer all the questions either in the chat or address it in person here. Also, it will be actually helpful while you're listening to the talks, maybe a question comes to your mind, write it down. So at the end of the talk, then you remember what exactly the question was, and same for the virtual attendees as well. Let's see. So we have a pretty packed agenda, so I don't want to hijack a lot of time here for the first part of the meeting here. So in the first part of the meeting, we have two talks. So one is going to be by Dr. Stacey. He is going to talk about just the general overview of ocular melanoma, the biology of it, epidemiology, why does it happen, and how do we diagnose it, and what are our treatment options once it develops. So Dr. Stacey needs no introduction. He is the best thing that happened to our ocular melanoma program, I think over 10 years back now, something like that, 8 to 10 years back. And I think he has a very incredibly busy practice, pretty much patients who get diagnosed with this disease in the entire WAMI region, so Washington, Alaska, Montana, Idaho, even Oregon. A lot of those patients come here to seek his expertise. So he needs no introduction, and please join me in welcoming him for the first talk. All right.
Thank you, Dr. Bhatia. Alaska. And you're not alone. There's a big group, and that's part of the reason we want to do this, just to make sure everybody recognizes that you're not alone. There's a big group here. The doctors who you're going to hear from take care of patients like you all day, every day. And there's a lot of exciting things that are going on. To understand, though, the disease, we're going to talk about treatments and other things today, but to understand the disease, we have to actually understand what the disease is. And so I'm going to talk about what the disease is, including just the biology, how often it happens, why it's happening, and what's going on inside of the eye to make us recognize that there's a melanoma there. And I will figure this thing out. I'm just going to use that. So the goals here are simple. I'm going to take about 20 minutes or so. I'm going to put my clock on because I don't want to go over and I want to leave time for questions. So if you have questions, please write them down. And I'm happy to answer any question that comes up as we're talking. There'll be quite a bit of time afterwards to answer some questions. So I want to talk about what cancer is, and then specifically what uveal melanoma is. We'll talk about how often it occurs, in what age groups it's occurring in, how we diagnose it, and what the basic treatment options are. To start, we have to understand what cancer is. So cancer is the uncontrolled division of cells. The word cancer is an interesting word. We use the word cancer because it comes from the Greek word for crab. And the reason they called it a crab is because when tumors started to grow, they would, in the 2,000 years ago, see all of the blood vessels growing on top of a very large tumor, right? So this would be a tumor that was very late and had a lot of big vessels. And it looked like crab legs growing over this tumor. So they called it cancer. So whenever we use the word cancer, we're actually using the word crab to refer to the blood vessels. But there's a lot of words that we use in the cancer space. So I want to make sure we know what all of those are. We use the word oncology. The word oncology just means the study of masses. So onc is a mass. So an oncologist like Dr. Bhatia and Dr. Hall are specialized in the study of masses in the body. We also use the word neoplasia. Neoplasia is simply a word that means new growth. When there is something growing in the body that should not be there, we refer to it as neoplasia. So what is cancer? Fundamentally, cancer is a disease of mutation. So the cells in our body all have DNA. Our DNA should be a certain way. If there is a mutation in the DNA, it may mean nothing, or it may mean that that cell has proteins and other things that change and allow it to acquire abilities that it did not have before. So all day, every day, we are producing cells in our body. And many of those cells are normal, but not always. This process is not a perfect process. When you're dividing a cell, you're replicating the DNA. You're duplicating it. And as it duplicates, things can happen, little changes in the DNA. If there is a mutation in the DNA, sometimes the body catches it and eliminates that cell, but sometimes the body doesn't catch it. And if it doesn't catch it and the mutation allows the cell to grow or to change, then you're going to get something abnormal. You're going to get a cell that looks a little abnormal or has some abnormal characteristic. And it may just end there. A few mutations may not lead to any kind of a concerning thing. And you may go on living your life and it may never present a problem. But those cells that have developed some mutation may in the future develop additional mutations. And as they develop additional mutations, those mutations may allow those cells to grow further in an unregulated way. We all have tumors that have developed mutations that allow them to grow in an unregulated way. If you've been in clinic with me, I've probably pointed to this mole on my face. I once had a dermatologist tell me I should probably take this mole off. And I said, there's no way, because I point to it all the time when I'm talking to patients. You're going to have to really convince me that that needs to come off. This mole is exactly at this stage. It developed some mutations and allowed the cells in there to grow, but then it stopped and it didn't invade into other structures and it didn't invade into the blood vessels and spread around my body. At the moment, it's just a mole. But that mole has a potential, and that's why the dermatologist is watching it. It has a potential to obtain additional mutations. And when that unregulated cell growth develops the ability to invade, then it becomes cancer. So the definition of cancer is when something can invade or when it becomes invasive because it invades. We also use the word malignancy here. This is just a stepwise progression of mutation. Now, once something invades, it doesn't necessarily mean that it will spread. That may require additional mutations beyond the ones that allow the tumor to actually grow and invade. Those mutations can lead to metastasis. Each one of these steps along the path is a stepwise progression of mutation. I won't go into all of the mechanisms here, but the stepwise progression is important. And in this disease, melanoma of the eye, we're understanding more and more about what those mutations are and what they mean. You're going to hear a little bit more about that today, I think, from one of our guest speakers. So what is ocular melanoma? I have said this to some of you before. We all say the word ocular melanoma. I want you to understand, we can always say the word ocular melanoma, OM, right? We all say it. It's not technically accurate because there are various melanomas of the eye. The melanoma we're talking about today is a melanoma inside of the eye in a part of the eye called the uvea. And so it's uveal melanoma. There are melanomas behind the eye. There are melanomas in front of the eye that you could refer to as ocular melanoma, but are not uveal melanoma. So today, we may all say ocular melanoma, but what we're referring to is uveal melanoma. And so it's important to understand what the uvea is, because that's where the melanomas are coming from for the patients in this room. The uvea is a middle part of the eye. The eye is like a hollow ball. It's like a sphere, like a basketball. Most people don't realize that, but it's full of just a fluid. The outside wall of the eye has 3 layers. There's an outer shell, and then there's the inner part of the eye that provides, I wonder if you can see, no, it's okay. The inner part of the eye provides the vision, that's the retina. The middle part of the eye provides some additional characteristics, and this is where the uvea is. In the front, you can see the green part there is the iris. In the middle, the orange part is the ciliary body. And in the back, that part is the choroid. The iris, we all know well. It's the thing that we see with color, blue, hazel, brown. Its purpose is to block light and let light in. So when there's a lot of light, the pupil gets very small and lets just a little light in. When it's dark, the pupil gets really large and it lets a lot of light in. The ciliary body behind it has some very important functions. Specifically, it regulates the fluid inside of the eye and helps the eye stay full and buoyant. The choroid in the back is very important. The choroid is the blood vessel layer that supplies blood to the retina so that we can see. Now, what does the choroid do? It essentially is, its main goal is just this blood vessel, but it has these cells. Now, why these cells are in this part of the eye, I don't know. We'll ask Dr. Mruthyunjaya at some point. Maybe he has the answer. The melanocytes are the pigmented cells that we have throughout our body. Melanocytes are in our skin to help block UV radiation, to help protect our bodies from external things. But you saw back here, the ciliary body never sees light. And yet it also has these cells called melanocytes. We don't know exactly why the melanocytes are in the eye in all of these various situations, but we do know that they are there, and we know that they can cause problems. The melanocytes in each layer of the uvea can undergo mutation. and they can become melanoma. This is why we see iris melanoma, ciliary body melanoma, and choroidal melanoma. The three of them together we refer to as uveal melanoma. The vast majority of patients have choroidal melanoma, and only a small subset of patients have isolated melanoma in those front structures. We talked a little bit about the mutations. We know which mutations cause melanoma in the eye. We know which mutations lead to metastasis of melanoma in the eye. We don't know exactly why these mutations occur, but we do know what they are. So how often does this occur? Somebody today said, commented about the age of patients of melanoma, and the age of patients here in Washington is very much average. The average age is about 50 or 60 years old, but there is long tails here. So we have children with uveal melanoma, unfortunately, and you can get uveal melanoma all the way up into your 80s or 90s. It is a little more common in males, but not so much. It is the second most common location for melanoma in the body. I'm proud of that, even though we are very far down, right? Skin melanoma is about 93, 92% of all melanomas. Ocular melanoma is second with about 5% of all melanomas. There are about 6 people per million. So that means that in the state of Washington, we get about 50 or 60 cases a year. And in the WWAMI region, we get about 120, 150. If you don't know the term WWAMI, that's what the doctors here refer to. Washington, Wyoming, Alaska, Montana, and Idaho. Most of the patients from those areas, including parts of Hawaii and the Dakotas, will also come here for treatment. So how do we diagnose it? The very interesting thing about melanoma in the eye and some other cancers in the eye is that the gold standard, or the thing that we rely on for the absolute definition of melanoma, is not a biopsy. It is simply the doctor looking in the eye and saying, this is melanoma. That doesn't happen almost anywhere else. Think about your friends and family who've had other cancers. When they have a lung lesion or a skin lesion or a liver lesion, they all go in for biopsy, and then we wait and we cross our fingers and we get the result of what the biopsy is. But that doesn't happen for the vast majority of you. And there's a reason for that. Remember, the eyeball is a hollow ball. I can't take my son's basketball and cut a circle out of it and then give the basketball back to him and say, hey, go play basketball. It simply isn't going to work. So we can't remove the whole thing and not destroy the organ itself most of the time. We can obtain biopsies, and we'll talk more about biopsies, but these biopsies, it becomes very challenging to distinguish between a mole and a melanoma from a small needle biopsy. Consider that a needle is going to pull out just a few cells. And I'm going to pull out those cells, and I'm going to do a lot of stuff with them. I'm going to put them in a lot of fluids, and then I'm going to lay them down on a slide, and I'm going to give them to my pathologist, who's going to look at them, and I'll tell you exactly what that pathologist is going to say. They're going to say, there are some melanocytes on this slide that look a little bit abnormal. Please correlate clinically, which means I have no idea if this is a melanoma or not. So we just can't make the decision. With a biopsy, we have to rely on other methods to determine if something is a melanoma or not. So we're going to talk about those methods. Usually, melanomas in the eye start as moles, or what you'll hear us refer to as nevi, 1 nevus, 2 nevi. They can appear in very diverse ways, but they are very common. About 5 to 10% of individuals have some sort of a nevus in their eye. But nevi can also change. Just like the moles on our skin, the moles in our eye can change. And I'm going to show you a few pictures of how these moles change. Here on the left, you see a mole with some blood vessels on the top. And over time, we saw that those blood vessels turned into tumors growing on the surface of the mole. Here's a mole that grew in a flat way. You can see that little projection aiming towards the center of the eye after it grew over a number of years. Here is a mole that looked rather benign initially, but then the whole thing just simply grew as we watched it. Here's a mole that had a little bit of a funny edge, and you can see as we watched that edge grew. So what happened in this mole and all moles is that initially there was a mutation that allowed the melanocytes, or the cells in the eye that produce a mole, to grow in an unregulated way, but then they stopped, and they could have stayed that way for decades. But then the little cells right there at the edge developed an additional mutation that allowed them to continue to grow and then not stop growing. That's when we have to do something about it. So this can happen in each of the 3 departments of the uvea. It can happen in the iris. It can happen in the ciliary body and the choroid. So we're going to talk about each of these briefly. An iris melanoma is rare. It happens, 2% of the time, not very often. Interestingly, melanomas in the iris are very low risk to the rest of the body. And we treat them, but we treat them mostly to prevent them from getting very large and destroying the eye. But they very rarely ever spread to the rest of the body. The ones that spread more often are the ones in the back, the ciliary body and the choroid. Tumors or melanomas in the ciliary body, we often don't see until they are much larger than melanomas in the choroid. And that's simply because they hide behind the iris. It can be 3, 4, 5 millimeters thick, and you're never going to notice, and nobody's ever going to be able to see it because it's behind the iris, and there's no way of knowing that it's there. So often when we have a ciliary body melanoma, it presents with a little bit larger size than a choroidal melanoma. Choroidal melanomas grow in various ways. Here's one that grew in a dark color first, and then a little nodule on it grew in a pale way afterwards. We diagnose these sooner, usually, because they're affecting your vision. And that's how many of you came in, is with some sort of a vision change. And you saw your local eye doctor, and they referred you to a specialist, and then they referred you here. It's a 2-edged sword. There's an upside and a downside to this, right? So if you have a choroidal melanoma very close to the center of the vision, we'll normally catch it sooner and treat it sooner. But it also means that the treatment will likely destroy the vision in that eye. So how do we make the diagnosis? And I'll talk here specifically about choroidal melanomas. We make the diagnosis using something called risk factor stratification. I'm going to have to start moving a little quickly here. We look for various signs in the eye to tell us if the mole is concerning or has a risk of growing. A mole that is growing is a melanoma. Now, moles can grow and stay moles, but they would grow at a very slow rate. An appreciable rate of growth is the indication that the thing we're looking at is not a mole and it is a melanoma. And so we use these risk factors to help us determine which of these lesions are going to grow and become melanomas. The first thing we look for is the thickness, and we do that with an ultrasound. So many of you are getting ultrasounds most of the time that you come to the office. That tells us the thickness of the lesion. We also get some information about how that lesion looks on the ultrasound that can help us differentiate between a mole and a melanoma. There is also a pigmentation that occurs in the melanoma. I'm very interested, Dr. Mruthyunjaya, how do you pronounce that word? So though, as I will explain at some point, he trained in the UK, it did not rub off on him as much as it rubbed off on me, because I say lipofuscin, but Americans say lipofuscin. This is an orange pigmentation that occurs inside of the lesion and gives us an indication that the thing is active and likely going to grow. We look for the presence of fluid between the choroid and the retina. We call that subretinal fluid. That's also an indication that the lesion is active in some way. One of the hardest things that an ocular oncologist does is differentiate between melanoma and everything else. There are a lot of things that look like a melanoma, and that's where the training to become an ocular oncologist is the most useful, is differentiating between melanoma and what is not melanoma. Only one of the things up here is a melanoma, and it's probably the thing that an early eye doctor would put at the bottom of their list because it's the thing that is very pale and has no pigmentation. Everything else is not a melanoma and not very concerning. we use the risk factor stratification to help us determine which of these things is likely to become a melanoma or a melanoma already. Now, when we diagnose a melanoma, it does require treatment most of the time, and that's because without treatment, a melanoma will grow. This is a patient who did not want treatment, and you can see what happens with the melanoma over time. It will simply continue to grow bigger and bigger, and the bigger it is, the faster it will grow. That's why we recommend treatment. And though the treatment is often somewhat devastating to the eye or to the vision, if we did not treat it, the growing melanoma would also be devastating to the eye and the vision. So the decision to lose vision or to lose the eye is not one that usually you or the doctor makes. That's already been made by the melanoma. What are our treatment options? There are situations where monitoring or surveillance is not out of the question. For very small melanomas, the risk of them spreading is also very small. So it, in some situations, might make sense to watch that melanoma instead of destroying the vision. Let's say that you're 90 years old and you come in with a very small melanoma right next to the nerve of the eye. If I treated you in some way, you would lose the vision in that eye. If I didn't treat you, the risk of that thing ever spreading and causing you to lose your life is very low because you're probably going to die of something else before this happens. It's something that, we don't love talking about, but it's something we talk about a lot in cancer. A lot of people, men in particular, develop prostate cancer. Most of them don't receive treatment for the prostate cancer, and that's simply because the vast majority of people with prostate cancer will die with their prostate cancer and not from their prostate cancer. So we do just watch in some situations, though those situations are somewhat rare. We can treat with lasers. There are a few ways that we can treat with lasers. Some of you were treated with a cold laser called a photodynamic therapy laser. We try lasers in some situations to try and preserve the vision. So there are some patients and some tumors that are small that will respond to laser, although not all of them respond. And so in many situations, we try laser, knowing that the rate of controlling the tumor with the laser is rather low, 50% or less. But because there's minimal risk from the laser, we might try it first just to see what we get. You've probably heard a little bit about a new treatment being done with the laser, where medication is injected into the eye, and then the laser activates that medication. That is a clinical trial currently being run by the Aura Biosciences company. I'm very excited about it. I have no relationship to that company, but I'm hopeful that lasers become a bigger part of what we do in the future. This is just a picture of a patient before and after the photodynamic therapy. This is one where it worked very well. You can see that the rest of the eye actually remained very healthy, and vision has remained very good after photodynamic therapy. I won't go too much into this because Dr. Jonathan Chen will talk to us more about radiation in just a minute. But the mainstay for most patients with uveal melanoma is radiation of some form. There's two main ways to deliver the radiation. One is a plaque, which is called brachytherapy, and one is external beam radiation, which can be delivered in various different ways. Here in the Pacific Northwest, we have a proton beam, and many of our patients are treated with a proton beam, which is a form of external beam radiation. Here's just some before and after pictures of what can happen to a tumor after it is treated with radiation. For tumors that are large, we do sometimes revert to surgery as a primary treatment option. We can treat, actually, with our proton beam, any tumor, and we can treat it safely. And the vast majority of patients who are treated with a proton beam will have control of their cancer in the eye. However, the bigger the tumor, the higher the amount of radiation. And at a certain level, it just doesn't make much sense to send the radiation into the eye because the eye will very quickly shut down. It will lose its vision and it will become blind and painful. So in those situations, we have a discussion about removing the eye in the first place. And I know some of you have done that. You've removed the eye in the first place. Sometimes we try the radiation and then the eye does shut down. And in the end, we have to remove the eye secondarily after the fact. We don't at this meeting have somebody to talk about prosthetics, but it is a wonderful field. It's when you have an eye removed, it's actually not what you would expect. Disney, Pirates of the Caribbean, Hollywood, they've all lied to us. There's no such thing as a glass eye. I don't know where that came from. It's not real. It's a very elegant process, and about a third of my patients end up having an eye removed. And I tell patients when they come to clinic, a third of the patients you saw in the waiting room don't have one of their eyes, and you had no idea which patients it were and which eye it was. It's a very elegant process. I won't go too much into this. We do stage the tumors based on their initial size, and we also stage the tumors based on what's happening inside of them. So we obtain biopsies to look for the mutations inside of the tumors that helps us determine what the risk is that these tumors may spread in the future. And we're going to hear a little bit more about that today. I know that the diagnosis is daunting. And it's something that I think about every day because I sit with you guys every day and we talk about it. But I'm also very excited about the future in this diagnosis. I got into the field at a good time. For many, many years, things did not change in this field, but we are in a very exciting place. New treatments are coming out. We have FDA approval for multiple treatments, both in the primary setting when the tumor is just diagnosed in the eye, and in the metastatic setting when the tumor has spread to the rest of the body. That was not true until just a few years ago, but we have new treatments, they are approved, we have new clinical trials, there's a lot of excitement in this world. And so I would focus on the positive here. It's a very good time to be an ocular melanoma patient. Thank you guys so much. And I'll take any questions you have.
Questions for Dr. Stacey? Just raise your hand and I'll bring the mic to you. Oh, yeah.
Sorry. The slides will be available, right? As well as the audio.
Yes, right. The slides will be up and the audio.
We'll be sending a link to the recording, but for the slides, I'll check with the speakers if they're okay with having those shared as well.
Yeah. But in the video, you will be able to see all the slides just like you're able to see it right now. So, yeah. Yes.
Are government budget cuts affecting research at ocular melanoma at all?
Yeah, so I'll just be honest here. We're going to try to not get very political today because everybody has enough stress in their lives, everybody who's here. But I mean, we have to say yes to that. Absolutely yes. So it's a challenge. Thank you. She asked if federal budget cuts are having an effect on what's going on. So let me answer that actually a little bit deeper. We are at what we call an orphan disease, which means few people have this disease in the country. And so it's hard for pharmaceutical companies to become interested in us, and it's hard for federal granting agencies to become interested in us. So while the answer to the question is yes, federal funding cuts are affecting us, the truth is probably not nearly as much as other diseases because there simply wasn't much funding for us in the first place.
Question from the online chat. The question is UW running any clinical trials at this time? And I'm going to modify that to say for localized disease, are there any active trials that are running in our institution or things that you think are particularly exciting in the pipeline?
Yeah, absolutely. So, and Dr. Hall changed that because we'll talk a little bit more about clinical trials in the metastatic setting or what is called the adjuvant setting a little bit later today. But yes, we are open for a few clinical trials in the primary setting. That Aura Biosciences trial, I was about to look up and see if anybody here was treated, but that I'm not going to do that. We have treated people here, and we are open for business in that trial. I'm very eager to see the results of that trial. We have, with the help of Dr. Mruthyunjaya, been involved in some other very interesting trials for large tumors when they come in that they are so large that they cannot be treated with radiation. There is currently a trial giving a chemotherapy agent to decrease the size of the tumor so that it can be treated with radiation. And we're excited about that potential as well.
Could you comment a little bit more about post-treatment and the cancer's under control? We do a regular coming back to you to see if cancers come back. And I think in the past you mentioned that for those people who have lost their vision completely in the eye, you use a laser. Is that the case of a hot laser, cold laser, or something else where you aren't concerned about vision loss?
Yeah, so I'll restate his question as I'm answering. Yeah, we're not going to, it's a great topic, and probably at the next meeting, we should have a whole talk on the life of an ocular melanoma patient after radiation. And because that's what the majority of your time is spent doing. Everybody is different. Every situation is very different. And so the laser that I referred to here is a laser to treat a tumor and destroy a tumor. Many of you who have had radiation will end up having a different kind of laser whose goal it is to try and decrease the side effects or the damage from radiation to the eye. And every situation is different, and there are a few tools that we use. We use lasers to try and decrease the damage inside of the eye. We also use medications, often injected into the eye, to try and decrease the damage from the radiation in the eye. But it's hard to generalize that because the tumor and the radiation and the response is different. In fact, interestingly, I could have the exact same size tumor in the exact same location in 10 patients, and I have absolutely no idea how to predict who's going to do well and who's not going to do well from the radiation. And so when you hear me in clinic being very generic about what's going to happen to your vision, I'm not just holding information back. I literally cannot predict what's going to happen.
I was wondering if there's been studies on the likelihood of the children of patients, if it's been around long enough to really know how likely a child is to inherit this DNA.
Yeah, that's a great question. And we do know a lot about that. And the most important take-home point is the risk is very low. When we see that happen, we normally see it in families where it's already happened. So if a patient comes to me and says, or I diagnose them with a melanoma, and when I ask them about their family, they say, oh yeah, my mom died and her eye was removed. They didn't know what it was, but then she died from liver cancer. And I had an uncle who also had an eye removed and died young. These are the situations where there's a gene running in the family, but it's extremely rare. Only 1% of patients with a melanoma in the eye are going to have a gene that runs in the family.
When I saw my ophthalmologist, because I had sort of twinkling changes in my vision and I knew there was something going on, he looked and said, yes, you have a retinal detachment, and sent me to see a retinal specialist who, after 5 seconds, said, you have two problems. And so I wondered how long I had the second problem that wasn't seen, because I was seeing him about every 6 months.
Yeah, it's a great question. Diagnosing ocular melanoma is not easy. And even very good specialists will look at something and think it is something else before the diagnosis is made. So it is not something that we expect local eye doctors to be able to diagnose. We expect them to be able to say, hey, something's not right. We're going to send you to a specialist, which sounds like what happened. In terms of the question, how long? That is very tough. What I will say is ocular melanoma is not fast growing. It's slow growing. And so if you had a detachment in your retina, it was probably growing not over days to weeks, but months to years. And so when we get diagnosed with a cancer, that's the first day we know about it. And then all of a sudden we want things to happen very quickly, and we wish things had happened the week before and the week before. But the truth is, it was years in the making, and nobody probably would have ever been able to see it until you had a retinal detachment and had something funny happen in your vision.
Would you be able to describe, you were talking about the laser therapy, and could you describe how that actually is done?
Yeah. How it actually works,
Yeah.
debatable, by the way.
Yeah.
But this particular, so the PDT, photodynamic therapy, what's done is you're given an IV and you're given a medication called Visudyne. The medication cycles through your body. It has really no effect on your body whatsoever. It's very safe. We aim a laser at a certain wavelength. That wavelength of laser activates the medication only in the area where the laser is pointed. And so in that area, the medication is activated. And the way this medication works is it works against the blood vessels that are feeding the melanoma, and the cells that line the blood vessels. They can be leaky and cause some problems. This medication targets those blood vessels and tries to shut them down. And so it's working against the blood vessels of the melanoma, and everywhere else where you are not aiming a laser will not be affected by the medication. Potentially you could, but unless the laser was aimed at it, there would be no effect of the medication. And whether or not it works on the skin, I am not a cutaneous skin melanoma expert, so I'm not sure. They do use this photodynamic therapy for many skin things, though.
Just for the online audience, the question was, if somebody has cutaneous melanoma, can we use laser? So just wanted to say that out. Question over there, and then.
Dr. Stacey, I don't know if this is a question, but when I was diagnosed in 2013, there was a lot of confusion for patients because we were diagnosed, but we also thought that was the prognosis. And people from 2012 and 2010 were on the cusp of me having Castle testing and gene testing. They hadn't had either. So do you know, is there more progress coming?
Yeah, so what the question is, so testing, when we get biopsy testing, at the moment, when people talk about biopsies of melanomas in your eye, they're not pulling out cells and looking at the cells. That's normally what a biopsy is for diagnosing a tumor. What we're doing here is we're taking the cells and we're chomping them up, and we're looking at their DNA and what the DNA is creating. At the moment, the tests that are available are really only useful to help us know what the risk is of spread to the rest of the body. I do fully expect that in my career and in my lifetime, we will get to a point where we see a lesion that looks concerning, and we can pull the cells out and look at the DNA and figure out if the DNA is more consistent with a mole, more consistent with a low-grade melanoma or a high-grade melanoma. We are officially not there yet. Some people would say that they think that they have the information, and those are interesting conversations, but officially we are not there. The biopsies are only available and useful for prognosis at the moment.
Andrew, we have one last question.
Okay.
Can you give us an elevator speech for what we should say to people in our life, the importance of getting a dilated eye exam?
Yeah, I'll give you my thoughts. I'll also give you our Academy's thoughts, which you may not appreciate. It is tough because in medicine, we have to consider costs to the whole country. And how many patients do we have to dilate for us to find a melanoma sooner than we otherwise would? And I'll tell you, that number is very high. However, how many patients do we have to dilate to find something that needs to be addressed? That number is much lower. You know, if we're dilating 100 patients who are 50 and 60 years old, in a fair number of them, we're going to find something to address, something that should be looked at, but we're not going to find many melanomas. And so would I like every American to be dilated every year or have a photograph taken every year? Sure, absolutely. I would love that. And if people have the insurance to do that, go get your eye exam. Do I get my own eye dilated every year? I won't answer that question. But yes, ideally, yes. It's just, I don't know that we could sustain having every American have a dilated exam every year. I just don't think we have the doctors for that.
But you do look at that mole every day, right?
Every day I look at that mole.
Yeah, just quickly to combine the two questions on the biopsy and inheritance, can that same process be used to identify DNA changes that tell you it is inheritable, or exclude that or not?
That's a technical question. I would say no. You wouldn't be biopsying the tumor to figure out if the patient has a high risk of passing it on. You would draw their blood and you would look in their blood for the mutations, because if they have a chance of passing it on, what's happening in the tumor is not really relevant. It's what's happening in what we call the germline, or the ovaries, or the sperm, right? So that's what we need to know, is if those mutations are in the part of the body that can pass it on. Thank you all.
Well, that was an excellent talk and overview of the disease. So once patients have seen Dr. Stacey, generally, if they're not getting surgery or enucleation, generally they would be referred to our radiation oncology team. And the chances are that they will be seeing Dr. Jonathan Chen. Of all the speakers today, I believe Dr. Chen is the only one with a double doctorate. So he has an MD, PhD, and he's an assistant professor at University of Washington, and he has been taking care of our ocular melanoma patients for the last several years. So please join me in welcoming him.
Morning, everybody. It's an honor to be here. We'll jump straight in. So yeah, I'm Jonathan Chen. I'm a radiation oncologist. One of my specialties is in proton therapy for ocular melanoma, which we'll talk about today. All right, the first part of my talk is going to focus on giving some historical context for radiation therapy, especially in ocular melanoma, and how we arrived at proton treatment. And then the second part of my talk is going to talk a little bit about some innovations that are happening. It gets a little bit technical. I'll try not to bore you, but I'm happy to answer any questions in the break afterwards as well. All right, so first, an introduction to radiation. So radiation has emerged as the optimal treatment for many ocular melanoma patients. The reasons for those are that it provides equivalent survival rates to upfront surgery. It gives a chance at preserving the eye and maybe some vision. And usually the potential for a salvage surgery still remains if we try radiation first. Now what is radiation? In short, radiation you can think of as just its energy. And radiation therapy is harnessed energy. You can classify and categorize radiation based on what energy it has. So this graph shows a spectrum of energy from the lowest on the left to the highest on the right. Microwaves are radiation, fire emits infrared, which is radiation, but those are all low energy, non-ionizing. The medically useful radiation that we use in treating patients is all on the right side of that graph, high enough energy to be ionizing, meaning if it encounters an atom, it can create ions. And the most common ones that we use are X-rays and gamma rays, you'll see over there on the right. Now, the concept of radiation itself was discovered sometime around 1896. Oops. Oh, before I get to that. So how does radiation work? Dr. Stacey kind of touched on this a little bit, but radiation takes advantage of the fact that cancer cells have gone through all those mutations that Dr. Stacey talked about. Now, radiation itself doesn't discriminate. Any cell that it comes into contact with, it will cause and inflict damage to the DNA of that cell. it will cause the same amount of DNA damage, whether it's a cancer cell or a non-cancer cell. When a cell encounters radiation and develops DNA damage, if there's enough DNA damage that's not repaired, by the time that cell tries to divide, the cell will die. The amount of DNA damage that occurs correlates with the amount of radiation dose that that cell receives. So there's three things that affect whether the chance that a cell will die after it encounters radiation. The dose it receives, which is technically related to the distance from the radiation beam, the rate of proliferation of that cell, how quickly is it going to try to divide next, and then the DNA repair mechanism that that cell has. Now that actually varies, that last point actually varies from not only cell to cell, but person to person. We don't know this for sure, but I speculate that a lot of the uncertainty that Dr. Stacey and I have about how a patient's going to respond, how your eye is going to respond to radiation, is some intrinsic difference in your cell's ability to repair DNA damage than someone else's. All right, so cancer cells specifically, we optimize for all three of these things, right? They have zero distance from the radiation beam. We're targeting it at the cancer. They typically are the fastest growing or fastest proliferating cells in that area. And the mutations that led to it becoming cancer, a lot of the times involved the loss of those same DNA repair mechanisms that they rely on. So that's why they're exquisitely sensitive to radiation. But they're not the only cell that can die from the radiation. Regular non-cancerous cells in your eye can die as well. And it's a bit of a probability stochastic chance. At any single individual radiation dose delivered, there's a certain chance that the cancer cell will die and a certain chance that a non-cancer cell next to it will die. And the gap between that is what represents what's called the therapeutic window. Now, we wish these curves were far enough apart that you could have 100% cancer control and 0% adverse events. But for most cancer sites, maybe all cancer sites and types, there's some overlap between those two graphs. And so in an oversimplified way, a lot of what cancer researchers and radiation research are doing is trying to move those two curves apart. They're either trying to give treatments or optimize treatments to move the cancer control curve to the left, so it would require lower doses in order to kill the cancer, or giving protective treatments to the other cells of the eye to move the red curve to the right, try to increase our therapeutic window. This is important for all cancers, but I'd say it's especially important for ocular melanoma because with ocular melanoma, we usually have surgery as a backup option. We could have done that in the first place if what our focus was just getting rid of the cancer in the eye. What we're trying to do with radiation is trying to treat the cancer and preserve the eye. But loss of the eye can sometimes be from damage from radiation as well. So it's this fine balance that we have to make. You know, where do we slide the radiation dose on that curve? What's the optimal point? Well, that's what we're trying to figure out. All right, now back to what I was saying before. So radiation was discovered as a concept in about 1896. And just a few years later, brachytherapy was invented. So what brachytherapy is the delivery of radiation to a tumor by placing a radioactive element or isotope directly into or near that tumor. So the first brachytherapies were using radon needles and seeds and things like that, and were first applied to ocular melanoma sometime in the 1910s. And so back then, they were inserting hollow seeds filled with radon gas directly into the eyeball to treat ocular melanomas. Not long after, the first published case in 1939, they developed plaque brachytherapy, which is where we embed the radioactive seeds into wax placed into a plaque, usually made of gold, like you see here, that can be placed on top of the surface of the eye to deliver the radiation, and then therefore can be removed later. It doesn't have to stay in the eye. This was developed 80, 90 years ago and still is largely similar to kind of how we do things today with plaque brachytherapy. There's lots of sophistication that goes into brachytherapy and advances there as well with plaque design, how we select the isotope that we use. For example, in America, the most common isotope we use is iodine-125, which has certain advantages. Other countries sometimes use ruthenium-106, and there's pros and cons to each. This talk was supposed to focus on proton therapy, so we'll talk less about brachytherapy. All right, the next leap forward in radiation treatment in general was the development of the linear accelerator in 1952. This was a machine that allowed us to generate medically useful high-energy X-ray beams without having to handle dangerous radioactive metals and isotopes. And so this linear accelerator machine, which you see on the right is how it looks today, finally allowed commonplace and widespread distribution of radiation access to all patients, not just centers that had ability to handle radioactive isotopes. These are now the most common deliverer of radiation therapy for cancers, not ocular melanoma, but for all cancers in the United States today. Not long after, in the 60s and 70s, a huge jump forward was also made with the invention of CT scans. Before CT scans, radiation doctors had to plan and aim the radiation at your tumor using X-rays. Now, as you guys can know and can see, X-rays are really good at seeing bone, but not very good at seeing soft tissue or organs or tumors. So well, not we, I was not alive back then, but what radiation doctors did back then is they had to use bony landmarks to approximate where your tumor would be. If you had cervical cancer, well, I know it's kind of close to the femoral head and the acetabulum, and so I'm going to aim 1 centimeter middle to that. That was really how radiation doctors had to aim back before cross-sectional imaging with CT scans. CT scans gave us the first ability to actually look inside the body and see where all the organs were, where the tumor was, and actually be able to aim at that and not just guess. Not long after that, in the 70s and 80s, a new type of radiation was developed called proton therapy, which is what we're focusing on today. Proton therapy is distinct from standard radiation, which uses X-rays because of the particle in the beam. So proton particles versus X-ray particles. Now, an X-ray particle was much easier to accelerate to the speeds needed to treat patients, especially in a small template, a small size. These machines here fit into a standard size room. The things needed to accelerate protons, which we call cyclotrons, were much, much, much larger. These are accelerators that, you know, in Europe, for example, the Hadron Collider are many, many miles in diameter at first. In the 60s and 70s and 80s, they were able to reduce the size to about 16 feet in diameter, which is the cyclotrons that we now use in most proton therapy centers. Now, what is the potential advantage of proton therapy versus X-ray therapy? Now, X-ray therapy is used by some centers for treating ocular melanoma. There's debate about whether it's inferior or equivalent, but mostly it's given by centers that don't have proton therapy. The potential advantage of protons, you see my mouse? No, okay. The orange curve in figure 2 over there represents how an X-ray beam delivers radiation inside of a patient. You can think of the y-axis on the left as the surface, the skin of the patient. As the X-ray beam is shot in and travels through the body, all of that is radiation dose delivered. Oh, is there a laser there? Oh, on this screen, I see, only on the left screen. Okay, all right, so not on the right screen. Okay, so the maximum dose an X-ray beam delivers is actually just at the surface. But then it continues to deliver a sizable amount of radiation as it passes through the entire body before it exits. A proton beam, in contrast, delivers the majority of its radiation energy and dose at a specific depth inside the body. This is called the Bragg peak. There is a little bit of entrance dose, but after the Bragg peak, the amount of radiation delivered drops to 0. The proton beam stops at a depth that we can control. So theoretically, if you were to superimpose the two, a single X-ray beam versus a single proton beam targeting a tumor right here, you would be able to decrease the amount of radiation exposure both before and after the tumor with proton therapy. So the first proton therapy treatment that was published in the literature, at least, was in 1975 at Harvard, at the Massachusetts Eye and Ear. And what they found was that with proton therapy and its ability to spare the nearby structures, they were able to treat much larger tumors than had been previously feasible, and with some potential, again, debatable benefits for both small and medium tumors as well, with sparing the nearby structures. Proton therapy today represents the second most common type of radiation treatment, probably the best external beam radiation therapy, second to plaque brachytherapy. There is ongoing investigation in how we decide between these top two choices, though: plaque brachytherapy and proton beam therapy for ocular melanomas. Now, research into this question has been limited by the fact that almost all centers either do one or the other. They don't do both. At Fred Hutch here, we do both, and we have expertise in both. And so part of what we're trying to do is figure out exactly which patients are best served by which treatment. Current data suggests that local control may be better with proton therapy than brachytherapy. This is obviously variable depending on the size and location. There may be different toxicities, though, or side effects. We've found, and other people have found as well, that proton therapy may, for some reason that we're not yet sure of, cause more damage and complications to the structures in the front of the eye, the so-called anterior segment, things like the sclera, the iris, the ciliary body, the cornea. So sometimes for tumors that are more close to the front, we'll select plaque brachytherapy than proton therapy. Some centers have suggested there may be more visual acuity loss with brachytherapy, but I think this does depend on the technique. And then there are just technically feasibly certain tumor locations that you can't use plaque to treat. Plaques that overlie the optic nerve, for example. You can't get a disc to be able to cover that, or very large tumors, you wouldn't be able to get a large enough plaque to surround it. And so for those, if you want to go for radiation and not enucleation, proton therapy would be your best choice. All right, what are some things recently that have been advancing in proton therapy? The first one is what I just kind of mentioned in passing already, which is the continuous refinement of how we select the treatment and the planning for your cancer. This is an orphan disease, just meaning that this is not as common as prostate cancer, for example. There's not as much money going into it, and there's not as much opportunity to do research that sometimes requires you to have 1,000 patients compared, because it takes a lot more time to collect 1,000 patients with ocular melanoma treated. But we are continuously looking at our data, looking at our outcomes to see what's the best treatment for each individual patient, for each type of tumor, each location. The way that we deliver proton therapy has also changed. To really understand some of those changes, I first have to talk about how we make a proton therapy plan. So the first thing that happens after you're diagnosed and referred to a radiation doctor, and everyone agrees on proton therapy, is you'll have an MRI, a cross-sectional image that gives us information about where your cancer is relative to the other structures in the orbit. You'll often also have markers made of tantalum placed into your eyeball to help with targeting. You then undergo something called a CT simulation, or you have undergone something called a CT simulation, where we make a mask to immobilize your head. We have certain things in place that different centers do differently to help try to immobilize the eye. And then we do a CT scan to fuse with the MRI scan that allow me and my staff to delineate exactly where everything is. So we typically in the past have just used those structures, the CT scan and MRI information to figure out where's the tumor, where's the optic nerve, where's the lens, where's the lacrimal gland, things that we have to try to spare and to treat the cancer. Once we've done the delineation, the next part is the part that is really fun for radiation oncologists. And it's the part that requires the most dependence on expertise and creativity, which is figuring out what's the optimal radiation plan. These days, a lot of this is done by computers and AI, but there's still manual iterative checking of these plans. We have to figure out what's the best angle to approach your tumor with, what's the best energy to use, and how many beams do we use? Do we come just from the front of the eye, from the side of the eye, from above, below, behind? Do we use multiple beams? Do we use a single beam? Things like that. When we go through the iterative process of trying all these different options, we have to have a reliable way of testing them against each other. Now, especially in the eye, but also other parts of the body, we can't actually measure the amount of radiation being received by the structure in the eye. It's too small. The measurement devices we have can't fit in there. So what we rely on are computer models and algorithms based on the density of tissue seen on scans to estimate how much radiation dose, if I point the radiation beam at a certain angle, at a certain energy, how much radiation dose will be received by each individual point in the body. So it is an estimation by an algorithm, a formula. And like with all other things technologic, our ability to calculate these things, our algorithms have been evolving over time and getting better and better. The possible beam arrangements that we have is also expanded the better our dose calculation algorithms are. The original dose calculation algorithms were not very reliable if you wanted to traverse the beam through very heterogeneous tissue. Now, in the eye socket, the most apparent example of that is the bone, sorry, this screen, the bone that you can see right here. Bone is much, much denser than the soft tissue. The old dose calculation algorithms that used to be used could not reliably guess how much radiation was being delivered if a beam had to pass through bone. So you were limited to beams coming only from the front of the eye. And so at centers that still use the old technology with a dedicated beam line, they can only use beams coming from the front of the eye. With the newest dose calculation algorithms that we have, we can now pass beams from any angle. So if there is a tumor that we think might be best served with beams coming from the side or from the back that go through the bone, we now have access to those beam angles. Dose conformality and penumbra. Those are technical terms that refer to how fast does the radiation dose disappear as you move away from the radiation beam. This is one thing where dedicated beam lines still have an advantage over the proton beam centers that are not dedicated beam lines like the one we have. Their penumbra, or the dose fall off from 100% to 0, or from 80% to 20%, depending on how you calculate it, is the smallest there is currently. It's about 1 to 2 millimeters, both on the sides and at the end. With prior non-dedicated proton beam lines using uniform scattering, the penumbra was closer to 3 to 4 millimeters on the side and the end. With the latest pencil beam scanning technology that we use at Fred Hutch now, we've been able to get the lateral penumbras on the sides equivalent to beam lines, about 1 to 2 millimeters. And the distal one now is down to about 2.5 to 3 millimeters. Still a little bit worse than dedicated beam lines, but hopefully in the future we'll get that even closer and maybe match. Then the ability to use the advanced dose calculation algorithms will really kind of shine through. Right now there's still some debate. Is a dedicated beam line better or worse than a non-dedicated beam line? The last thing is time of treatment. Some of you and some patients who were treated before may have received uniform scattering proton therapy, which takes 5 to 10 minutes to treat the tumor. The patient's eye is immobilized purely through asking the patient to look at a dot and not move their eyeball. And so there is some reliance, and it's not fair of us to ask them, but we have to, there's no other way to do it, is to ask them to focus on that dot for so long. With current technology and with dedicated beam lines, it takes only 1 or 2 minutes, so it's much faster. There's much less concern about there being some flickers of eye motion that can compromise the reliability of that treatment. Another advancement that we've done recently, we've just implemented this last year, is a software module, called Ray Ocular, made by RayStation or RaySearch. It allows us to use not just CT and MRI imaging, but also the image information that Dr. Stacey collects through the fundoscopic exam, where he's really in there in the eye. Right? MRIs are kind of secondhand. I'm relying on computer images to tell me where the tumor is, but Dr. Stacey really was right in there. It can help me delineate exactly where he thinks the borders of the tumor are, what he thinks the depths of the tumor are at different places along the base of the tumor. We can now use this software to better combine all this data to to figure out exactly where the tumor is. And this is just cutting down on any of the margin or guess factor that we've had to use before. All right, this will be a brief slide because I believe there might be other talks on this later. But other ways I'm excited about continued innovation with proton therapy lies not with the proton therapy itself, but with what other therapies we can add to proton therapy to make it even better. These 2 bullet points represent examples that I mentioned earlier. How can we move that red curve to the right? Are there therapies we can use to decrease the risk of complications for proton therapy? And there are. There's evidence and trials going on right now testing agents injected into the eye, like anti-VEGF agents, that have been shown potentially to reduce post-radiation complications. The second bullet point is how do we move that blue curve to the left? How can we enhance the effectiveness of the radiation therapy? What I think is most exciting is the potential to do this not just for the cancer in the eye, but potentially for any microscopic cells that might be hiding in the rest of the body, which is really the main concern long-term for survival of uveal melanoma. Can we combine radiation with, for example, immunotherapy? As some of you might know, in cutaneous or skin melanoma, immunotherapy has been hugely successful at transforming the prognosis for metastatic cutaneous melanoma patients. It has not quite had as much success in uveal melanoma, but there is evidence that it is still effective. There is a recently approved drug, an immunotherapy agent, that was the first to show an overall survival benefit in metastatic uveal melanoma. So we know there is still some potential to harness the immune system to help fight metastases from uveal melanoma. Research from a lot of places like Cornell show radiation is really good at helping recruit the immune system to help come fight cancers. Now, it's not usually good enough by itself. You usually have to add other adjuvant therapies to it to unlock the immune system, especially in a privileged location like the eye. But there's a lot of potential, I think, in the future to improve on treatments with this. I'm going to skip this real quick due to time. That's it. Thanks.
That was another excellent overview, and we'll entertain questions for maybe around 5-10 minutes. I'll ask the first one. Can you just give us a sense of how much coordination is happening behind the scenes between you and Dr. Stacey to develop all these plans and actually administer it?
Yeah, it's a lot of coordination, and it's one reason why I'm so thankful that Dr. Stacey is so easy to work with. There's a lot of coordination required, a lot of communication, and it's not easy. It's not easy to get 2 doctors who have busy clinics and being in the OR to be able to sit down and figure out each patient's plan, each patient's tumor delineation, making sure everything looks optimal. But we do it for every patient, and we do it as much as is needed. Yeah. Yeah.
Yeah, my question is, my melanoma has moved from my eye, which the proton took care of that, took care of the melanoma in my eye, but it's since traveled to my liver. Is there any chance of using proton to affect the liver?
Yep, great question. We don't have any data to suggest that helps yet, but it's a very good question that we're wondering too. In other cancers, that exact approach used to be discouraged. People used to say, well, once someone has metastatic breast cancer or prostate cancer, you don't need radiation or surgery anymore. The cancer has spread. Why treat those individual spots? It's just going to pop up somewhere else. It's different now. We have lots of studies in other cancers that have shown that using radiation to treat metastases in some situations is still beneficial. Right now, it's mostly being explored in lung cancers, prostate cancers, other cancers. But could it be true for uveal melanoma? Maybe. Liver-directed therapies is a topic of another talk later today. Could proton beam radiation or maybe even X-ray-based radiation be useful? Maybe, but we don't know that yet.
Online, there's a question that kind of piggybacks on that. I'm just wondering, the question is, what types of radiation can be used in recurrence of melanoma, other sites in the body. And since the liver is such an important organ for our patients, maybe you can talk about the potential and the challenges of delivering radiation externally to the liver metastases.
Yeah, it is something we do all the time for other cancer types. Our GI specialists do treat liver metastases as well as primary liver cancer with radiation often. There's also other treatments for liver metastases that are also done often. Transarterial chemoembolization, TACE, T-A-C-E, radiofrequency ablation, other liver-directed therapies you'll hear about. In other types of cancer that have spread to the liver, there is controversy over what the best treatments are. Similarly, in uveal melanoma, we don't know what the best treatments are for liver metastases, or if they help at all in melanoma. In other cancer types, we often have to have very close coordination and discussions with our IR colleagues, with our surgical colleagues, to decide if someone has a liver metastasis and we want to treat it. Do we surgically remove it? Do we treat it with one of the other techniques that the interventional radiologists do? Do we give it something called yttrium-90, which is a radiation technique used by our nuclear medicine folk? We're still figuring out all these questions. It's a really good question. We don't have the answers to those yet. All right. Oh, one more question over there. Two more? Yeah.
Hi, Dr. Chen. I was wondering about this slide that said there's immunotherapy with radiation that can be helpful. I wasn't sure about the timing.
Yeah,
maybe I spaced out and just didn't hear you say it, but does that suggest that you do immunotherapy like simultaneously with the radiation, or is it in response to metastasis after, however long after the radiation has been?
Yeah, good question. So let me clarify. That was a potential innovation for the future, currently not in standard use. If we extrapolate from other tumors like cutaneous melanoma, this has been established for. If you combine radiation of a single metastasis from cutaneous melanoma with immunotherapy, it can potentially have effects on cancer throughout the whole body, presumably through helping recruit the immune system to fight the cancer elsewhere. So even places where you never aim the radiation at will regress following a combination of radiation and immunotherapy. Could that be useful in uveal melanoma? It's a question that we want to investigate. Right now, there is no current use of it. If it does prove to be useful, it could prove to be useful in both of those settings. It could be that after someone already has metastasis, if we use radiation or other therapies like liver-directed therapies and combine it with immunotherapy, and maybe that's a better outcome. It also could be really interesting to investigate if we give primary treatment to the cancer in the eye before there's metastases, combine that with immunotherapy, maybe that'll reduce the risk that metastases will occur, maybe. These are all open questions.
There are many parts of the country where radiation therapy isn't available for 1,000 miles away. How are those patients handled?
That's a good question. Yeah, so proton centers themselves are relatively rare. Centers that do plaque brachytherapy also coexist with those. So if you combine them, there's a little bit more. But still, there's only about 40 proton centers in the whole country. Many of them do not treat ocular melanoma. And so it is a limited resource. I don't personally know the answer to your question. I don't know what happens to a patient who sees a doctor who doesn't have access to these things. I would imagine many of them get referred to the closest center of expertise. As Dr. Stacey mentioned, a lot of patients in the Pacific Northwest do get referred to us. Might there be patients who never get referred and maybe go straight to enucleation? It's possible. I'm not sure, but hopefully those patients are all being referred to a center that does have access to those technologies.
I might suggest there are several patient groups. I know I was on the board of one for 5 years, and they can help provide funding for travel to centers of excellence. in metropolitan areas.
That's great. Thank you.
Hi. I have a question about sort of the collateral damage of proton beam therapy to the optic nerve and the macula. Are there data being collected that correlate the extent of damage, I guess, or inclusion of the optic nerve, for example, in the treatment to loss, complete loss or degradation of vision in the eye? So if, you know, me personally, I had I think about 60% of my optic nerve was in the direct line of fire. Just curious if there's studies out there collecting that type of data.
Yeah, we rely right now on a lot of data from non-proton therapy of uveal melanoma treatments. So radiation therapy that might encounter the eye for other types of cancers like brain cancers and things like that. There's much more extensive literature establishing the relative risk of optic nerve damage from those treatments. And we partially rely on those. We ourselves and other centers are collecting data specific to uveal melanoma to see if we can better optimize exactly how much radiation dose an optic nerve can tolerate. Now, these are aggregate estimations over populations, right? Because there are patients who I can give more radiation dose to their optic nerve and they don't suffer any damage, whereas the same patient or a different patient who gets even less radiation dose might have even more damage. So we are trying to come up with thresholds that we use during planning that best serve the populations we treat. A pipe dream would be to, at some point in the future, probably not in my lifetime, use individual patient-specific genetic information to tailor the radiation for your optic nerve, but that is a long ways off, I think.
Sorry, Dr. Chen, I was going to save this for afterwards, but I want to piggyback on the last question. I was diagnosed in 2013 and had proton beam at UC Davis, and it is the oldest proton beam in the United States used for medical purposes.
Okay.
And I only was radiated 30 seconds or more for 4 days. And on the 5th day, which was planned, we showed up and the nurse said, "Oh no, sir, you've had plenty enough radiation, you're done." And I didn't know how to take that. Well, 9 to 10 years later, my dentist went ballistic on me because I lost 2 teeth here, 1 tooth here, 1 tooth here, radiation coming in here. My sinus is blocked. I've lost hearing in my left ear. And so I'm curious too, are there reports or are there statistics on life expectancy maybe for one thing?
Sorry, just to repeat your question, I wasn't sure. The question was about life expectancy or the risk of damage to those structures from radiation?
Well, I know I have damage. So I'm curious if there are studies. Yes, long term. And I understand my case is different because Davis was so old and wasn't designed for eyes. But many, many patients have gone to Davis.
Right. Yep.
I wish I could have gone to one of the newer proton beam machines, but in 2013, there weren't that many.
Yeah, I'm going to try to answer that question carefully. The risk, there is a long-term risk of damage, as we talked about, to any structure that receives radiation exposure. Our job is to limit the number and amount of structures that get exposed to that radiation and the dose that they receive, which correlates with the risk. The amount of damage that you received was to a large area outside of just your orbit, which I'm sorry to hear, it's very unfortunate. I would say that these days, those kinds of risks are very rare, if not close to zero with current technology. We're glad that technology has moved on to the point where those are less rare, and I'm sorry that they happened to you.
Yeah, it's actually relevant to that question. As a younger patient, definitely the concerns of like, okay, I might have the effects of this radiation for decades and longer. And I know that I think for a lot of people in like the lay audience, like radiation, we think of as causing cancer, why do these therapies like really not seem to be causing cancer? Like when I've looked it up, there's, you know, no real reports of like secondary cancers being caused by radiation treatment. Like, why is that?
So it does. So radiation treatment that we use, proton, plaque, all of it, as sophisticated as it becomes, is still at its essence radiation exposure. The same as the radiation hitting us now from space and from the ground, concrete all has radiation. We are exposed to radiation all our lives. For most patients, that's what causes cancer. Radiation treatment is no different, although it's much more focused. It's also much more high energy. Radiation treatment does increase a patient's risk for developing another cancer in their life. But it's all relative to how much radiation, the volume of body exposed to radiation, and the amount of time that you live after the radiation. The amount of your body exposed to radiation with proton therapy for ocular melanoma is vanishingly small relative, for example, to the amount of your body exposed to radiation with breast radiation or prostate radiation. With those cancers, so I treat prostate cancer as well with proton therapy, we estimate that a prostate cancer patient who gets treatment with proton therapy, if they live 20 years after their radiation exposure, do have an increased risk of a secondary malignancy of about 0.5%. So for a uveal melanoma patient, it's going to be a fraction of that. So it's not zero, but it's so hard to measure that many people approximate it as zero. But the younger you are, the greater that risk is going to be, because that risk continues to increase over time. And so the younger the patient, the higher the risk is going to be. Okay, thanks everybody.
Well, thank you. All right, so with this, we'll conclude our first session. We are running a little bit behind time, but that is all because of excellent.
Here we go. So thank you so much for being here. We're going to move to our next session. And I want to introduce our next speaker, who's a dear friend, Prithvi Mruthyunjaya. Dr. Mruthyunjaya is an ocular oncologist and a retina surgeon at Stanford. He grew up in upstate New York and went to medical school in upstate New York. And then he went to Duke. I believe he is a Dookie through and through. He went to Duke for medical school. For residency, and then also a fellowship in retina surgery. He then went to Moorfields Eye Hospital in London to do a fellowship in ocular oncology. And we have a kinship there. That's where I did my fellowship. He did his fellowship a little bit before me, and I was the next American to do the fellowship. And I heard Prithvi's name almost every day. I could never live up to the standard that Prithvi set as the last American fellow in London. Prithvi is a friend and a colleague, but also a mentor. He's a genuine nice man, and ever since I started the program here, he's the type of person who helps out whenever I have difficult situations. If I had a difficult case, and maybe you were one of these difficult cases, he's the type of person that I call and I say, hey, Dr. M, what would you do in this situation? And he's always so very helpful. He's very well respected and very well published. I learned this as I was looking through his information today. One of the ways we understand how much research somebody does is we look at something called the I-10 factor, or how many papers somebody has published that have at least 10 other papers referencing them. Once you get a paper that has 10 papers referencing you, it's a pretty important paper. So Dr. M has more than 100 papers that have been cited more than 10 times, which is kind of an incredible statistic. Did you know that? Did you know you were over 100? I don't believe it. So he's going to talk to us today about some prognostic testing, and I'm so grateful that he's here. Thank you, Dr. M.
Good morning, everybody. Thank you so much for letting me be a part of this wonderful initiative that really brings together the key stakeholders in the care of our patients. Most importantly, our patients, but also the doctors and the researchers who are trying to come forth together to make a difference. And I think the ocular melanoma space is really unique because it is a small community, as Andrew pointed out, and everyone has like the same mission goals in mind. And I think that kind of dedicated energy really takes the whole field forward. So thank you so much for this invitation to be here today. Didn't have to travel far, and it was really an honor to join. Here are my disclosures, none of which are pertinent. But I will like to say a few words about Dr. Stacey. So it is true, I first met Andrew maybe a little more than a decade ago when he was doing what I did maybe about 50 years before when I did my fellowship. He's like 15, I think. I'm not sure. But it wasn't easy to decide to leave the United States to get training in another country, and we both chose that fellowship because it offered us a very unique perspective on the care of patients and a different healthcare system. We worked with proton beams and we worked with radiation surgery, and the first radiation surgeries that were ever done for eye melanoma were in London. So we really were part of a long heritage of taking care of patients in innovative ways. I don't know if you know this, but Andrew himself, he'll never admit how amazing he is, but he is a global leader in eye cancer epidemiology. So he tries to figure out what the root cause is of what causes cancer in adults and in children. The statistical genius and brainchild. So we all use him as a way to figure out the best way to answer complicated questions. So he's really developed a wonderful program here, and I can tell that there's a lot of love coming from all of you to this guy up here. So thank you, Andrew, for being who you are. So I'm going to ask you to guess. These are 3 patients that all have ocular melanoma. You saw all the pictures today. And as we all know that there's a risk that these tumors can find their ways to other parts of the eye. Can any of you look at these pictures and guess which patient might develop a tumor that leaves the eye and goes to another part of the body? Is it that small one on the far left that looks a little white? Is it the medium-sized one here on the right that looks, dangerous, or is it the bigger one in the middle? I could ask this question to a room full of ocular melanoma specialists and ask them with all of their fancy knowledge and all this stuff, can you tell me which one's most likely to metastasize? And guess what? No one will get it right. Everyone will have a reason why, but just by looking at it, we can't always tell. We can maybe kind of guess if it's really, really big, but not all of them are that big, and they all have that risk. So what we're going to talk about today is this concept of prognostic testing. Why do we do it? Why is it important? What are the methods that we use in uveal melanoma? What is the recent collaborative work that's being done to try to get some of these answers? We'll also talk about how people need to read or interpret some of the genetic testing that's come about. And then also some of our work with maybe the next steps that we can take genetic testing going forward. So if we step back away from just the eye, why is prognostic testing important? Why does it matter in cancer? Well, it tries to predict the risk of cancer spreading, or let's just be upfront, metastasis. I think we all are aware that in uveal melanoma, the big issue is that risk of metastasis, and what do we do about it? It might help to guide personalized treatment and monitoring of a particular patient. So kind of customized or precision medicine for how often you have to go get that body scan done. How often do you need to consider clinical trials or other treatments? And it might help to avoid then unnecessary tests. What if you don't need to get an MRI every 4 months? Maybe you could do it once a year. That's a big load off of your mind, and it helps to open spaces for other people to get their scans done, as long as it's done in a safe way. And then more importantly, it's trying to inform decisions that can allow us to be more personalized in our care of our patients. And I think that's why we want to do prognostic testing. And what does the term prognosis really mean in uveal melanoma? I think what we like to think of it is that it's a potential for a particular patient's melanoma to cause a problem. But that's not like really accurate. What we're really trying to do is to define prognosis as the likely course of a particular medical condition. So it's the course of the eye, it's the course of the tumor, it's the risk that the patient might ultimately develop metastasis, or the risk of whether the melanoma and the outcome could lead to their mortality. So it's really important to kind of think about why we use that term of prognosis. So why is it important in uveal melanoma? Because we're dealing with a tumor that we know that might remain localized to the eye, but also has a high risk of spreading to other parts of the body. And we know that we worry about the liver and other vital organs. And we know that in some older studies that about 50% of patients might develop that metastatic risk. We think that number is kind of high and maybe due to some prior older data, but we still kind of keep that bar where it is because we do want to make sure that we're not underestimating the risk overall. And the goal is that early risk prediction may allow personalized follow-up as we go, and hopefully, and this is the big hope, to be able to guide patients into clinical trials, and those clinical trials are the ones that are going to make the difference in the long-term outcome and survival in our patients. So there's a lot of ways that you can try to estimate the risk of metastasis or development of tumors outside of the eye in uveal melanoma. The first is just clinical features. So we can look at a picture, we can look at inside an eye and say that it's a certain size, it's a certain shape, it's a certain location. And those clinical features, you might be able to then try to estimate whether those could be predictive of the risk for that patient. The second is histopathology. That means in those cases that you either had to remove the eye and then can really look at each individual section of an eyeball to see are there features that you see within the tumor that then you could correlate to long-term outcomes. So that would require either taking a large sample of the tumor or removing the eye. So you haven't saved the eye then, but you get that information. What we're going to focus on are some of the newer techniques that we can use the information within each individual cell to give us more information about the long-term effect on a patient. So one are called chromosomes. So alterations in the number and the kind of stability of those chromosomes can be helpful. And then kind of the newest way that we try to predict risk is what we call gene expression profiling, or GEP. And then the even newer version of that is a risk modifier that we call PRAME. So we'll kind of hit on most of these newer techniques, but let's just step back a little bit and talk about how cancer cells and cells in general take information and use that information to control how they work. So within each of us, we have our genetic code. That's the DNA that sits inside each and every one of our cells. That's the blueprint to provide the body and each cell the steps to make all of the things it needs to kind of work and function and reproduce going forward. So the DNA then converts itself into a signal that we call RNA. So RNA is the building blocks of proteins, and proteins are it's the signal that helps us to make the proteins, and it says how those proteins should look, and that defines how they're going to work. The proteins then might be altered, and that alteration in proteins is what causes what Dr. Stacey was talking about, the cells to grow abnormally. So it's kind of a multi-step process. It's not just one event, it's multiple events, and you need different pieces of genetic information to make that happen. So every cell in our body has this genetic material called DNA. The genes in the DNA are read by the cells, and they make this other material called RNA, which tells the cells what to do. If the tumor's genetic activity is off kilter, then that means that it's going to start to make these abnormal tumors. And if you think of it kind of in a bigger way, when we're talking about prognosis, we have the cell that makes this RNA, and it expresses the impact of all of these collections of genetic material called genes. And it's how much those genes are expressed. In my body, I could express it to this level. Someone else could express it to a lower level. And that aggregate of that expression is what defines how that cell and that cancer cell is going to work. So in the tumor, that gene tumor activity affects how the cancer grows, and that might impact how the cancer might want to spread. If we follow those patients over time, and if they have a certain alteration in their gene expression, and we find that having one expression higher leads to patients maybe living longer, or an expression being lower and the patient not living as long, that might give us a sense of whether that expression itself can be a trigger or a clue on the long-term prognosis for the patient. So that prognosis can differ based on the gene expression. We wrote a paper on this to kind of look at all the different ways that we can look at genetic or molecular prognostic tests in uveal melanoma. And there's a lot of different ways that you can get a lot of information. And I'm going to be clear, there's not one perfect way to do it. There's a lot of ways to get information, and all of these have been well studied. You can look at the number of copies of DNA that you might have in a patient. We all have 46 sets of these, 23 sets of these chromosomes. So sometimes you can have a little higher number or a lower number. You may be missing one or missing part of one. We can use other techniques that allow us to amplify very small samples to be able to give us a lot of rich information. And then newer techniques that take little bits and pieces of genetic information and try to put all that together. What's really made the difference is a lot of basic laboratory research in uveal melanoma that really puts us in a nice little shoebox in cancer itself. One of the unique aspects of uveal melanoma, you might say one of the bad aspects, is that there are a limited number of mutations or alterations in the genetic code of a uveal melanoma cancer cell compared to some other types of cancers. Some cancers, like say lung cancer, have multiple different mutations that have been identified. In uveal melanoma, there are relatively few. That's a good thing, because that means that we can focus our energies on treatments and targets on not 100 different sources that we have to hit, but maybe a fewer. However, it also means that there are fewer number of targets, right? So we have to be able to find those therapies that make sense. But there are two kind of key separating points here. One is what we call initiating events. And this is all work through the lab of Dr. Bill Harbour, who's now in Texas. So this cluster 1 or initiating events are mutations that take a normal melanocyte, just a cell that Dr. Stacey pointed out is in the back part of the eye, and triggers it to do something a little bit abnormal, start to grow in a lump. So that could leave the Dr. Stacey nevus that's on his forehead, and it could be a bigger nevus, or it could be the start of a melanoma. So once you kind of start the ball rolling, then all those cells kind of keep multiplying and you get those mutations. What is also unique, though, is that there's a second event that has to happen. Lightning has to strike twice. That second event is what helps to define some of our risks of high risk for spread or metastasis or lower risk. So there are two mutations. This is SF3B1 or EIF1AX, which are both what we would consider a lower metastatic risk mutation. The higher metastatic risk mutation is BAP1, so a loss in this one gene expression called BAP1. So what I'm trying to say here is that there's an event that has to happen that starts that cell moving towards clumping together and becoming a tumor. There's a second event that has to happen that then tries to determine what would be the long-term event. So all of these are potential points along the way that we could either try to find ways to intervene or to try to target. So knowing that is important, because now we've taken all of these genes and all of these proteins and now kind of focused our attentions on how to detect some of these changes. So when I'm talking about a prognostic test, like you don't just pull one out and say, this is a prognostic test and you should use it and everyone should trust it. There's a process that goes, and that gets to some of the data we'll talk about today. So you have to usually get a sample of the tumor because the tumor cell is what you're looking for to see what's abnormal about the cell. And these are studied in great detail, and we try to identify something that looks abnormal that makes sense biologically to be able to target. The test is performed to identify it. You want the test to be easy to do, not so technically difficult that it only has to be done in one place, that others can replicate it, and it's affordable and reproducible. And then the patient needs to be followed, and you're following that patient for an event. That event could be the tumor reoccurring. The event could be having to remove the eye. The event could be developing metastasis. The event could be death. The event could be not dying. The event could be the patient surviving for a certain period of time. So you can define that event, but you have to follow the patient to see if they had this abnormal marker, and then something happens or doesn't happen, and biologically doesn't make sense that that marker helped to make the prediction. Now, you could go wrong with it. You could say, well, if I have, spiked red hair and I lived for 5 years after that diagnosis of uveal melanoma, it must mean that if I had spiked red hair, that protects me from dying from uveal melanoma. Doesn't make sense. And I don't have spiked red hair. So, it can't use that as a way to go. But it has to be something biologic within the tumor. And that goes back to that research. And then people like Dr. Stacey come in, where he's going to be looking at that analysis and then trying to find the statistical answer as to why it makes sense. Because then it comes down to the science. Does the science make sense? And do the statistics verify this? Is there truly a greater risk? Are there confounding factors that make that risk kind of make sense, but not true? And then we talk about these things called survival curves, or we take a population of patients and we follow them over time for where they have that specific event that we define. And if we can do that, we can then statistically look at this outcome to see, does it make sense? Is it better than what we've compared to before? And that helps to move the field forward. So just to say that this test is verified isn't something that can happen quickly. Usually it takes about 5 years at least of waiting to see how patients go through their lives and their testing otherwise. So all of these prognostic tests really take a lot of work to get to that point. So you can't just come up with a new one tomorrow and use it. You can use it, but you have to verify it, which means the patient needs to be followed for a long period of time. So the two main areas that we as ocular oncologists and you as patients may have heard about genetic testing come from two kind of different techniques. One is called chromosomal testing. This checks for chromosomal abnormalities that are linked to high metastatic risks in our patients. So one is called monosomy 3. So you lose one of the copies of this chromosome 3. There are a lot of different methods for it to be used. It's a little hard to get enough cells in a biopsy to always be able to look at all of these chromosomes. So it often takes a lot of samples, some very small tumors within the eye. So sometimes the technical success rate may not be as good. Chromosomal testing, though, the most common ones we're looking for is the loss of chromosome 3, but there can also be these strange mutations where there's extra pieces of chromosomes that are brought together. So this kind of creates too much information, and then the cell doesn't know what to do with it, and it creates the cancer cells. But it is one of the earlier and well-established markers for high metastatic risk if you have this monosomy 3. And it correlates with one of those secondary mutations we talked about, which is BAP1. So it then makes sense. Loss of chromosome 3 and correlating with the BAP1 mutation really kind of makes a lot of sense with it. If you don't have monosomy 3, the outcomes are good. And there's a company called Impact Genetics that does offer a verified test for Uveal Melanoma Prognosis. They have kind of put this together into a nice package for patients that gives them a combination of their genetic information, which is done by several different methods. They kind of add in demographic features about other populations of patients with uveal melanomas, and then it tries to give you a personalized result. So this is the result that you would get from Impact Genetics. It would tell you whether in the key chromosomes, so 3 is monosomy, chromosome 8, you have multiple gains, and other ones, they were or were not done. And then it gives you a survivorship prediction. So what it'll say is that taking all of this information that they have in their database, what is the predicted survival at 3, 5, and 10 years for this particular patient with this particular genetic abnormality? And what's the risk of developing metastasis? And what's the risk of having mortality from any other cause? So it really tries to put it together as a risk predictor. Remember, just because the numbers say that, that there's a risk, it doesn't mean that that applies to everybody. This is taking a large population and it can help guide, but by no means is anything absolute. So that's important to know. The second main test, and we'll spend a little time on this, is gene expression profiling. So this measures the RNA activity or expression within these tumor cells. RNA, as we just mentioned, is the message that the genetic code within us makes to instruct the body to make proteins that help to kind of regulate how the cells work, either in a good way or in a bad way. There are found again through Dr. Harbour's work, 15 specific genes and the expression of those genes, so just 15, that classifies tumors into a low risk, which is called class 1, or a high risk, class 2 for metastatic disease. You take all of this information that you can collect, but it just takes 15 of these genes to be expressed in a certain pattern that helps us to differentiate. And it's a really amazing test because it's technically very successful. We don't need to take a large sample within a tumor, just really small samples. And multiple studies have shown that it's probably more accurate than the chromosomal testing. Not to say that chromosomal testing is inaccurate. It's just with every iteration of technology, we're probably better at what we do than what we did in the past. So the system allows you to classify tumors, and it's further refined by another expression called PRAME status, which we'll talk about. And the advantages of theoretically of gene expression profile testing is that it really offers us a kind of a composite of what's happening within the tumor, like the environment of the tumor itself is being sampled, because it's these multiple gene expressions, multiple potential proteins that are being made. So it may be more than just saying you have, one less, roadmap, which is the chromosome. You have what's happening with that abnormal roadmap situation. Tumors can have different components of their tumors showing different rates of growth or other changes. This kind of averages all that together, and it can be done very successfully. So when we talk about getting genetic material from tumors, like how do we actually do that, right? We're making it sound like, oh, we just take a sample of your eye. Like that's not an easy thing to do. The eye is actually really rather small. So we talk about doing tumor biopsies. So depending where the tumor is located, we alter our technique. So I'm going to show you some stuff. Hold your breakfast in. We're going to show you some eye surgeries on patients with ocular melanoma. So here's a patient that has a elevated mass inside the eye. So what we're doing here is doing surgery on the eye where we're going to safely make a little pocket to then use a needle to go into the tumor. This patient's going to have radiation surgery right at the same surgery. This is just really a needle that's hooked up to a syringe. And so we bring that needle right up to the outside of the tumor. We go in maybe about 1 millimeter or 2 into the eye. My assistant is kind of just pulling on the syringe to give us some suction. So we're kind of vacuum cleaning that tumor tissue in. Doesn't really cause any bleeding. You can see this dark stuff in the needle. Those are the tumor cells. So we don't need a lot of tumor cells, but that amount, that's a lot of cells. We clean up around the eye, we put a little suture to be safe. And then at that time, the radiation disc is going to be placed on the eye for brachytherapy, or they could go to proton therapy after that as well. Sometimes the tumors are in the very back part of the eye, so it's not so easily accessible from the outside. We have to go into the middle of the eye to get that tumor. So here we're using our surgical microscope. We make little holes. The patient's not feeling any of this, by the way. Hurts me more than it hurts them. And so we actually take the needle, and then by watching directly, we're going into the tumor itself. We're again kind of pulling and aspirating with the syringe, so those fine tumor cells come in. Once we have what we need, we just come out with that needle, and there's sometimes a little bit of bleeding in that location, but that allows us to, again, we put a little pressure, and that allows us to obtain enough tissue to do all of our testing. So it doesn't take much tissue, but it's very delicate to be able to do that. So again, Dr. Stacey is an expert at being able to get these small tissue biopsies. We also looked at all of the data on all the different types of testing and techniques. And so it doesn't matter whose hands you're in, if they are experienced with this, the data is good. You're going to get some answers in the vast majority of patients. And I think that's reassuring that you're going to go through this biopsy technique and it's not going to create more trouble for the patients. It's actually going to be helpful. So we all love to work together in these rare diseases. And there's a group of us we've come together called the Collaborative Ocular Oncology Group, or COOG. Dr. Stacey's a valued member of this organization as well. And so this is a group where we wanted to be an evidence-based collaboration of ocular oncologists and medical oncologists. We can kind of initiate our own studies, and what we're trying to do is to come up with better therapies and better tests for patients with ocular melanoma. We have multiple sites across Canada and the United States, and the first studies were all based on laboratory work, again by Dr. Bill Harbour, who's one of our good friends, that looked at the gene expression profile in uveal melanomas, and that led to more discovery of other mutations that we were talking about earlier. And then finally, a new study that we'll talk about that was just released that gives us even more information. So the first study that we worked on now over 10 years ago was the first report, which is a validation of this prognostic assay. So this looked at 15 genes and tried to classify patients as high risk or low risk. Almost 450 plus patients from across the country were part of this study in 12 centers. And then we compared what was at that time standard of care, which was the chromosome 3 analysis, with the size of the tumor. And what we found is that by taking this very special test, this gene expression profile, and we take all of the patients, we found that the computer could separate them into two groups. We call that class 1 and class 2. And interestingly, if we followed those patients over time, we found that the class 1 patients had very few evidence of developing metastasis or dying from their melanoma, whereas the class 2 patients had a higher risk. And this separation between class 1 and class 2 in all of cancer is probably one of the most powerful separators, telling us that this is very advanced information that we're providing our patients that maybe other cancers don't have that information for. So what we found is that it was highly accurate. It reproduced this prognostic tool, technically very successful, and it showed that the importance of now using gene expression profile testing as an important method to determine prognosis. The result that folks have gotten, maybe some of you have received this result as well, kind of defines the class of the patient. So it'll say either class 1A, class 1B, or class 2. It'll give you a value, which is kind of like a quality check on the data, and then published information regarding the percent of patients that will not have metastasis at 3 and 5 years. So the class 1A patients had a very low risk for metastasis. The class 2 patients had a higher risk for metastasis. But this now gave us that information to be able to make that distinction, whereas before we wouldn't know that. PRAME is another marker that's been developed as well. It measures the expression of a gene that's linked to many cancers being more or less aggressive. So you can take a patient who's either class 1 or class 2 and then figure out their PRAME status, and that might help to define whether they are a higher than class 1 that we knew before or higher than class 2. So it kind of is a risk modifier. And it creates now 4 separate groups. Before we had 3, class 1A, class 1B, and class 2. Now we combine those 2 into a paper that was just released last year in the Journal of Clinical Oncology, where we collaborated again to try to figure out this long-term information. So the second COOG report, it was trying to validate the integrated prognostic information, not just one test, 2 tests together taken on that same biopsy specimen that I showed you. So this time we had over 1,500 patients from 26 centers across the United States, and we followed them for now over 5 years. And we compared that with everything else that we knew, the size, the chromosomes, everything, and to see, is this actually a better predictive manner? So these patients underwent the biopsy, and then we have a special test that looks at both the gene expression and the PRAME. And this is what we found out. Before we had 1A, 1B, and 2. It found that with this larger group of patients that represented a more common presentations of how patients show up, if we looked at patients, the 1A and 1B didn't really make sense anymore. So we found the survival for all class 1 patients together and the survival of all the class 2 patients together. So instead of having 3 different groups, it was 2 different groups. And then we looked at the PRAME expression, which is that other modifier, and we found that it wasn't as big of a difference between the PRAME negative and PRAME positive patients compared to the class 1 and class 2. So the class is still the most important. So if you're trying to figure out risk, it's either the class is what's kind of driving it. PRAME modifies that risk. So it's more information. And putting it together, we now develop a 4-model system. So you're either class 1 PRAME negative, which has the lowest risk for metastasis, class 1 PRAME positive, which isn't as strong of a risk modifier. This is the class 2 PRAME negative and class 2 PRAME positive. So now we're really kind of coming down to very, very customized information regarding an individual tumor. And all of this provides our medical oncologists really important information. So the COOG-1, which was now about 10 years ago, COOG-2, so we enrolled different numbers of patients, but the COOG-2 is probably more representative of the tumors that we see every day. And it included more smaller tumors. So COOG-1 had very large tumors. These were smaller tumors. So both of these studies use the 15 gene expression profile. And then the COOG-2 now incorporated PRAME. So we have way more information than we did before. What about chromosomes? What about clinical size, things that we used to use before? So the COOG-1 told us that the GEP was superior to chromosome testing. And COOG-2 found that the GEP and PRAME system was better than the sizes alone. So we're using really technical information that takes away some of the guesswork that we had in that very first slide when I said, if you looked at it, could you tell? Now we can really tell, and I think that's important. And COOG-2, in a large scale, confirmed these advanced genetic techniques. It showed that PRAME actually adds information to our patients' prognostic data, and it's now changed the class 1A, 1B, and makes it a little simpler and calls everything class 1. So that's something to kind of keep in mind. And then this was now given what we call level 1 evidence, which we'll talk about. So how do we read the report? So Castle Biosciences, which is the company that we all send this test to, will give you a result, so class 1. And then there's data that tells us the percentage of patients that will be metastasis-free at 3 and 5 years, so that data is shown. And then we'll do a second test that will tell you whether you're PRAME positive or PRAME negative. And then putting those data together, the class and the PRAME, we have a more updated information about the risk of not having metastasis at 3 and 5 years. So this is giving our medical oncologists even more information. This is such high level data that now the National Comprehensive Cancer Network that advises doctors on how to manage patients with cancer with high level evidence now can use class and PRAME to define patients at low, medium, or high risk for metastasis. What that means is when you then get your tests for your body scans and such will differ based on your risk. So patients that are at higher risk will get more frequent scans. Patients at lower risk will get less frequent scans. So I'll end here just talking about maybe some of the future directions that we're taking with prognostic testing. So when we go in, and I showed you those pictures, we go into the eye and we stick a needle into the tumor. But when we go into the eye, we're going through a lot of space that's inside the eyeball itself. And that space is filled with fluids. So our thought was if inside the tumor, way in the back of the eye, if there are, we know that there's DNA and RNA and it makes proteins. Some of those proteins stay inside the cells, but some of them leak out of the cells and they may go through the choroid and into the gel of the eye called the vitreous that takes up the middle portion of the eye. Some of those proteins can even go to the front of the eye called the aqueous. That's the part of the eye in front of the colored part of all of our eyes. It's another fluid compartment in the eye. And maybe some of those then go into the blood. So this gets to the concept of liquid biopsies versus tissue biopsies. So when I stick a needle into that tumor, that's a tissue biopsy. I'm actually going in and taking cells and analyzing them. But I go to the doctor and they tell me to, draw some blood, or they tell me to pee into a cup. And those are examples of liquids in our body that give information. So one of the trends in cancer therapy is using liquid biopsies to get answers. So we then looked at our patients that we're doing our biopsies on and sampling the fluid that we have to go through. And what we found is that by looking at just a teardrop worth of fluid from inside the eye, it can actually predict the gene expression and the PRAME expression, which is something that you'd have to stick the needle all the way into the tumor. So the tumors are leaking proteins and we're kind of not even looking at them because they're just floating around in fluid. But if we can capture those proteins and analyze them, it may give us information that before may not have been achievable unless you did a biopsy. What we also found is that we can decide which types of drugs that are currently being used for other cancers may actually be targeted by those proteins that are already being leaked by the tumor. So that may allow us to think of new therapies that could be customized for each individual patient. Now that's a lot of what we do with these biopsies are done in the operating room. But you know what? I could actually, in the office, stick a needle in your eye, doesn't hurt, and just like that, take fluid from the front of the eye. And we take just a little bit of fluid and we can analyze that. And we recently looked at this with a new technique that we call tempo. And what tempo means, and I'll try to break it down for you, is that we take a little bit of fluid from the front of the eye. We used a new system to count the number of proteins, and usually we'd get 100, 1,000, maybe 1,500. Now we can get close to 6,000 proteins from literally a teardrop of fluid that's in all of our eyes. That's way more than that's ever been captured from the eye before. And then if we look at where those cells in the eye are located that make those proteins and put it all together with some really powerful computing, it ends up with this basic cartoon. So if the front of the eye has red proteins and green proteins and yellow proteins that are important, we can figure out which cells in the back of the eye those proteins leaked out of, came to the front of the eye for, that we were able to collect in the clinic. So we can target or learn about what's happening way inside the eye and maybe even inside the tumor just by taking a little bit of fluid from the front. So we then applied this to patients with ocular melanoma. So we took the direct sample and we took the fluid. And what we basically did was applied this tempo technology. And what we found is that of all those proteins in the front of the eye, there were about 240 that were specifically from the tumor. So the tumor is leaking proteins that are unique to the tumor, that are unique to the inflammatory cells around the tumor. And that signal is coming to the front of the eye. So we can try to capture that. So what we did is we took the most powerful proteins that we could find and put it all together, and we can now distinguish an eye that has a melanoma from an eye that doesn't have a melanoma just by taking a little bit of fluid. We then said, well, what about this gene expression business? Can we decipher that from the fluid in the front of the eye like we did from the fluid in the back of the eye? And it was able to distinguish it almost perfectly. So we find now that these proteins may help us with prognostic testing in the clinic itself without having to, at least for until we can prove it with larger patient samples, without having to go to the operating room. And maybe more importantly, we can do this repetitively and follow patients over time to see how that risk can change. So I'll end by saying that prognostic testing is something that I think should be offered to patients now because the technology has been validated and I think it's quite accurate. Sometimes in the past that wasn't available, and it's really hard because patients have been treated and they want to know what their result is. But then we rely on previous methods, which can still be helpful. But newer patients that are diagnosed are always offered that opportunity. These results guide both the patient and kind of, their long-term expectations, but also the clinicians in trying to time metastatic surveillance or newer treatments, which we'll hear about later. And currently, the GEP and PRAME are really the most advanced tests that are currently available, and we're fortunate to be able to offer that. Let me just end by saying class 1 versus class 2. I think some of you have heard these terms. Class 1, lower risk, class 2, higher risk. No one wants to be class 2, right? Like no one wants to be class 2, and I get that. But what knowing that distinction tells us is that it gives us an opportunity. We can look at those patients that are class 2 much more closely. We hold them in much closer monitoring and for follow-up. And if we are thinking about new therapies, that could be risky, right? They could have other side effects, but new treatments. We don't want to put the patients that are class 1 necessarily in those high-risk treatments because they may not ever really need it. But we want to find those class 2 patients and then offer those treatments to them because they're the ones that may have the most benefit, and we may learn the most about a therapy in those high-risk patients. So we talked about a lot of things today, and I think I've gone way over time, but I wanted to thank my team for all of their work and for Andrew for the kind invitation. Thank you.
That was really very cool. I'm sure there'll be questions in the audience. There's a couple online with a similar theme, so I'm going to batch them. For patients where, for whatever reason, no FNA was performed, and I think this came up 2 years ago, and Andrew spoke to it then, what can we tell them now? They've already had treatment. Is there anything we can offer them that might give us a chance to learn more about their risk?
So we still know about risk because we know the clinical features of their tumor. We know the size, we know the location, and other clinical features that still have been validated to provide information about risk and prognosis. So it's not that you don't have that information. And we're talking about going from Google to ChatGPT, right? You're still getting a lot of information by asking a question to Google that can define what needs to be done. It's just with every iteration of technology, it just might be a little bit more accurate than before. But it's true that some of the tests that we have now are not validated on patients who have already been treated. So we can't go back sometimes to do it, but there's still information that your doctor will already have that can guide you.
So you were talking about gene expression profiling, but so then I think previously, Elaine, it was more of a genetic test to look for particular markers. And so that was more looking for somatic or looking for changes in the tumor itself.
Yeah.
And so in terms of that, how much information from that is a good prognosticator for, in relationship as opposed to gene expression profiling?
Yeah. So probably gene expression profiling, and we've seen this, is more accurate in determining risk. But some of those other changes that we're seeing looking, within a tumor and looking at various expressions, it's kind of the precursor to what gene expression profiling is currently doing. So there's been a lot of work looking at different stains within tumor cells and to see what's present or not, and they've all kind of done the same type of thing, which is to find these alterations, follow patients, and see if it does help to prognosticate. So there's still plenty of information that's been obtained from other testing methods. It's just that the newer ones have been validated to be more accurate. Yes, sir.
Hi, thank you for all the information. I'm trying to absorb it as best I can for the question. In the case of the prognostic testing of tissue, are the same methods used for the biopsies that you showed as are used on the tissue after enucleation?
Really good question. So short answer is yes. We can do it in different ways, though. So when the eye is removed at the time of surgery, we can take a fresh sample and that can get sent. If the sample isn't obtained, then they can take a slide of the enucleated eye and they can still send that in. Again, accuracy may be just a little bit different, but it still is validated on after enucleation specimens too. So it can be done.
And further to that, if a person was classified 1B, as my wife was, can that old information help provide the PRAME status?
Good question. Short answer is yes. It depends on how long ago it was and whether the company can rerun it. They save samples for X number of years. So they should be able to rerun within the last 5 years for certain. If it's like 10 years, then the quality of the gene expression may not be accurate enough, so it may not be the best answer. But again, the class is the biggest divider, right? So if you have that class, 1 information, that gives you the greatest distinguishing bits of information.
Thank you.
Yeah.
You talked quite a bit about VAP1, but I don't recall you mentioning anything about positive or negative.
So
can you explain that a little?
Yeah, sure. So BAP1 inactivation or loss of BAP1 is what drives these tumors to be more aggressive. It's a tumor suppressor gene. So the function of BAP1 is to keep cancer away. So if you need 2 of them to make that happen, if one's not working well or one is missing, then that ability to protect is lost. So BAP1 is seen, the loss of BAP1 is seen in the most aggressive ocular melanomas, and that's been shown in various different techniques of genetic testing.
Hi, thank you. Given all the genetic and proteomic information we're collecting on the uveal melanomas, are there any antigens, overexpressed antigens on the cell surface of these melanomas, overexpressed relative to normal tissue, that would allow them to be targeted with more specific, antibody drug conjugates or immuno-oncology agents?
Brilliant question. Yes. So short answer is there are. And one example, for example, is the treatment that Dr. Stacey was talking about with Aura Biosciences. So using that's a heparin sulfate proteoglycan. That's one of the overexpressed molecules in melanocytic lesions. So there are already drugs that are targeting for that. So the nice thing is the number of overexpressed molecules are relatively limited compared to other cancers. So it does provide an opportunity for direct targeting of those, but the eye is a little complicated to get all of that into. But we're now seeing with the other clinical trials in the neoadjuvant setting, such as by a company called IDEA with darovasertib, that there are targets now that are clearly expressed that antibodies can go to. I think that's a brilliant next step that we need to explore further. Yes.
For you, Dr. M. Do you think in our career lifetimes we will be obtaining biopsies from the aqueous in most of these patients' clinical visits when they come in?
Yeah, I think we should. I think that this type of information again needs to be validated, and we need to follow patients further. But what we're seeing is that there are different ways to characterize patients in general based on this protein, which is different than the size of the tumor or the location or even the gene expression. I think it's going to give us more information. And the bottom line is proteins are what drugs work against. Drugs don't work against genes or gene expression. So I think this does provide an opportunity for customizing local therapies within the eye, and maybe that will define what's happening outside of the eye as well. The other advantage of this is that it's done in the office, it's easy to do, low risk. So if someone has a lesion that we're not sure, and you brought this up before, how do you tell if something is going to be a stay as a mole, or does it become a melanoma, or does it become a high risk or low risk? I think there's opportunities to try to figure that out. We can talk during lunch. Thank you. Yeah.
Thank you so much, Dr. M, and thank you for coming to visit us this weekend. It's a real pleasure having you. I'll introduce our next speaker. Lucinda Innes is a PhD student studying immunology at Cornell and also in a lab at Yale at the moment. She's working with people specifically interested in uveal melanoma. And of note, she is a uveal melanoma patient herself. So soon to be Dr. Innes. Thank you for coming today.
Hello, as you mentioned, I'm Lucy Innes. It's really nice seeing you all here. I'm really happy that I can sort of bridge this gap between patients and researchers and doctors. I was diagnosed 3 years ago and still doing well. So without further ado, I've basically been spending the past 2 years focusing my PhD research on studying uveal melanoma, particularly in the context of immunology and how it evades the immune system. And so I'll talk a little bit about the immunology of uveal melanoma today with you. So first of all, I want to talk about what's the purpose of the immune system and get everyone on the same page. So most of us think, okay, it kind of protects you from bacteria and viruses. My definition is that it protects you from cellular attacks. So it doesn't protect you from being stabbed, right? But it will protect you from any cell trying to attack you. And that's typically we think of bacteria. They're really small cells. They're going to come in and try to invade your body. Viruses will hijack your cells and try to use your cells to attack the body. But what's less known is that actually the immune system is really, really well optimized to also fight cancer. So that's cells that become malignant and try to attack you from the inside, your own cells trying to attack you. And the immune system is really, really great at fighting these. I mean, it actually happens fairly often that cells will start to grow out of control and the immune system can sort of sweep it up. And it's really only the tumors that are able to evade this that will develop into a clinically relevant disease. So let's talk a bit about what are the two arms of immunity. So there's the innate immune system, and that sort of, it's what's been fighting off bacteria for millions of years. It fights the things we've known forever. Typically that's bacteria. There's also the adaptive immune system, and that's going to fight off things like viruses that are constantly changing and adapting. And both of these play some role in fighting cancer. And I'll walk you through really quickly what are the sort of the key players of the immune system. So in the adaptive immune system, we have T cells and B cells. And these are looking for viruses or malignantly transformed cancer cells that are looking really suspicious. T cells will basically, when they find something, they'll clone themselves a million times and sort of stage the frontline attack against that suspicious cell. And B cells are really there to create a long-term memory against that suspicious cell. In the innate immunity, we have neutrophils and macrophages. These don't play a huge role in fighting cancer. They're really good there. You know, if you get a cut, they're going to be that first line of attack at defending against the bacteria. The key player in the innate immunity for fighting cancer is natural killer cells. And they are awesome at finding all or most of the cells that slip through the cracks and evade T cell killing. So in these two arms, we have T cells and natural killer cells being the main fighting force against cancer in our immune system. And the last cell I want to mention, give a little shout out to, is the dendritic cell. And these can actually potentially are already helping us, say when you get radiation and there's a bunch of cell debris and they come in and they see all this sort of site of like a suspicious event, they can actually take all those proteins, bring them to the T cells, and potentially the T cells can engage a response. So, okay, now we've got this whole cast of Avengers fighting your cancer, right? So how exactly does cancer evade this, what's seemingly pretty, complex mechanism? And the first mechanism, I first have to explain, how does a T cell identify a suspicious cell? And that's through this marker called MHC class 1. It's basically an identity marker. A T cell cannot look inside of your cell and see what's going on there. It has to look on the surface, because otherwise it'd break open the cell and kill it. It only wants to do that if the cell is suspicious. So it looks at this molecule called MHC class 1, and that will sort of give an indicator of how healthy the cell is. If it's healthy, the T cell will leave it alone. If it's a cancer cell, if it's suspicious, if it's virally infected, that T cell oftentimes will attack it and kill it. And that's sort of the end of the story. In real cancer cells, the first mechanism to evade T cell killing is to just lose this MHC molecule altogether. If that MHC isn't there, the T cells have a much harder time killing the cell. And so this first mechanism is hiding attack signals. The next one is what we call immune checkpoints. And so this is, sometimes there'll be a cell that looks suspicious, but it's totally healthy and it wants, maybe it's just damaged and it's trying to recover. And so it'll put up what's called an immune checkpoint. In this example, it's PD-L1. And it basically says, don't attack me, I'm healthy. And when the T cell sees this, it may say, you're a suspicious cell, but you've got this don't attack flag, I'll leave you alone. And cancer cells will kind of hijack this system and express PD-L1, and that will allow them to evade killing. And so this is what I call like displaying don't attack signals. And these are, I'd say, the main two mechanisms by which cancer cells will evade being killed by T cells. And so that brings us to sort of how does immunotherapy work? Because basically the point of it is to try to alter these stop and go, these attack and don't attack signals to try to get the T cells to still attack these suspicious cells without attacking healthy cells. So in this example, the cancer cell has this stop attack signal, PDL1, that binds to PD1 on the T cell, and it makes it so the cell does not get killed, it's alive. In a clinical setting, we can use a monoclonal antibody that's going to block this interaction. So it's in the way. It's bound to PD1 on the T cell, so when that don't attack flag tries to tell the T cell, don't attack me, nothing happens. And this may sound a little abstract, you're like, it's a monoclonal antibody, but some of you may have even taken a therapy that uses this. So nivolumab and pembrolizumab are examples of PD1 inhibitors. And basically, the mechanism here is it blocks this interaction and allows the T cell to keep killing, even if they have this don't attack flag. And I've been really lucky to work with one of the first clinicians to use this therapy to run the first clinical trials. He's on my committee, Dr. Jed Wolchok, and I heard this really incredible story about, I think the first stages of immunotherapy were really, really toxic to patients, and it made a lot of clinicians very, very hesitant to try future attempts at it, just out of fear of the toxicity. And Dr. Jed Wolchok really had a lot of faith in this therapy. And the story I heard is that he basically went to every single patient and personally talked to them, left his name on every door, and really thankfully that those clinical trials went really, really well and are currently a frontline therapy for a lot of uveal and cutaneous melanoma patients. And that does raise the question of we see really, really excellent results from immunotherapies in skin melanoma patients, but we don't see quite as promising results in uveal melanoma patients. And so really quickly, I'm just going to talk through why do we see this difference? Why is there less of an effect in uveal melanoma than in skin melanoma? And the big thing is that mostly we see cutaneous melanoma has a lot more mutations. It has a lot more of these suspicious these attack flags than uveal melanoma does. And so a T cell can see it, say, hey, this is obviously something's going wrong here, let's attack it. Uveal melanoma might just not have as many of these. And so if you block the don't attack signal, that might not do anything because it's not attacking in the first place. The other side of it is that the eye and the liver, for different reasons, are both what's called immunosuppressed organs. So they basically, in the eye, it's not great to have a immune response because it can make you go blind. And the liver, it's getting all of this sort of antigen from your blood, from food. And so it doesn't want to attack every single thing that comes in. So both of these things just happen to be really immunosuppressed sites where there's essentially a lot of sort of environmental don't attack signals floating around. And those tell the T cells only attack if you know for sure there's something here. And if you pair that with the fact that uveal melanoma is a more subtle cancer that's kind of flying under the radar, this can sort of add up to seeing much less of an effect with these traditional immunotherapies. And so the next thing I want to talk about is just sort of what's the future of immunotherapy, because I think all of us want to know that we're going to be, there's more therapies coming out in the future. A lot of therapies have focused on T cells, and a lot of advancements are still coming out in terms of T cells. But one thing I'm really interested in is looking at natural killer cell therapies. They tend to be less toxic, especially in combination with T cell therapies. The other one is dendritic cell therapies, and Dr. Chen was actually sort of implicating this, where potentially that could get used in combination with radiation, where you're basically telling the dendritic cell, this is what you need to look for, and those will go on to tell T cells what to attack. And you're really, I think the main goal here is trying to use the whole immune system, taking a step back and using the checks and balances that are already in the immune system to create a more natural immune response to the tumor that includes all the checks and balances required for safety. And so, yeah, I'm really hopeful looking ahead at these, and I'll keep you all up to date about them. If any of you are interested, I did record a podcast with Danae in the I Believe podcast talking a bit about immunotherapy. So if any of you want to watch that, that's online. So, but yeah, thank you so much.
Thank you so much for a great overview. We are going to talk a little bit more about immunotherapy, so we're going to hold questions until the three next speakers are done, and then we'll have the panel come up and answer questions. So thank you so much, Lucy. We are moving from the eye space to the body space. So we talked about eye treatments. We talked about the prognosis that we get from the eye. We now talked a little bit about immunotherapy. And of course, the reason we talk about the basics of immunotherapy is because immunotherapy is at the front line of how we treat melanoma, uveal melanoma, when it moves to the eye. So our next talk is going to be given by Dr. Evan Hall. He's going to talk a little bit about the treatments for the rest of the body when uveal melanoma moves to the rest of the body, the liver in particular. Just a little bit about Dr. Hall. He's a medical oncologist, an associate professor at the Fred Hutch and at the University of Washington, and a great colleague. I send him difficult things a lot. This guy a lot. I like all sorts of, he somehow got a pharmaceutical company to give us a free, very expensive medication recently. So I don't know how he works the miracles that he works, but he does. And I'm so grateful that he's here.
Thank you, Andrew. Can you guys hear me okay? I'm going to try to stand up straight. I always slouch, but I feel like when the microphone's low, it's harder for me. So let me know if you're having a hard time hearing me. It's really exciting to be here today. I just want to see who was part of the program 2 years ago. If you can just raise your hand online, in person. So about half, great. We've grown about 30% or so from the 2 year ago attendance. So it's really exciting to see this event gaining steam and bringing people together as a community. I think that's really the aspect of this event that's hard to appreciate unless you're here in person, is getting people with a rare disease together and the power that that has beyond the content of the lecture. So I thought what I would do today is talk a little bit about what happens when metastasis occurs with an eye toward things that are new and exciting. Because I think we know that what we have now, we've made progress, but it's not good enough for most patients. We need better treatment. And so I've kind of do a now and future oriented talk here. I do have a couple disclosures, none of which are relevant to the material I'll present today. So when we talk about systemic cancer therapy, and this is going to be in contrast to Dr. Bhatia's talk next, which is going to focus on liver targeting treatment, there are different types. And these terms get thrown around a lot by oncologists, and I think we just forget that not everybody maybe know what we're talking about. So I just started out with a couple definitions. We're not going to talk a ton about chemotherapy, but for many cancers, that's still used and is fundamental to the treatment of things like breast cancer and lung cancer. And these are basically carefully dosed poisons that they poison dividing cells. And as we've heard today from earlier talks, one of the hallmarks of cancer is they're dividing faster and in a less controlled fashion than normal cells. And so that's how chemotherapy works. Targeted therapy, which we will talk about today, are drugs that target specific biologic pathways. So we heard from Dr. M about some genes that are commonly mutated in ocular uveal. I'll use uveal melanoma. My title was ocular, so even doctors get confused by ocular versus uveal. But we know a lot about the genetics of the disease in terms of genes that are abnormal in the cancer cell, and we're starting to make some progress in developing therapies that work specifically at those growth signals that are abnormal in the cells. We just heard a great summary of immunotherapy and immune checkpoint inhibitors. So these are those medicines that block the don't attack signal. So I'll just leave it. I think Lucinda did a great job summarizing that. We have a unique type of immunotherapy in this disease called an ImmTAC. We'll go through how that works. That is how tebentafusp works, which is the FDA-approved medication, also known sometimes by the brand name Kimmtrak. And that's actually the only disease where this type of immunotherapy has made it to the market. And then we'll talk about cellular therapy, which is, I think, an exciting avenue for future treatment. So here we're taking an immune cell out of the patient and modifying it in some way to help it try to fight the cancer better. And then the drug is a living immune cell that is given back to the patient. So that's a little bit different type of therapy. So just to orient, when we're talking about metastatic disease, we're talking about time after diagnosis and usually after treatment, and patients are being monitored and are discovered to have a recurrence in a different part of the body, often the liver, but not exclusively the liver. And it's uncommon that this all happens at once. So that's only a few % of patients are diagnosed with metastasis when their eye tumor is diagnosed. This is usually a time later. And often when patients are being followed by an oncologist like Dr. Bhatia or myself. So our current standard systemic therapy toolkit is not very deep. We need a deeper bench, to use a sports analogy. So in the clinic now, if someone's diagnosed with a metastasis, and we're just looking at what's accessible to us as a standard type of treatment, not a part of a clinical trial, these are the types of treatment that I usually think about. We'll talk about tebentafusp in detail, and we've heard a lot about these immune checkpoint inhibitors, and we'll talk about those briefly before we move on to talking about what might be joining the bench soon. So tebentafusp was actually approved before our last symposium. So it's been on the market now for routine use for about 3 years. And it's actually the first treatment that received formal FDA approval to treat metastatic uveal melanoma. It is really a unique medicine, and we'll kind of go through this schematic, which I think does a pretty good job of explaining how it's unique, but not everybody is a candidate to receive it. And it's one of the most frustrating, disappointing parts of my job caring for patients with this disease is to go through the testing and to find out someone's immune system profile does not match the drug, and therefore the drug won't work for them. So it's not a treatment choice, and this is an inherited thing. We have no ability to control whether or not our immune system works well with this drug. It's something we inherit from our parents, and it's not something that's commonly known. So we have to test for it, and then we find out 1 to 2 weeks later, and we find out, yes, your immune system is potentially fit for this drug, or no, it's not. And when it's not, that's really disappointing because there's nothing you did wrong. It's just, it's just in your genetic code. So how it works, and we heard about how T cells engage with cells. The tebentafusp is basically this orange thing, and it is like a really sophisticated Velcro. So it sticks to T cells on the bottom, and this part's not that fancy comparatively. The fancy part is up here. You guys can see that. So this is basically a protein called GP100 that is presented in a picture frame that is determined by your inherited immune system. So an HLA, which is kind of how those proteins are displayed to your immune cell. And this is what has to be the A0201 type. And this is a really sophisticated lock and key connection of the Velcro at this end. And so if you don't have A0201, it's like a key trying to go in a lock that doesn't fit. This drug won't work. So it's actually important that we find that out so we don't offer a treatment that won't help you. But this is why the drug is so sophisticated and why it is limited to only about 40 to 50% of patients who have the HLA A0201. So we have to test for that to determine if this end of the target, if you're basically your lock and key mechanism of this drug will fit with your immune system. Just to kind of go into how impressive it is to do a study like this, to get on the market, about 400 patients were accrued, 56 cancer centers, 15 countries. Took 3 years to bring patients onto the study. So the study was open for 3 years, trying to accrue patients. And it took patients who were treatment naive, newly diagnosed metastatic patients. They had to have HLA A0201, and they were randomly assigned. So it also requires patients to be willing to undergo treatment that's randomly assigned to them, which is a difficult thing for patients often to kind of wrap their head around and be comfortable with. And here, 2 patients were randomly assigned to tebentafusp for every 1 patient that was assigned to investigator's choice. And I'll just say, this reflects how little at the time standard practice was to treat this disease. It wasn't everyone getting the same treatment in that arm. It was doctor's choice of several choices. And most patients got a drug called pembrolizumab, which is one of those immune checkpoint inhibitors that Lucinda talked about. But it actually was kind of a grab bag of your doctor could choose which of these they thought was right for you. And what brought it on the market, and this is actually an updated set of data since the symposium 2 years ago, is that patients who got tebentafusp lived longer with metastasis than those who didn't. And this has now been shown to be a long-term effect. Even now, this update provided patients with at least 3 years of follow-up. And you can see that the orange line represents the percentage of patients who are alive over time. And the blue line is, the orange line is the tebentafusp, and the blue line is the control. And even out for 3 years, the people who had tebentafusp first had a higher chance of being alive 3 years later than the people who didn't. And on average, patients lived about 5 months longer if they got tebentafusp than if they didn't. So interesting, this is the first time a randomized study where some patients get treatment A, some patients get treatment B, showed an overall survival benefit, a higher chance of being alive for metastatic ocular melanoma, which is what brought this on the market. What continues to be interesting and honestly perplex me, at least in the clinic, is the drug has an interesting way in which it seems to work. So one of the ways we start a treatment and then we do a scan a couple months later, we want to see, is the cancer smaller? We usually like that. Is it bigger? We don't like that. Or is it about the same? And on this study, the time until the cancer started to grow was pretty similar on average between the tebentafusp group and the other patients, the control arm who got investigator's choice. So that was kind of weird, because usually we think that the way a drug helps you live longer is that it slows down, or it delays the cancer growing and spreading further. And that didn't seem to be obviously happening here. And what was really interesting, and this was presented in the updated data, is even for patients whose first scan showed significant cancer growth, the cancer had progressed within the first 100 days of starting tebentafusp, those patients, compared to the patients whose cancer progressed starting the other treatment, also lived longer, even though the cancer in both cases had significantly grown in the first 3 months. So it's very interesting. It suggests that tebentafusp is doing something that plays out over the long term, even if it's not rapidly shrinking tumors in really very many patients at all. So this is still something we're trying to puzzle with and understand a little better, because it defies a lot of what we usually think of about how treatments work to improve survival. We know a lot more about side effects over time. This is usually the second thing that people ask when they're talking about a treatment is, what's the benefit and then what's the side effects? What's the price? And tebentafusp is an interesting drug in that most of the side effects happen early on. So in the first 1 to 2 months, it's very common to have things like rash, fevers. The first few doses are actually given with observation in the hospital overnight because it can affect your blood pressure in some patients, and they need increased monitoring. But over time, this is showing the side effect rates over time, it's actually pretty well tolerated. So once people get through the early turbulence, the drug seems to be fairly tolerable and not cause a lot of late side effects, which is interesting and different than some of our other treatments. So as far as where we stand, the rates of cancer shrinking when we start this, which is always what we like to see. We get that first scan, we want to see this treatment's definitely working, it's shrinking a lot. It's only about 1 in 10 patients, even with this longer follow-up, who get that. Yet we know that patients who get tebentafusp seem to live longer. So we're honestly still wrapping our heads around how much tebentafusp is enough, when do we move on, how do we put all this together? It's given weekly, which is really inconvenient for patients, but the side effects being front-loaded and it being pretty well tolerated over time is good. And I would describe it using a baseball analogy as like it's a single or a double. I think it's tremendously important to know that we have something that bends the curve and helps people live longer, but it's clearly not enough. We saw that 3 years after on the study, About 3/4 of patients who received tebentafusp were not alive. So we need better treatment. There's a whole group of patients, which is over half, who can't even receive the drug because they don't have the right immune profile. And so it seems to delay patients dying, but doesn't seem to prevent death, in my opinion. So it's a useful drug, but it's not a game changer. And so we have work to do. If we think about, I actually, because of Lucinda's great presentation, I don't have to talk a ton about these drugs, but these are the drugs that block the don't eat me signals, or don't attack me signals. And this is our treatment for people who aren't a tebentafusp candidate, or an alternative for those who've had tebentafusp or maybe decide not to receive tebentafusp. So typically we use a combination treatment of one of the PD-1 drugs, like nivolumab, with a partner called ipilimumab, which is a similar drug but works a little differently to have a stimulatory effect on the immune system. And what we know is that, again, only a minority of patients have cancer shrinkage. When we see it, it can be durable. So here it's kind of like there are occasionally some pretty impressive results with these drugs, but most patients don't have impressive results. So we can see here the rates of significant cancer shrinkage are probably somewhere between 10 and 20%. But for those patients, the control duration can be long. However, these drugs are really toxic. About half of patients can have severe side effects. I know some patients in the auditorium have received them and have experienced things that are very powerful in terms of the effects these can have on normal parts of the body. So here, there is this glimmer of, I wish I could tell who these patients were who would benefit in advance, because for them, the risk benefit is favorable. But for a lot of patients, they have toxicity and it just doesn't help them. So that's the current lay of the land. What's the exciting new stuff? So one thing that I think is we need to diversify our portfolio. Right now, we've got the ImmTAC drug, and we've got immune checkpoint inhibitors. And I am a huge immunotherapy enthusiast because when it works, it tends to help things in general across cancer improve long-term outcomes. But we need other tools in our toolkit. For the other diseases I treat, besides ocular melanoma, we have targeted therapy that can help patients who have side effects from immunotherapy or for whom immunotherapy doesn't work. And so we'll talk about targeted therapy in this disease and where things stand. And then we'll also talk about cellular therapy as something that's exciting on the horizon. So we heard from Dr. M that most ocular melanomas have mutations in the GNAQ and GNA11 gene. Those are that initial step. So this is incredibly common. In fact, it's really uncommon that I see a patient in clinic who's had the molecular testing who doesn't have a mutation in one of those, almost everybody. And we know those are involved in how the cancer grows. And so, boy, wouldn't it be great if we could develop a drug that targets that? That would be applicable to almost everybody. And so we've tried, and this is a part of a cascade. So this protein, which is mutated, functions and affects cell growth through a cascade of different proteins. And so there are multiple studies involving a drug that targets PKC. This is the darovasertib drug that's been mentioned a couple times, and we'll talk about that in a second. So this is a different schematic with a lot of the same proteins, but I like this picture because it shows all the different drugs that have been tested in different settings. I've highlighted in red the two that I'll talk a bit about as what I'll call emerging targeted therapies, or things that seem promising. So the first is the drug now called darovasertib, previously called IDE196. It's nice to have an actual name to call it. This inhibits a molecule that is downstream of that GNA11, GNAQ complex called PKC. And this is in an ongoing phase 2/3 trial. So if this shows promising results, this study has been designed with the idea that it could lead this drug to the market. So in the coming, I would say, year or years, this may become something that we add to that slide as far as our current toolkit. And so this is actually looking at the A0201 negative patients, specifically people who aren't candidates for tebentafusp. And the study is giving patients the darovasertib with a second pill-based targeted drug that seems to help darovasertib work better versus investigator's choice. So again, it highlights for the AO201 negative patients, there's not really a standard treatment that's deployed around the world. I do like seeing ipilimumab and nivolumab in here because that's how we treat patients here. So that seems like an honest and fair treatment there. But in earlier studies, smaller studies, this has showed up to 45% of patients have significant cancer shrinkage. So that shrinkage rate, kind of an early marker of effect, and average control duration of several months. So this is not related to HLA, so that seems promising. And I think we sometimes struggle with patients who come in and they're already feeling sick. And so if the cancer's already making you feel sick, and we think that the way to help you feel better is to really knock the cancer down and shrink it, none of the treatments I've talked about are incredibly likely to do that. And so something that maybe gives that result in half of patients could be a particularly good option for someone who's having symptoms. So I think that the targeted therapy space is certainly continues to be an area of interest. At ASCO this year, so just a couple months ago, some early data was presented about kind of a very new, kind of exciting approach to this. So the drug is called DYP688. It's not, doesn't have a name yet as far as I'm aware. And it's an antibody that has a drug stuck onto it. So the idea is, can we use the antibody to deliver the drug to the tumor cell and try to prevent it from being delivered to the rest of the body? Because that's where a lot of side effects come from cancer therapy or effects on normal cells. And then the drug itself is actually a GNAQ, GNA11 inhibitor directly. It actually inhibits the thing that we know most patients have a mutation in. So it basically is it's like a targeted therapy. It's like delivering a targeted drug with a target on the melanoma cell. The antibody binds to actually the same protein that tebentafusp targets, a protein called GP100, and then it delivers this GNAQ inhibitor. And so this was very early data. Patients on this study were getting different doses of the drug. So it's really looking at safety, but they actually treated 66 patients with ocular melanoma, and about 17% had significant shrinkage. 76% had some shrinkage at all, kind of less than that 30% threshold. And so this is, some of these patients have had multiple prior treatments. This is a very kind of heterogeneous group. Again, some patients had a low dose of the drug, some patients had a higher dose. So I think this is also pretty interesting. I like the idea of targeted therapy. Very novel. So coming back to things that are a little bit more in the immune system. Are there ways we can engineer immune cells to better fight these cancers? And here we come with PRAME. So we just heard from Dr. M a little bit about PRAME. PRAME is interesting. It's an acronym. It actually stands for preferentially expressed antigen in melanoma. It's a thing that we've known melanoma cells often express that normal cells don't. So this comes to a comment that was made earlier about how can we target things that are unique to melanoma. This is an interesting protein in that it is part of what's called the cancer testis antigen family. So most tissues in our body do not express this. It is really uniquely presented by cancers, and many different cancers besides melanomas of the eye express PRAME. And then the reproductive organs, so things like the testes, the ovaries can sometimes express this, but it's not present in our GI tract, in our skin to high levels. So it's a very appealing target, and it seems pretty cancer specific. What's tricky about it is that it mainly works inside the cell. So it's not expressed on the surface of the cell directly. It's again expressed usually within one of those HLA complexes. So this effort, called IMA203, is an effort to take immune cells from a patient, edit them to basically have the armament necessary to attack PRAME when expressed in AO201. So on the plus side, this is a really interesting immune modifying approach to attack a cancer-specific target. As it currently stands, this is also limited, though, to patients with specific HLA. So I think it's kind of a double-edged sword. It's also really different than anything we've talked about in how we treat patients. So you have to find out, again, if someone has the right immune profile. You take immune cells out of the body through a blood filtration procedure called leukapheresis. And then they're manufactured and turned around. And then you have to give patients chemo. So it turns out when you're going to give someone billions of immune cells back to their body, if you don't give chemo, it's kind of like a no vacancy sign on a hotel. And the cells tend not to live in the body and do what we want them to do against fighting the cancer. So you actually give chemo to create space in the body for the cells. And then you get the cells, which are, again, kind of programmed with the machinery to search and destroy PRAME-expressing cancer cells. And then you get an immune-stimulating medicine called IL-2 for about 10 days afterward. It's a single treatment. One very intensive process. This chemo is intensive, and this immune-stimulating treatment is, I would say, modestly intensive. So where we're at now is we've seen data from about 16 uveal melanoma patients. 2/3 had significant cancer shrinkage. Average rate of control was approaching a year. On the downside, it again appears to be headed towards another HLA-restricted drug. So again, this kind of haves and have-nots that has nothing to do with anyone's personal health or anything, just their inheritance, which is a little frustrating. It's very intensive. So I think we really need to learn, if we're going to deliver a treatment with a bunch of toxicity, how can we learn who's most likely to benefit? And maybe we can look at things like PRAME expression and find cancers that express PRAME a lot, and maybe those will be the ones that end up being the best treatment for this. So a lot to come here, but I think a very exciting and a very different approach to immunotherapy. So in conclusion, we're trying to diversify our bench. Right now, we've got tebentafusp and immune checkpoint drugs for most patients. I think targeted therapies and cell therapies in the year or years to come will be things we hear more about, including the PKC drug, which is in an ongoing phase 3 study. I think there's a lot of unanswered questions, which segue into Dr. Bhatia's talk. How do we combine these things with things that can help treat cancer in the liver? And then as we get a bigger bench, how do we do the right sequence? You know, if we begin to have more choices, what's the right way to go about sequencing treatments? And then how do we deliver the HLA drugs to patients who don't have AO201? And is there a way we can do that without doing repetitive large trials that require lots of resources? So with that, I will wrap up and look forward to questions after Dr. Bhatia's talk.
Thank you so much, Dr. Hall. I'm sure everybody understood everything about those. And if you didn't, welcome to the club. There's maybe 2 people here who do. But the great thing is how exciting the world is that we live in right now in uveal melanoma. Those of us who are ophthalmologists are excited for this as well, because we think it's going to have a role not just when the tumor spreads, but also in the primary setting. Perhaps getting us away from radiation would be great. Our next speaker is Dr. Bhatia. Dr. Bhatia is the director of the melanoma group here at the Fred Hutch. I know that he takes care of other patients, but I like to think that he thinks only about us. And I know there are other melanoma patients, but whenever I talk to him, we're talking about ocular melanoma. So I feel like his whole career is ocular melanoma because I don't see any other part of it. But he's very important. He sits on some important committees across the country and is very knowledgeable about this space. We're grateful for him to be here. He's going to speak about therapies directed at the liver. Dr. Bhatia.
Thank you, Andrew. So Evan and Lucy have made my job much easier by introducing you to the many concepts already. I don't know if you have seen the agenda. Evan and I are going to have a fierce debate after lunch. We are on opposite sides of the spectrum over there. But before lunch, we are buddies. We're going to try help each other solve this challenging problem of how to stimulate immune system against cancer cells in this very challenging disease of ocular melanoma. And I actually want to make one more comment. Dr. M, his last name, Mruthyunjaya, does anybody know what that means? Mrityu is death, and Jay is conqueror. So Dr. M is the conqueror of death. And as oncologists, that is kind of what we aspire to be. We want to be more like Dr. M. So
All right, so what we have heard all morning is ocular melanoma is a challenging disease. Despite adequate therapy to the eye, many a times it spreads, and the organ that it goes to most commonly is the liver. So it raises the question, actually, if we look at all the patients coming into our clinic, so Evan and I, 85% of those patients have disease in the liver. Once they have metastatic disease, that is the primary site of disease. And if it is unchecked, that is what makes ocular melanoma the life-threatening disease that it is. Liver is a vital organ. If tumors keep growing over there, generally over time, the liver will stop working, and that is what leads to life-threatening complications from this disease. So the question is, while we are trying to figure out a systemic solution, which is what Dr. Hall talked about, can we also figure out how to control the disease in the liver so we can prevent the morbidity and mortality from this disease? And there are many ways to do this. And I've listed a lot of liver-directed therapies over here. As you can see, we can always do surgery if there is 1 or 2 tumors. We can throw radiation. Somebody asked Dr. Chen the excellent question of, can we use proton radiation for liver? We can do these different kinds of ablations. We can put probes into the tumors. We can heat them up to death. We can cool them down to death. We can also do what we call transarterial embolization. Basically, we put a catheter in the groin, and then the catheter goes into the blood vessel that is feeding the tumor, and we can block the blood supply that is feeding the tumor. And we can then deliver chemotherapy. We can do radiation. There's a radioactive isotope, yttrium-90. So all of these approaches can be done. Then there are FDA-approved therapies which are also delivering very high doses of chemotherapy selectively to the liver. So you kind of give it through the artery and take it out of the vein. So you spare the rest of the body from getting that chemotherapy, but you hope to control disease in the liver. Recently, there is this other new modality where you can deliver energy to the tumor tissue in the liver and disrupt it, something called histotripsy, which is available in Seattle as well. So there are all of these different liver-directed therapies that can be done to address the tumors where we see it. Interestingly, of all that we do for people with metastatic disease, the biggest impact actually happens with liver-directed therapy. So this is the survival curve. The liver-directed therapies are shown in orange, anti-angiogenic drugs, chemotherapy drugs, immunotherapy drugs, and other kinases that Dr. Hall just talked about. They're kind of all listed here. But if you look at the best survival is people who got liver-directed therapy. So again, I think when we are evaluating patients in the clinic, we are also thinking about, in addition to creating systemic benefit, can we also simultaneously try to control the disease in the liver? Today, I'm going to switch that focus from liver-directed any therapy to actually liver-directed immunotherapy. And the reason for this is we have learned a lot of what we do in ocular melanoma from cutaneous melanoma. So in cutaneous melanoma, we actually have a lot of different drugs now available. We have a lot of different immunotherapies that we just learned about, immune checkpoint inhibitors. We also, on the other side, we have a lot of chemotherapies, targeted chemotherapies that Dr. Hall described, darovasertib and GNAQ inhibitors and so on. All of those drugs are available in cutaneous melanoma, and they work really well in cutaneous melanoma. They work right away. So some of these targeted therapies, within hours, they shrink the tumors, and they keep the tumor shrunk for many, many months, more than what even immunotherapy works in ocular melanoma. So the question was, if you have both options available, what would you use for the patients? From my experiences of the last 20 years, I've always been a believer in the power of our immune system. I have a fundamental belief that if we can stimulate the immune system against the cancer cells the right way, magic happens. It doesn't happen very often in ocular melanoma. That is the problem. But it is all about the immune system. If you want to, Dr. Hall used the baseball analogy. If we can sometimes go to the first plate or the second plate, but if we actually want home runs, we have to involve the immune system. So in cutaneous melanoma, this question was addressed in this very elegant trial where half the patients got immunotherapy first, and then if it stopped working, they could go then get the targeted chemotherapy. The other half got targeted chemotherapy first, and if it stopped working, then they got the immunotherapy. And what it showed is the sequence matters. If you get immunotherapy first, your survival is far greater as compared to targeted chemotherapy. Now, both of these approaches work really well in cutaneous melanoma. So early on, probably chemotherapy actually works even better, but long-term outcomes are better with immunotherapy. So that is the fundamental belief that has guided how we are treating this disease in our clinic. And Lucy referred to this. This is kind of how I envision what's happening in every single patient situation. So generally, when the cancer cells are first arising in the eye, our immune cells, the CD8 T cells or the NK cells, natural killer cells, they're able to lead to elimination of the cancer cells. But then cancer cells become smarter, and they are then able to coexist with the immune cells. They use some of those mechanisms of hiding from the immune system. And that is where we have equilibrium. Everybody's coexisting. The tumors are not growing. But when we see the problem in the clinic, when somebody's tumors are growing, they have escaped the immune system through some of those mechanisms. So this is the problem we have in the clinic. And we are trying to restore it either to elimination, ideally. We want to cure our patients, get rid of the cancer cells. And sometimes we are not able to do that. Then at least we want to put them in equilibrium. So we help the immune system control. And that is what Dr. Hall again talked about. Drugs like tebentafusp are trying to do that by at least restoring the equilibrium. So today, I'm going to also tell you what we have been doing over the last 10 years, again, trying to stimulate the immune system against the cancer cells in the liver. So Dr. Natalie Miller is one of our newest faculty recruits, and she looked at our data with this approach over the last 10 years, and this paper just got published a couple of months back. So what this paper is trying to show is how can we combine liver-directed immunotherapy with systemic immune checkpoint inhibitors to overcome this immune escape in the patients. So what is transarterial embolization? So I just told you that we can put a catheter in the groin, go to the blood vessels that are feeding the tumors. Instead of delivering chemotherapy, which is called TACE, or radiotherapy like yttrium-90, we can actually inject this drug called GM-CSF, which works on those dendritic cells that Lucy talked about. So the idea there is that we can block the blood supply to the tumors, which will hopefully kill the tumor cells, but then we inject this immunotherapy there. Hopefully the immune cells will detect the dying cancer cells and train themselves against those dying cancer cells. So that is the idea of this approach. And this is kind of how it looks like. Dr. Wayne Monsky does most of these procedures at University of Washington. And you can see the catheter here, which was put through the groin. And it injects this dye and see all these blood vessels in the liver. Then he injects this gel foam, and the immunotherapy drugs. And you can see all those blood vessels are now obliterated. So again, the idea of blocking the blood supply to the tumors. And what we have done is combine this approach with systemic immunotherapy. And the idea there is that we will kill the cancer cells in the tumor, in the liver, and hopefully train the immune system against those dying cancer cells. But also those trained immune cells, we want them to work better. So the drugs like Ipi, Nivo, Pembro, those drugs, the immune checkpoint inhibitors, can help those immune cells work better. So if you combine a local approach in the liver with a systemic approach throughout the body, maybe we can get better immune responses. So the first part of combining different things is it safe to do it? And what we found out that, yes, it's generally very safe, and most of our patients were able to get multiple treatments. Some people do get side effects. So 50% of our patients who got some immune side effect, generally that happened if they got the 2 immunotherapy drugs, Epi-Nivo, which we know has more than a 50% chance of causing bad side effects. So we were not seeing anything specific with combining the two. We were just seeing the toxicities of the 2 approaches. There is always a concern that if you try to create too much action in the liver, it could result in hepatitis. So that is one particular side effect we were very interested in. And it did happen in some patients, but all of these patients, we were able to treat it very well with steroids. And in many of them, we were able to restart immunotherapy as well. So the bottom line is we are able to combine it in patients, these 2 different approaches, we working together with Dr. Monsky. So this is kind of summary of the results. So we looked at patients treated over the last several years. We identified a total of 18 patients. And 3 of those 18 patients, 17%, actually had what I would call close to home runs. They had significant shrinkage of the tumors, and it actually lasted much longer than the average expected duration of 12 months or so. But many other patients had what we call stable disease. So their tumors did not shrink substantially, but they were stabilized for long periods of time. So either one of those is a victory. It could possibly lead to elimination, or as I said, equilibrium is acceptable here. So again, if you sum it up, like close to 50–60% of patients, I feel like benefited from this approach. And this is one of the examples. So this person had 2 liver lesions, and you can see this is before the treatment, but after the treatment, this is 3 years later, this tumor is shrunk, the other one is gone, and there are no other new tumors that have arisen in the liver. So again, that is very powerful when you think about 3 years of benefit with an approach. That is not something that we see with our other systemic therapies. So our overall outcomes are summarized here. Most patients got this, an average time to next treatment. So generally, we will switch the treatment when we realize that the first treatment is no longer working. So the average time was close to 20 months, so 1.5 years. The average survival from the first procedure was 3 years, 35 months, which when you look at the data with benta-FUSP or the other liver-directed therapies, it actually doesn't look bad. So we feel like we are not hurting our patients by trying to combine these 2 approaches. And the other beautiful thing is it doesn't require the HLA typing that we use. So then we also looked at, okay, are there features that could predict more success or less success? And it turns out that people who have high tumor burden in the liver, which was defined as more than 20% of the liver was involved at baseline, they are the ones who may not do as well. But if the tumor burden is less than 20%, Dr. Monsky can do a series of treatments to control the disease in the liver, and that seems to be manifesting itself in much better overall outcomes. So the summary is that we can combine this approach with systemic immunotherapy. It's safe and feasible. It can lead to sustained clinical benefit in a subset of patients, not everybody. And patients who have less than 20% involvement in the liver, they appear to benefit the most. So in a way, this approach that we've been using for 10 years before any of these new approaches have come on board gives us the proof of concept that combining liver-directed immunotherapies with systemic immunotherapies may be the way to go when you're trying to stimulate immune responses in this cancer. So fortunately, there are efforts, other people are realizing it, and there are several efforts that are trying to do the same. So this is actually a clinical trial. This was the first clinical trial in this disease that I was very excited about because it was trying to mirror what we have been trying to do. And what they did is, this is a company called Trisalis. They use the special catheter, which is injecting the drugs at very high pressure. And you can see that if you use a standard catheter, the drug doesn't quite reach the tumors. But if you use a very high pressure catheter, the drug actually reaches the tumors much better. And then they were injecting this drug, which is a TLR, toll-like receptor agonist. So it is, Lucy talked about innate immune system, the natural killer cells and so on. So this kind of drug would stimulate the innate immune system. And then we combine it with systemic immune checkpoint inhibitors. And this is just a picture of the first patient who was treated on the trial. The team that was there, Dr. Monsky is here, and it's quite an elaborate procedure to do these kind of treatments in the interventional radiology suite. The other study, which is also trying to do similar things, is using this virus called RP2. This virus expresses GM-CSF, the same protein that we are doing in immunoembolization. It expresses it. Ipilimumab or anti-CTLA-4, the drug that is given systemically, this virus also expresses that. So in a way, it's delivering two different immunotherapies mixed in the virus, and we inject the virus into tumors like this, and you can see that it shrinks nicely. But then there are other tumors in the yellow here which were never injected, and you can see that they start shrinking too. So this suggests that if you stimulate the immune system in one place, the immune cells can travel to other areas and then do their magic. So we are really excited about this trial. The beautiful thing about this trial is it doesn't require patients to have a certain kind of HLA. So it's applicable to anybody with liver tumors. As long as we can see those on an ultrasound, we can inject the drug into those. And this trial is hopefully going to be up and running in Seattle very soon. So I think my final message is that to make the biggest difference in our patients who have metastatic disease, we need to persist in our quest for successful immune responses. And my treatment plans generally would be, we have to use immunotherapy plan A. If it doesn't work, we go to immunotherapy plan B. That doesn't work, we go to immunotherapy plan C. All we need is one plan to work really well for our patients. If we are successful, then that generally leads to, something closer to home runs. So with that, we'll stop. Thank you. We are running.
We're running a little behind, but we have time for maybe a couple of questions. If Lucinda, if you want to come up here as well.
Yeah, maybe we do questions till like 12:20 or so, and then we'll have 40 minutes for lunch.
First of all, I want to say that I feel incredibly lucky to be living in Seattle and to be under the care of all of these doctors here. As somebody who is connected across the country with the community, we have a very, very unique situation here. So thank you all. Also, Dr. D'Amato spoke highly of you. Dr. D'Amato, right, from Mooresfield. I met him at Aura in February, and he spoke very highly of you. So I'm just thinking, like, immunotherapy. I am a patient of immunotherapy. I had it as a first-line treatment because my cancer spread in a very unique way. It wasn't in my liver. I had what I think we would call a complete response, or at least, the tumors aren't there. And it came with, significant side effects. But I still think I'm still so excited about immunotherapy. I'm excited that Dr. Bhatia thinks that is the answer, because I think that immunotherapy is the answer as well. It's just getting it right. Is there any thought on, just curious what your thoughts are on patients getting it? Like, let's say it's not, in my mind, it worked so well for me because I had no tumor burden in my liver. It was outside of my liver. We attacked it aggressively and my immune system responded. So do you think there's anything to doing immunotherapy earlier overall, like that would get a better response in a cancer that doesn't typically get a response, or am I just really that unique?
When you say earlier, do you mean like
Like-
after diagnosis,
like,
even
not-
before development of metastatic disease, or?
Kind of, I know there are clinical trials with that. Like I'm on the, Dr. Hall and I we have talked about this. I'm probably in the middle as a person with significant toxicities. But I'm just curious, like what the thoughts are. I love the approach with the liver directed and the, nivolumab. I love that you guys are testing different dosing levels. Sorry.
Dr. Hall may be caring for you, but what you're saying is you are in my corner for the upcoming debate. So.
I probably am, but I'm also currently having significant side effects. So I might be more in his corner right now.
All right. Okay.
Some of us that did like chemo, right? I did a clinical trial with Dr. Sato when I was diagnosed immediately. So I did that not knowing if I needed to, but I did it because I was hoping it might help. And so I'm kind of like, is that much different than, the immunotherapy? I mean, because it wasn't an easy task either, so but it was offered to me and I jumped on it, so.
I think my question is just like, how early in the setting would immunotherapy be, the most effective? And and I know we're figuring that out, but I am very excited as a patient that was diagnosed 6 years ago, that was like, there was no hope, like to be where we are today is incredibly remarkable. So. Sorry,
No, a lot to respond to there, but I think I would say, in my opinion, that it is almost certainly better to treat metastatic disease early, and as early as we can identify it. I think that's a very appropriate time to begin immunotherapy. That leads the question to, what about if we use it as insurance, which will be the after lunch item. But I think that in general, by monitoring patients closely, although there are still some patients whose cancers grow very quickly and even between scans develop something that I would classify as more than minimal. For many patients, by monitoring people closely, we can intervene at a low tumor burden state. Initially, those patients that seem to do better in Dr. Bhatia's presentation, the lower burden patients, where things might be better set up to have a good immune response.
Yeah, I think the way I see it, yes, the concept is there is power in our immune system, and it is the key to eliminating cancer. But then there are different ways of stimulating the immune system. There are somewhat non-specific ways, which is what many of these drugs, Ipi/Nivo, are trying to do, and that is why they cause side effects. But I think as we are learning more about the immune systems, there are other ways to selectively stimulate the immune system against the cancer cells. So hopefully the vision of the future will be that we will be having many more effective cancer-specific ways where we can get the desired response without paying the price in terms of toxicities.
I think I've also heard, I'm not on the clinical side of this, but sometimes waiting until there's really enough disease for the immune system to really have enough content to stage a defense against can be valuable. But I think it probably varies dramatically from disease to disease.
Yeah, I wasn't saying that because I think I do not want to be monitored more closely. There is something that is a whole other talk. I think, because you mentioned being monitored more closely, and I think something within the patient community is thinking that you need to be monitored. I have to be monitored every 3 months. I have to, and that comes with its own, mental health side component to it. And I will also add, just for the patients in the room, that my metastatic disease was not even discovered during my every 6 month Mine was discovered during a mammogram. I know I'm sharing a lot, but I'm open. So it's keeping that in mind, like that the answer isn't always more frequent scans. And I also appreciate that you guys very much consider that, like in the overall. So
It's great. Thank you. We have time for a couple rapid fire questions.
What about the drug that they're developing that's supposed to be in pill form?
So,
I didn't mean to stump y'all.
darovasertib is a pill. So I'm wondering if that's maybe what you're talking about.
Yes.
I would say those generally fall into that targeted therapy category. There haven't been a lot of immunotherapies that have been successfully delivered in pills. So that drug is in a study that if it shows the effects it's shown previously, will hopefully lead it onto the market. So that's in its last hurdle to climb, so to speak.
So what time frame are we looking at?
I think we're going to see some preliminary results this fall, but probably not the level of results that we need to get it on the market to know if it will be approved. But the study it's on its last stages, and then we have to just wait a little while, which is hard. But probably in the next year or two, I would guess, we'll probably have the final results of that study.
So I might be mistaken, but I do know that during my initial diagnosis, there was talk of being tested to find out if I would be eligible for a drug. And I'm wondering if that's the AO201 testing. Because I wasn't metastatic at the time, I was told that I couldn't have the test. Is that something that you feel would be beneficial for everyone who's diagnosed with OM to have, just on the safe side?
I think that test is actually an easy test to get. So yes, there are, sometimes with tests, we feel, and it's a relatively expensive test, a couple of $1,000s. So I can see why insurance companies may create problems, especially if you don't need the information right away. And of all the battles we fight with the insurance company, that is one we have kind of let it slide away, a little bit, because as soon as we need that information, it's easy to order that test and we have the results in a week or so. So we're not wasting time by not ordering it in everybody. But I agree with you. The ideal situation will be, yes, might as well be prepared as early as possible.
A couple of rapid fire questions from the online community. First, some of them we will address. There was questions about adjuvant therapy. We will talk about that after lunch, so stay tuned for adjuvant therapy discussion. One of the patients asked, there's been a lot of discussion about BAP1. Is that a targetable thing?
Well, the rapid fire answer would be no. I think there's interest in that, but in the slightly longer answer is it's proven to be hard to target tumor suppressor genes. They're lost and they're not having their function, but to try to restore that is a lot different than blocking a gene that's causing the cancer to drive and overdrive. So it's a more sophisticated challenge for our colleagues in the laboratory to try to develop a drug to target BAP1, I would say.
The research I'm doing is actually looking at this complex called PRC1 that works opposite to BAP1, and it's looking, and actually apparently both of them are lost in these aggressive BAP1 mutation cancers. So there's actually some further research being done to explore maybe not directing therapies to BAP1 directly, but to other complexes it engages with. So that's, keep tuned.
Thank you. Maybe, go ahead.
So I've had 10 immunoembolizations. I've had them in combination with low-dose nivolumab. So far, things are great, but if there comes the time that the tumors become active again, is it the possibility or the idea to continue with the immunoembolizations, but maybe pivot from the nivolumab to Pembro or another PD-1 blocker or PD-L1?
So I think the question is, what if somebody has had toxicity with one immune checkpoint inhibitor? Are there other options? So the answer to that is yes, we can always do other drugs. We can still do combination of drugs such as Ipi-Nivo, for example, even in people who have had a side effect, because we are chasing those immune responses. And sometimes we know that we are going to get side effect, but we accept that because there is a bigger cause. But all of those decisions have to be individualized, depends on what side effect a person has had previously, and whether the potential benefit is worth the risk. But yes, we have all those options at our disposal.
I have one last question, and then we'll go to lunch from the online community again. Is there any lifestyle modification, diet, exercise, or otherwise, that should be done in combination with these? And I will add that is probably the most common question that I receive.
Specific to this disease, probably not, but I think it comes back to what Dr. Bhatia said about risk-benefit. So there was a very prominent colon cancer study that was just published that showed that for patients with colon cancer after chemotherapy who are treated with the goal of cure, exercise in that setting improved long-term survival. It improved the fraction of patients who are alive and cancer-free. So I think, the stuff that we're talking about has a way worse risk profile than exercise. So I think, to my mind, it's always, what's the harm? And we know the benefits of exercise extend way beyond cancer. So I think modest exercise, a great goal.
And how about diet?
That's really tough. I think, I would say in a nutshell, the things that we think of as healthy, whole grains, lean protein, avoiding processed food, they probably help your immune system to work better. We don't have anything that says, 25 blueberries a day is the magic thing. I wish we did, because that would be really actionable. But I think it, like, fundamental principles about promoting your body to be generally healthy as much as it can, so your immune system works as well as it can, is kind of where we're at. Someday we may have better.
I've actually got a really good one for this, which is that the stress you put yourself through trying to follow this crazy regimen, trying to follow these, this thing you read, and maybe competing diets that are all like disagreeing with each other, that stress can do more harm to you than following all those in the first place. So yeah, that was a big one for me, I'll be honest.
Thank you. That's great. And it proposes the most challenging thing that a doctor does, which is when they get this question, what you want to say is stop stressing. But the second you say stop stressing, they stress about stressing. Okay, let's go eat lunch. We will be back here at 1 o'clock. Conversations I had to Seattle was with some of the doctors you're going to hear here about whether or not we should have an adjuvant clinical trial in Seattle. And it's led to a very frequent back and forth about exchanging of ideas on the topic. Some of the doctors are supportive, some are less supportive. And I think what I love most about working here with the doctors you've heard is they are very open to ideas and really are trying their hardest to make the right decision. Not just the decision that everybody else is making, but the right decision. And so you're going to hear some for and against adjuvant clinical trials and probably an explanation of what exactly that means. And so Dr. Hall and Dr. Bhatia are going to argue on one side and the other of these trials, and then we'll ask them some questions. Who's starting? Are you going to start? Dr. Bhatia will start.
Just want to confirm this is being recorded, because I want this to be captured. All right, so the topic was adjuvant therapy of ocular melanoma, and one has to speak for and one has to speak against. So once upon a time, Evan and I used to be friends. So this is us at the Society of Melanoma Research last year in New Orleans. And we were at Cafe du Monde and enjoying our beignets and coffee. And we were smiling and, putting our hands around each other, getting these pictures taken. But when we were asked to do this debate, I think things have changed now. So I asked Evan, okay, do you want to speak for or against? And I gave him the option. I said, I'm fine with either. He said he wants to go against. So, and then he puts this smiley face with a wink. I have no idea why he did that. But this has led me to essentially this, that I am not going to hold any punches back today. So this is AI generated. The only thing I asked AI was to make us both look really buff. And I think they did a good job at that. Now, Andrew, I don't know, I don't think he knows what is going to happen. He has no clue how to control this fight. Like, you can see the helpless expression on his face. So, I want to start by why I am for adjuvant therapy. So I think what we have heard today is that ocular melanoma, yes, we can treat it in the eye. We can do surgery, we can do radiation, and the local control rate in the eye is actually very good. Very seldom we have failures in the eye. So that is not the problem, but generally the problem is that people can develop metastatic disease. And the risk for developing metastatic disease is not trivial. What Prithvi told us was, yes, we can estimate the risk better, but even if we are not able to estimate based on these fancy testing, if you just look at the smallest tumors in the eye, which are depicted here by stage 1, you can see, yes, the 3-year prognosis looks great, 2% chance of metastases, 5 years, only 5%. When you follow people over longer term, at 20 years, it's 20%. So if any one of us were told that in the next 20 years, you will develop a life-threatening disease which does not have great options, I think that's a significant threat. Unless I'm 95 years old, then I may not care about the 20-year prognosis, but otherwise I am going to be worried about this disease. So this is the earliest possible stage, stage 1. If you look at stage 2, that risk is 43%. Stage 3, 72%. So that risk is super high. And gene expression profile testing helps us estimate it somewhat better. What we actually when we look at the follow-up on gene expression profile, it's only 5 years. At 5 years, even this looks great. But at 20 years, it doesn't look great. So I think one of the things that we need in our field is more follow-up on gene expression profile. So in my mind, there is no low-risk ocular melanoma. Either it's high risk or moderate risk. So that is one principle I want to start with. And this is kind of what it looks like. Stage 1, 2, 3. Over time, if you give it enough time, there are more and more recurrences. The curve kind of goes up if you develop a recurrence. So you can see stage 3 has a high chance of developing a recurrence. And this is the point I was trying to make with Castle Biosciences. Yes, it's only 5 years. It looks great at 5 years, but if we gave it enough time, we will find more people develop metastatic disease. So the question that was raised earlier today was, when we know that something bad can happen, yes, we're going to monitor for that, but why not do something to change the outcome over there? And that is what adjuvant therapy is. After we have treated the eye, can we do some sort of therapy? Because we know those liver metastases are possibly there, can we do something proactively to reduce the risk of developing liver metastases? So ideally, going back to our 3 E's, ideally we want to eliminate the cancer cells. So prevent recurrence altogether, which is basically what we want to do, cure, facilitate cure. Now, sometimes we are not able to eliminate, but we talked about putting the cancer cells in equilibrium with the immune system. So that would lead to at least delaying a recurrence. So if the recurrence was supposed to happen 2-3 years from now, can we delay it by another couple of years, add more time of cancer-free interval? Because then in that 2 years, a lot of good things can happen. Maybe there will be multiple new drugs that become available. So if we can delay the cancer coming back, maybe our outcomes will be better. So with that in mind, there are several possible candidates which work in stage 4. When we can see the tumors, these drugs shrink the tumors. So for example, Ipi/Nivo has a 15-20% chance of working. Can we do it sooner to eliminate the cancer cells? Tebentafusp has 11-12% chance of working in HLA-A0201, and in others, it may still help. It may not work by shrinking the tumors, but it may stabilize those. Then there are all these other liver-directed therapies that we talked about, which can work against established liver tumors. Can we do those proactively? And then there is this class of drug called HDAC inhibitors, and these are supposedly drugs that can turn a class 2 tumor into a class 1. And they may be actually able to work. And there are trials that have been done with valproic acid. So I think there are lots of candidates which we could try. And again, we can use these to move the cancer cells from escape to elimination or equilibrium. And my final slide is, doing nothing is not an option. So thank you.
All right, you won't see any screenshots, personal confidential communications. Didn't know we were going there. We did surprise me. I like the AI graphic. I think we may very well come to a place in the middle, but I think I'm going to approach the argument against adjuvant therapy from a slightly different lens. And I think that where we're at is we shouldn't use this routinely now. I am all for a day where we know something works and we know something has the effect we want and is generally safe using it then. And I would argue that's not now, not with any of the treatments that he just described. So, we have had a number of attempts to try to look at effective adjuvant therapy, looking at different drugs in the different classes that I talked about earlier during the metastatic session. When I say a clear benefit, what I need to see is a group where patients are randomly assigned to a treatment or to placebo or to observation, and a clear reduction in the recurrence risk, or even more preferred, improved long-term survival. That's really the gold standard. You're giving a drug to a cancer-free person, as far as we can tell, cancer-free on scan, and you're exposing them to risk, so you have to see the benefit. And that's the bottom line of my presentation. Last year at ASCO, there was big news. Who heard about the Ipi-Nivo adjuvant study from ASCO? Anybody raise their hands? A few, okay. Well, maybe it wasn't that big a news. So in clinic, I use adjuvant therapy in skin melanoma and in kidney cancer in the other hats I wear in clinic, and it's a really complicated discussion with patients, and I usually draw a scale. And I try to describe what we're getting from taking the adjuvant therapy on the left, and what I would like to see is a clear reduction in the risk of recurrence, and even better, long-term reduced risk of dying of metastatic ocular melanoma. And then that's balanced against the risks. What are the side effects? What's it like to be on the drug? How much time does it take to do this? These are intravenous things. How long am I going to be spending in the cancer center, not out enjoying my hobbies or working? And then the reality is, when these things are used as standard, there will be some expense generated to the patient and to society. So that's kind of the balance. And so this was the study, if you haven't heard about this. This was a study that was very interesting. It's done through a cancer cooperative group. They tried to identify high-risk patients, and they gave them Ipi-Nivo. So they gave them the immune checkpoint inhibitor drugs that we talked about earlier and that Dr. Bhatia mentioned. And then they compared them to a control group that was not a part of the study. They tried to match them to other patients in history that were also high risk and look at the outcomes. So this was not a randomized study, but they tried to do what we call a synthetic control arm, like look at a group of patients outside the study and kind of estimate what would have happened with just observation. So patients got a year of treatment and were followed up. And then they did a bunch of really sophisticated statistics to try to minimize the effects of bias with this group. Because obviously you could take a group of patients and everyone recurred, and no matter what you showed, it would look good. And you could take a group of patients where no one recurred and this would look horrible. So they really tried to do as good of a job as they could to do a good control arm. So what did we see about the benefit from this at the presentation? So they showed, this is again, these curves of distant metastasis-free survival. Who was free from ocular melanoma metastasis? What percentage over time? And their study was designed to look at the 3-year outcomes, and that was the reference point where they decided if this treatment was effective versus controls. And that's this dotted line here. And the conclusion was 70% of people who got Ipi/Nivo were disease-free at 3 years. This was the people on the study. And in their group of patients that weren't a part of the study, it was 43%. So this was found to be statistically significant. So this got a lot of buzz. I actually saw people on social media saying we should give people Ipi/Nivo in the clinic next week. Like the next high-risk patient I see, they should get this. That's provocative. And I think this is provocative. I'm going to point here. Here, the two curves cross. If you actually look up to about 20 months, the risk of metastasis seems to be higher in the Ipi/Nivo patients. We don't usually see something like this when we do a randomized controlled trial. There's a few exceptions. But to me, this suggests that it further calls into question the control group. Like how much are these the same patients? Why would getting Ipi/Nivo increase the risk of metastasis early on and then decrease the risk of metastasis later? So I think this is an interesting finding of this graph. What about the risks? So on this study of people who were cancer-free by our best assessments, 48% had severe treatment-related side effects, 6% of patients had myocarditis or immune inflammation of the heart, which can be serious and life-threatening, 6% had immune-mediated lung inflammation, and 1 person died from a side effect of immunotherapy, cancer-free. They died of the treatment. So these are big drugs with big toxicities. And when we're using them to treat patients who have active metastatic cancer, that is a life-limiting illness. The risks are often warranted by the benefits. Giving them to people who might have a future problem, the risk-benefit changes considerably. Even if we go beyond serious and life-threatening toxicities, these are the rates of what I'll call nuisance side effects, things people experience during the treatment and oftentimes afterward. Fatigue, itching, and rash. If we think about time, patients on this study who got the treatment had 24 infusion days over the 12 months. Probably at least a half a day driving there, labs, infusion, leaving, coming home. I estimated at least 100 hours of in-clinic time, let alone travel. So a significant time expense. And then these drugs are expensive, which is, I think, a secondary issue, but one that is merits mentioning. So I think this is where we are with using this Ipi/Nivo study as an example. I'd say that there's uncertain benefit. Maybe there's a signal that the 3-year recurrence risk was lower, but not against a true control arm, against a manufactured control arm. So I would say uncertain impact on recurrence risk, no data yet about the risk of dying, certain side effects, certain risks. So I'm not actually against adjuvant therapy as much as I think my debate style would be. I'm in favor of adjuvant therapy that conclusively works. We don't have that yet. So I guess in that regard, I'm against adjuvant therapy today. To expose healthy people who might or might not develop cancer recurrence, we have to be sure that it improves outcomes at the population level. Class 2, we've heard it repeatedly, class 2, class 2, class 2. I have patients in my panel who are beyond the 5-year mark and who are cancer-free. So it's the best tool we have, but it's not perfect. You can be class 2 and not recur, and you can be class 1 and recur. So our ability to predict the highest risk people is getting better. But if we're going to give them treatments like Ipi/Nivo, I'd like it to be even better than it is. So we make sure that people are getting, the right patients are getting treatment that might help them. It's really hard to do nothing. I think that speaks to Dr. Bhatia's last point. You come into the office, you've had a serious illness, you hear about things like liver metastasis, and then your doctor says, we'll just see you every 3 to 6 months with scans. That's not comfortable to be in. But I actually think that there's an argument that doing something may be worse than nothing if you have significant risks, and that outweighs the benefits. And I would say that in order for me to change my mind, what I will need to see is a randomized trial where treatment is given against either a placebo or observation to ensure that we have the benefit part of the benefit risk before this is offered routinely. So with that, I will end my fraction of the debate and we can open it up.
Why don't you guys come up here in the octagon? Do you have one? Yeah. Okay. This is a hot debate. I mean, we joke a little bit, but it's a hot debate. And I've had this hot debate with these doctors a number of times. I have a few thoughts. Yeah, they don't even want to look at each other. Dr. M he'll keep them apart if. Okay, so I'm going to ask some provocative questions myself. Dr. Hall, I'm going to start with you. Your last point here, very, very good. What you would need to see is a randomized trial that compares the drug to placebo or observation and show that it actually is working with minimal side effects. So is not that, though, a different standard than holding an adjuvant clinical trial? So what you're referring to there is the risks and the benefits of treating somebody with an adjuvant treatment that may or may not already be approved. But are the standards lower for a clinical trial? Because if your standard is that thing, then we need that thing to happen as well. But that thing can't happen if your standard is that thing.
Yeah, I think I understand the question. So I am not against motivated patients seeking out and enrolling in adjuvant clinical trials. And I've actually had patients do that. I think we have not, in the 6 years that I've been here, had an adjuvant clinical trial open at our site because I don't think we found a trial that we thought provided benefits the right potential patients, the potential right benefit risk. So I can understand the motivation for an individual patient to seek out an adjuvant trial. Again, that feeling like you're doing something is very impactful, and but I think I don't know if that answered the question. I'm not against running an adjuvant trial, and I would say it's there's been a feeling that patients wouldn't go on an ipi/nivo versus placebo randomized trial because you don't know if you're going to get placebo or ipi/nivo. And I would say, boy, for the future patients that come after, knowing if this actually works, you're going to be exposing patients to myocarditis and pneumonitis. And so, boy, it would be sure nice to know for sure that it does what we think it might do. So there is a selflessness that you have to go on to a trial where you might be getting nothing. But when the treatments are toxic, I think it's really important.
Could you describe in generic terms what the benefits and risks would look like for a treatment where you would be comfortable holding the adjuvant trial or submitting the patient yourself to the adjuvant trial? What are the potential outcomes?
I think in most situations in cancer, treatment to be effective at eradicating a microscopic metastasis, it has to show benefit in the metastatic setting. So for most of cancer, that has held. So I would say there is an adjuvant tebentafusp trial happening around the world, largely outside the United States. That seems reasonable. We know a lot about the safety of the drug. It's a lot of time to get the drug, but like that, we at least have established that it seems to improve outcomes for metastatic patients, or at least some patients in the metastatic setting. That's reasonable to study. I actually think it would be reasonable to do an ipi/nivo adjuvant trial. I don't think that's an unreasonable study to do as a controlled trial.
Let me just make sure you all understand, because that's something that I had to learn as a non-oncologist. That's a very important point. What Dr. Hull is saying is that there doesn't seem to be much sense in holding a trial with a medication that has shown no effectiveness when we know that there are tumors. So when there are tumors in the liver and we treat a patient with that medication and it's not showing any sign of working, why would we move that to a different setting when we've never seen it work in the first place? And this is something that a lot of trials do. So let me ask the corresponding question, Dr. Bhatia. Do you believe, and let me introduce some terms here, we know that when melanoma spreads, it spreads in a small cell way. We refer to this as micro-metastatic disease. So there are probably cells spread through a body, though we cannot see them or know where they are until they grow large enough. Dr. Bhatia, do you think that there is a difference in how medications work in the micro-metastatic setting compared to when there are big tumors? Or in other words, is it possible that medications that don't work great against big tumors might have an effectiveness before the tumors exist?
That's a great question. And that is basically the fundamental question behind doing underlying adjuvant therapy. So I actually want to say, first of all, the reason for why Evan sent me that winking smiley face was because he knows where I stand.
Oh, he's giving it away.
He knows that I am completely against using adjuvant therapy with the current context. So I take pride in Evan winning this debate because, in a way, I'm winning because I recruited him here. So if he wins, it's actually a win for me and our program. So yes, I'm giving in to the debate. But I think the discussions that we have had over the years, in a way, are guided by what we have already seen in cutaneous melanoma. In cutaneous melanoma, we have the same drugs which work very well in metastatic setting. They work 50, 60% of the times. If you look at Epi-Nivo, 60% of the times, that makes a big difference. Many of those patients are cured. So when a drug that works so well in that setting, we don't use that in the adjuvant setting, even in high risk. The question is why? We have tested it, and what we have found out is that there are two options when you have a high risk situation where you know that the cancer is most likely to come back. You could either use a drug proactively, or you could wait when the cancer does come back. And there has to be a difference in outcomes with those two strategies to force you to treat everybody proactively. And in cutaneous melanoma, despite the drugs working so well in stage 4, we still do not see much difference in those two strategies. That suggests that while you could treat more proactively, if you just wait, and when the disease comes back, you can possibly get the same outcome in the long run. Now, what you don't get by delaying the treatment to when actually it's needed is side effects. Evan, actually, he talked about some of the more threatening side effects, but he also does research on long-term side effects. It's, joint pains and other things which can actually affect quality of life in a big way. And when you start exposing people who have 10, 15, 20% risk of the cancer coming back, and 80% chance the cancer may not even come back. And then you are exposing a lot of normal population to these potentially toxic drugs, and that has consequences. So that is why I completely agree with him that even if there was a drug that was super active in uveal melanoma down the line, I would still want to see a trial of it being done proactively in high-risk patients versus reactively down the line when the disease actually comes back.
Thanks. Dr. M.
That was excellent, and at very high and down and dirty low levels. It brings up really good points. So a comment and then a question. So some of the work that we've done with the sampling of the fluid within the eye shows that there's definitely different levels of proteins that are expressed in different tumors. And some of those proteins will correspond to pathways that are druggable, like meaning drugs that are available on the market today. So this gets, again, trying to probe Andrew's question of, is there a difference between the melanoma cell when we know it's just in the eye or one cell in transit versus the actual metastatic tumor? And then whether if you target it at the point even in the eye, could that have a role later? So gets to this question of neoadjuvant and adjuvant, which we'll probably have to explain to the group. But now the FDA is not allowing, or as I understand, a neoadjuvant adjuvant study. You have to show the neoadjuvant effect first before you add the adjuvant after. So it gets to, if you can treat the drug before you do the definitive ocular therapy, and it's the right drug, like customized to the right patient, would that have an impact down the line? You'll have to translate all that.
So there's two words that we use here, neoadjuvant and adjuvant. I don't know why we use such hard words in medicine. Neoadjuvant refers to when there is a tumor, say in the eye, treating with a medication for the whole body before doing anything to the eye. So giving some sort of a medication to see if the tumor in the eye shrinks before giving radiation or before removing the eye. Adjuvant treatment means after the tumor has been treated in the eye, either by eye removal or radiation, then giving a treatment to try and prevent the tumors from popping up in other places of the body.
That's a really good question and comment. I think I'm all for strategies that can help us identify which patients are likely to benefit from which treatments. And when you have the neoadjuvant approach, so this is, let's say you took a pill and then you had your eye tumor watched for 4 to 6 weeks. And then you had the protons or whatever, like if it shrank dramatically, that would suggest the pill was working on your tumor. If you do the protons and then you just take a pill for a year, you have no way of knowing what effect the pill's having. So I like that approach to make us understand which drugs for which patients, because we have patients where Ipi/Nivo has worked. It doesn't work for most patients. In fact, for most patients, it doesn't work. But if I knew who those people were, and you said, this is going to work for you, then all of a sudden that risk benefit looks totally different than there's a 15% chance this is going to work for you and a 50% chance you're going to have serious side effects. There's a 100% chance this is the right treatment for you. And then, yeah, there's a 50% chance of side effects, and we'll help manage that. But we know this is the right treatment for you. So I think the neoadjuvant approach, looking at biomarkers and trying to understand this, is a great learning system for us to then figure out what's the right treatment for which patient down the line and start making these numbers not 15% benefit, but 50, 60, 80% of patients with this type of this rare cancer benefit from this treatment. So I like the neoadjuvant approach to learn. That's a little different than doing it for everybody routinely. Like those are kind of different objectives. So I think as a study where we can learn from it, it's really powerful.
Thank you. We are in the 10th round here, so we are going to have to finish up and move on. But let me just ask one last question to the three of you. You included, Dr. Mruthyunjaya. Consider either yourself or your partner or your child is diagnosed with a 8 millimeter thick uveal melanoma that gets molecular prognostication and is class 2 PRAME positive. So you're in a stage 3 or 4 clinical tumor stage. You have a class 2 and a PRAME positive outlook, and your family member is 40 or 50 years old. What would you tell them to do at that point? And let's say the eye is removed. What would you tell them to do at that point?
I would say that you should be followed with a high-risk surveillance protocol. And for someone who's really motivated, there may be opportunities to look at different ways of doing surveillance, like circulating tumor DNA and other things that are probably going to change how we monitor people moving forward that aren't quite ready yet. So I'd probably try to translate that desire into doing something, into some sort of different monitoring strategy rather than an active treatment that we don't know if it works or not.
Yeah, I would echo that. I think so. I wouldn't suggest going on Epi-Nivo, for example, but I would encourage looking at other clinical trials that may be available and evaluate them to see what the risk benefits are, and if it's going to lead to an answer that could change what happens for them, but also for others. And I think you also bring up a good point. There are some or less invasive, maybe non-medication types of studies that are out there where that information from that one patient could be like the deciding difference, right? So being willing to do that might be best use of effort.
Thanks.
So just in accordance with my last slide, I will not do nothing. But that doesn't mean that we have to expose somebody to a potentially toxic treatment with no option, with no benefit. I think I completely agree. Close surveillance is the key. There's a good chance, as Evan mentioned, even a class 2 thick tumor may not recur for many years. And doing something today may actually end up doing more harm. What if the tumor does come back 8, 9 years from now? We are pretty certain the track we are on, we will have much better treatments down the line. So I will wait for the science to evolve to a point where there's good data for doing something actively from a treatment perspective. I do want to say the ideal treatment in the adjuvant setting is one that does not have a high risk of systemic side effects. The ideal treatment will learn from the biology of the tumor, whether we sample the fluid in the eye and find out what proteins are expressed on the cancer cells. Ideally, those proteins which are helping the cancer beat the immune system. So maybe we can inject a drug at the site of the tumor after doing the radiation to stimulate immune system against the dying cells, and that prevents the cancer cells from going somewhere else. And we already have many such treatments in other melanomas, and I think we can learn from those. We just need to keep trying, pursuing those immune responses in as relatively less invasive ways as possible. And then I think that's the key to solving this problem in the long run.
Thank you. Thank you, everybody.
All right. So we're not going to take a poll, but I think I seem to. No, I'm just kidding. We're not. I don't need to declare victory. The last part of our program is going to be focused even more on patients, which is really why we're here. And I think really excited to welcome our next speaker, Alex Lee, who's one of our clinical social workers in our melanoma clinic. So if you ever speak with one of our social workers, there's a couple that we have, and he's one of them. I think, the experience in that waiting when you're on surveillance is often a very challenging mental health exercise, an ongoing one where the challenges can change. And so I'm really happy Alex is here today to join us and talk a bit about fear of recurrence. Thanks, Alex.
Thanks everyone for having me. Thank you, Dr. Hall, for that introduction. Yeah, hi everyone. So my name's Alex. I use both he and they pronouns, and I'm one of the social workers here at Fred Hutch, attached to the melanoma group alongside my colleague Tracy. So we've heard today from several of our esteemed medical professionals on the amazing work and intense challenges that are associated with the science and medicine of uveal melanoma. And I'm here to take kind of a different tack. As Dr. Hall said, we're kind of switching up the focus a little bit to fear of recurrence. So for those of us who work in the mental health field at Fred Hutch, mostly including social workers, psychologists, and psychiatrists, this is something that we sit with routinely when we sit with patients or sit with caregivers. And when I came on board to do this talk, I was thinking, well, how do we talk about this fear of recurrence question, because one of the themes that seems to have come up a lot today is, what are we doing about the cancer? And in some ways, I'm kind of reframing this a little bit to, what are we doing with our lives in this moment? So as a little bit of a shameless plug for our social work team, so Tracy's on the left. She's actually the person who was originally scheduled to give this talk today, but unfortunately she's ill because she caught a back to school bug. And she wanted me to let you know that she wishes she could be here to join you. Let's just jump right to it. So our focus today is related to fear, and I want to make sure that we understand a bit about what fear is. Fear is an emotion. It can be real and entirely normal. It's also adaptive. It brings out our brain's automatic pilot to keep us safe by mobilizing our reserves when we're under stress. And this helps us recognize threats and respond by increasing our overall alertness and mobilizing our bodies to act. So I'm just going to go very superficially here because I know that we have some excellent physicians in the room and I dare not tread too deeply into those waters. So on the left side, we have our parasympathetic nervous system, which kind of keeps our bodies moving along when we're not actively under threat. People will refer to this as kind of the rest and digest system. We're kind of able to go about our daily functions, stop and smell the roses, or enjoy meaningful conversations with people, or do the kinds of activities that we generally enjoy. And on the right side, this is there to mobilize us when we're in some kind of a stressful situation, like right now when I'm giving a talk in front of you all, bringing out those kinds of reserves so that we can go back to that less active state and do other things that we enjoy. All right. So when we're talking about fear of recurrence, often how we might define it is as a fear or worry or concern relating to the possibility that cancer will come back or progress. And unlike distress, once we have this kind of fear of cancer recurrence, it doesn't really decrease over time if we kind of just let it go untreated. So the reason that the bear is here, so imagine that we're out on kind of a lovely hike in the Pacific Northwest, and we have a bear stumble out of the trees in front of us. And if anyone here has kind of like as few self-preservation instincts as I do, or have seen that internet video where there's that girl who's like, can I pet that dog? You know, you might be like, oh, that's so cute. But I imagine that for most of the people in this room, you might have some degree of distress or worry depending on how close that bear is, and want to gear up to either struggle or get away to a safe place. And so we might refer to this as fight or flight, or sometimes freeze, where we actually just shut down entirely in the moment. And let's say that somehow we get out of this situation successfully. We survive the moment, we get back in the car, we drive home. And when the bear is no longer in front of us and we have the sense that we're back in a space of safety, we might find that a concern about a bear attack relaxes substantially. Most people aren't really that concerned about getting attacked by a bear at home. Although if you do, please ask your wonderful oncology team to put in a special social work referral for me. I will take all bear-related requests. But yeah, no, most people don't get attacked by bears throughout the day. And that is what can feel so different about the experience of cancer and the fear of recurrence. So some patients might tell me that that fear is like waiting for the other shoe to drop, or feeling like there's a cloud over me all the time. And so if we extend kind of that bear analogy into the space, it becomes a fear that doesn't go away because there's a sense that at any time, in any place, it might show up again. And I want to note that, you know, fear of cancer recurrence affects everyone, everyone in this room and everyone online, I imagine as well. You know, we often talk about the experience of cancer as it relates to patients. And of course, this is a wonderful opportunity to talk about how it affects caregivers, loved ones. And also I want to recognize the members of the team that are participating in care as well, because all of us are human and care about your experience in this. All of us can be impacted by this fear and really driven and be motivated about what we can all collectively do to manage cancer and manage the concerns. So there are different studies or different numbers depending on which studies you look at. And so here we can kind of read off a few. here 78 to 83% of survivors and patients with cancer had some moderate and severe fear of cancer recurrence, and 31 to 85% of adolescent and young adult cancer patients experience this fear, and also half of caregivers. I think depending on the study, I've seen something like 22 to 99% as well, with kind of a higher proportion for patients who have rarer cancers, like uveal melanoma, experiencing FCR at a greater intensity. And at the same time that I talk about addressing this fear, I don't want to just jump and pathologize this whole experience. Fear is a very real and normal response to a range of situations involving cancer. Whether that is something like a new diagnosis, a change in treatment plans, or an end to a particular treatment, these are all major points where we have to make adjustments to our existing paradigms, where there's a certain kind of stress from a particular set of thoughts, assumptions, and beliefs around the way that things have worked or that things are having to work now. And so among them, things like shock, denial, anger, fear, sadness, guilt, existential distress, anxiety, depression, you name it, all the responses on this page and more are all very normal responses, and I have to make space to recognize that. And so some of this is indeed normal, but then, as some of these things fade, we might still be stuck with some of this emotion. And that's at the point where we start to mobilize a different kind of response. So as kind of, an interlude, I'm focused on kind of like fear of cancer recurrence that really stays with you and impacts your life. But, if we don't want to go there, if you say, well, Alex, you know what, I actually find this whole topic around fear of cancer recurrence to be really frustrating. And that's why I go through the day and stick to positive thoughts, because there's already enough negativity in my life related to cancer. And to that, I would say that if it is working well for you, I can't stand before anyone here and say that I can tell you how you should be living your life. But where I want to go is is the ways in which FCR really affects people's lives, affects the quality of your day-to-day. I think one of the ways that this fear can be so insidious is that it can show up in ways that we don't recognize and validate the same ways that we might some amount of physical symptoms. And so one kind of salient example that brings us into the cycle is that, in this process, we might notice some kind of experience of a physical symptom that we would have shrugged off before a cancer diagnosis showed up. So maybe you would notice like a drop in energy level, an increase in nausea or pain or something else. And, at that point, perhaps you would say, well, I'm feeling low energy because I stayed up too late, or maybe I ate something that didn't agree with me, or I tweaked something when I was out on a walk. But once cancer has entered that sort of domain of consideration and enters the realm of possibility, it can be quite common for that physical symptom to trigger a thought, well, what if this is a sign that cancer has come back? And that sort of really kicks off this cycle. Our fear creates that sense of perceived danger. It's definitely easier to tell if there's a bear in the bedroom with you than if cancer has returned. But the same part of the brain that's activated to respond to fear and keep you safe can get overwhelmed because we can simultaneously recognize that cancer as a threat and also not easily be able to calm that or know that it has or hasn't recurred. So then a lot of people will feel that the sense of cancer is pursuing them everywhere. And that becomes the sustained anxiety or worry that brings up feelings of hopelessness or helplessness. And as people lurk in that negativity, they can look for momentary sources of reassurance. They might avoid things that they used to enjoy, especially if those things remind them of cancer and lead them to pull back from the world. Suffer from insomnia, which can, kick up another round of this cycle. And also engage in substance use just to get some relief. And I wouldn't be shocked if anyone in this room or someone that has had some of that experience. So then we kind of go to the magic question of, how much of my time do I spend thinking about this? And as I kind of alluded to, the reason we make such a big deal about this, even when cancer is not being like medically aggressively targeted, is because we don't choose to pretend that the experience of cancer has just stopped impacting you because you're not coming as regularly to appointments when you're on something like high-risk surveillance or surveillance period, whether you are a patient or someone who cares deeply about a patient who's going through the experience. We've talked a lot about time today, and it's a really big deal that there's so much literature out there that your team has read, that maybe you've read when it comes to time. And we've talked about time, through just about every presentation today. And in that process, we might ask, what's that prognosis going to be? If there's a significant risk of recurrence, how long am I going to have before I start to worry about cancer showing up again? If the consequences of recurrence showing up are severe, if we don't catch it immediately, how primed am I going to be to react to everything and make sure that I get that message to my team so we can do something about it? And these are all important concerns. Just thinking about them, however, can also take up so much energy and take so much away from us that, in this moment, on this very day with you all here, that you can enjoy other things aside from the experience of cancer. So then what? So one of the questions that often comes up toward me in this process as a therapist, as a social worker here, is how do we take in all of this and do something about it so that we can actually move forward beyond kind of a fight, flight, freeze response? So in the sense that we've talked about, we got to do something about this, we have to act, we can't do nothing. I would say that there are different ways of acting that aren't just about targeting treatment to enhance this quality of life question. Because there's nothing that I know of that we can do to absolutely guarantee 100% without a shadow of a doubt that cancer won't come back. And so in the upper right-hand corner of this slide, we have kind of a problem-focused approach that may have worked very early on when you were first diagnosed or someone you love was first diagnosed, because in that moment, you and the team had a plan, an approach, and that may have been the thing that brought cancer into a place of control in the first place. But when we're talking about FCR, it's not clear that there's anything more that you can do, whether it's through continuing ongoing medical interventions or discussing lifestyle interventions, as people have talked about. Maybe we can tweak probabilities, but not arrive at that point of certainty. And so in shifting this focus, we go moving our locus of control from the external variables that can't be verified to our complete satisfaction back into a space of internal development so that we can face these fears through a focus on this emotion and work to live with them so they are quieter and less overwhelming in the course of your life. I guess very briefly, because I think I am already at time, I'll just introduce a couple of techniques that we'll use in therapy. If it feels like, some amount of briefing on this in 15 minutes isn't quite enough to, calm everyone's anxiety forever and ever. So therapy is a great individually tailored approach to address the specific experiences that any of you might have. Many clinicians will use different approaches, but highlighting a couple of them today, cognitive behavioral therapy focuses on this triangle between thoughts and feelings and behaviors, and practitioners will help you address the thoughts that you're having, the actions you're undertaking, so that you can so that they can create with you a positive impact for your mental health and emotional state. We might also look at the behaviors that we do and don't do when we feel that fear. Are we pulling away from people? Are we spending more time in bed? Do we engage in more impulsive actions? And as we manage some of these thoughts and behaviors, we can turn down that level of sympathetic nervous system activation and spend more time integrated with the world around us. The second form of therapy that I like to highlight, because I quite enjoy this one, is acceptance and commitment therapy. And for those of you who were maybe here a couple of years ago, I think Dr. Breckbiel also highlighted this one, but this is known as ACT. And one of the main questions that comes up in the course of ACT is, how do I live my life according to my values? What do we want to do, all of us, with cancer diagnoses or not, with the uncertain time that is given to us? So that might mean a renewed focus on spending time, but also spending presence with our loved ones, being less overcome by the thoughts that lead us towards, well, what if this never happens again? And be so fixated around that question that we don't enjoy being in that moment. So through ACT, we would work to understand what's really important to you, allowing our bodies and minds to have their natural emotional reactions. And despite that, without dismissing it, the commitment part is continuing to dedicate our energy towards what matters to us. Making that commitment to ourselves that we don't necessarily require certainty to move forwards, to live in the ways that we want to live. And so, thank you everyone for your time. Thanks again to Dr. Hall for the wonderful opportunity to be here, and I'll try to answer any questions you might have.
We have time for a couple questions.
Are you still available online?
Do we make them available?
Have you sent a link to the recording? But I checked with the speakers if they'd like their slides shared.
The recording will have the slides visible too. We'll make sure that you get the link that has the content here for afterward.
Of course. Thank you.
This is kind of a question for the oncologists, but this is one thing I sort of discovered and wasn't really told to me right away, but oftentimes with uveal melanoma, signs of recurrence are only ever show up in the scans, and it's never something that you feel in your body. And that's one thing that reading that I found really comforting, but I'm not actually sure if that's something that is actually accurate in the clinician's experience.
I guess the goal of surveillance is to detect before it creates trouble. So generally our surveillance plans will try to proactively identify if somebody's at risk of developing liver tumors at a very small stage before the tumors get big enough to create even minor symptoms like fatigue or nausea or appetite loss, those kind of things. But sometimes, we do space out the surveillance frequency, the scan frequency, 10 years from after diagnosis. We are not doing the scans as frequently, and we do educate the patients to watch out for any new symptoms. And this is what I tell commonly in my clinic, that, we all have symptoms. We all have fatigue. We all have, nausea from time to time. That doesn't mean it's cancer related. And keeping two words in mind, if you have persistent and progressive symptoms, generally that's something potentially concerning, and it's good to mention those symptoms to your primary care physician or your oncology team that, hey, I'm having this new symptom. It's not going away. It's getting worse over time. And that way I feel like we can mostly keep our patients safe before they develop in big trouble.
I have another question about scans, particularly MRIs. Can anybody tell me why they're so noisy? No, I'm serious. It's like they're mechanical.
What a great idea for a talk for 2 years from now, the next time we have the event. Does anybody want to tackle that with an educated?
I do not know.
I think it
other than the magnets are what us created.
Yeah, I think it's the cooling mechanism for the magnet. So when the magnet is spinning around and generating the image, there's a lot of energy, and they have to keep the magnets cool. I think it has something to do with that.
No, magnets. So that's a really good question. They don't have a good answer to that. I know, right? That's where it all starts. But I have a question that kind of goes along with MRI scans. So, you'll see patients in clinic and you get to know them after so many years. But you can tell something is off on a given day, right? Your favorite patient just doesn't seem quite right. And more likely than not, they've either had their scan yesterday and they're waiting for results, or they're going for their scan after they see you, or it's coming up soon. And for my patients, that is a peak time of anxiety. What is your experience with that? I know, as you pointed out, it's a continuum on how to manage it, but I wouldn't be surprised if any of our patients here were like, yay, I'm going to my scan today. So can you, like, in your experience, share what might work for some and not work for others?
I think, well, for myself, often when I'm talking about scheduling visits with folks, we do schedule around kind of scans either before or after, or sometimes both, so that we have kind of a check-in of like where our anxiety levels might be going in or coming out based on kind of the results that are received. I don't know if that's a sort of privilege that we happen to have in our capacity to see patients at Fred Hutch that might not exist elsewhere, but I often like that in addition to the practice of some of these coping strategies, because there are some points where like something like a scan, probably most commonly is something to do with the scan, really spikes anxiety in a way that even if we're practicing some kind of coping strategy, that might exceed the sort of therapeutic practice. And so with a lot of the behavioral techniques in therapy, it tends to build us toward the tolerance and being able to meet some of those concerns. But sometimes a big enough stressor comes along, and I just like to support that with a visit as well. So maybe in that case, if you feel like, as a provider, knowing that there might be a kind of a concerning scan going forwards for someone, bringing in social work as kind of like a heads up can kind of alert us to when there's a potential need to be brought back into the picture.
One more in the back, yeah.
I'm in a good place right now, and I don't have any problems. I go to the scans and they're all zeros and looking good. But in the future, if I have need of your services, how do I access your help?
Yeah. So a couple things. I'm just going to go back to our contact slide because, all right, that's the two of us attached to the melanoma service. So you can reach out to us directly by email or our phone there. But also, I think usually the fastest way would be to get in touch with your oncology team and ask them to place a referral. And then we can just about always do like a one-time assessment to see where things are at and then kind of go from there. For people who have been not actively followed, our typical practice is to meet the concern in the moment and then figure out if it makes sense to refer someone to a provider in the community for some ongoing therapy. Because one of the other things that I didn't talk about that comes up with this is that when I meet with patients, sometimes it's anxiety about the cancer, but sometimes cancer brings up anxiety and histories that are from way back earlier in life that people thought were settled issues, but brings them back into a sense of feeling like they didn't have control. And that can be really hard and doesn't explicitly have to do with cancer, but was brought on as a mental health consequence because of this.
It's not a question. It's just an expression of deep gratitude for who you are and the space that you hold for all of us. I appreciate your question, how to, I'm in a good place, but how do I reach out if I need some things? Because we've been on the receiving end of that. And I just want to express my appreciation. Thank you.
Thanks to you too.
Right. So I think many patients, when they're diagnosed, maybe the first time they've ever heard that you can get cancer in your eye. And one of the things that I take some comfort in at the first visit when I meet people is that there's a really vibrant community of people with this disease that help provide support and information to people who are newly diagnosed in the form of patients. And so The next two presentations will be from our partnering patient advocacy organizations. So first, I'd like to introduce Melody Burchett, who's the president of Recurrence. I've known Melody for several years. She supported this event the last time we had it, and I'm really thrilled that she's back again. So Melody, thank you so much.
Good afternoon. I'm thrilled to be here. Thanks for inviting me back. At a Cure Insight, we're a patient advocacy organization. And Ritu, I need your help. Oh, never mind. I got it now. Thank you. We're a patient advocacy organization. We are patients ourselves. So we have the motto by patients for patients. And that brings a big insight into what a Cure Insight does, because we're in the community with you. We're walking the walk right along with you guys. So we know what you need. We know what we want. We know what we didn't get when we were diagnosed. So we try really hard to stay as connected with patients as possible so that we are filling any gaps that you might have. One of the biggest things that we're so proud of is that we developed a new patient packet that we send out to patients when they're first diagnosed, and this does help them feel a little bit more connected to the community, gives them some information, and you don't feel quite so lost and alone. When I was first diagnosed, there was nothing out there. So I made sure that we had stuff for people that were newly diagnosed. People don't understand that we do financial aid. We help patients get to treatment. It's a big thing. Sometimes people have to travel very far. We provide hotel rooms, plane tickets, bus tickets, gas cards. We also help with medical bills and living expenses. And it's all, you have to qualify. So we don't just give it to everybody. But if you are having an issue financially, please go on our website and submit an application. We have the first podcast for ocular melanoma. I'm very proud of that. We developed that in 2020 and it's doing really well. We've got Danae and Megan are our speakers that on our podcast, and we have some of you people in our room have been on our podcast, so we appreciate that. But check out our podcast, our YouTube channel, and you can hear stories from other patients. We also highlight medical research and emotional support speakers as well. We try to bring people together. We want people to become patient advocates. We want you guys to help us help community. So please consider volunteering, sharing your story, being a buddy, and get involved with us, because without you, we might be missing a big part of the community. This is something brand new. You guys are hearing about it. We just did a light launch of it. We have an app on your phone. You're tired of social media? We got you covered. It works like Twitter, Facebook, Reddit. And there'll be more on that. It's going to, as it gets launched fully. We also have events to try to bring the community together. We have our 5Ks. We were just here in Seattle in July. We had about 60 people show up in person to walk that day. We'd love to have you all come out. You do not have to walk. You do not have to run. But please come out and meet and talk to each other and show some support. We have a Zoom meeting every Tuesday night at 7 Eastern, 4 Pacific. We have around 20-25 patients jump on. It's really great to be able to talk to other patients. Our annual I Believe patient seminar is coming up in October in Raleigh. And we have our golf tournament in Raleigh every April. In January, we're going to do our Steps for Sight again, where we walk 7,000 steps a day for the 7,000 people around the world that are diagnosed with ocular melanoma each day. It's a real fun, event to get involved in. Swing for Sighters, I Believe. Eye Patch Day is a fun day. It's the third weekend of May. We encourage people to dress up, wear eye patches, try to get get your fellow people to wear an eye patch and see how it feels to go one-eyed for a day. We have a newsletter. Please subscribe to our newsletter so you can be kept up on all these events that I just flew through. Our website, we've got a really great website. Excuse me. It's broken down into newly diagnosed, metastatic, If you are metastatic information avoidance, just don't touch that tab and you won't know anything about it. So we just we designed it that way on purpose. So there's a lot of really great information, and everything that I'm talking about here today is on our website. This is, excuse me, I am so sorry. We have a physician locator. You guys all know you're physicians, but if you ever run across somebody who lives in Iowa and says, I don't know who to go to, and they can't come here, you can tell them about this as well. We are the only ocular melanoma nonprofit that has a store with lots of merch. So if you want to play with some merch, these are some of the designs that we did for for a campaign that we did called Sight for Life. So we like to go big or go blurry. Registry, we have the very first patient registry launched in 2020. 2020 was a big year for us. The Insight Registry is a patient input national history registry. And you fill out your own surveys, and we're going to be publishing some data on this next year that you can always join. You can jump in at any time. Please, if you're in here, please make sure that you are updating your surveys, especially if you're metastatic. We need to know what your treatment options are. This is a big news, and you guys are hearing it here first. So we've launched a biobank, and we are in the process of getting our IRB approval. The greatest thing about this biobank is that it's going to be tied to the registry. So we're going to be able to tie your registry profile with your bio sample, which then we can grow cell lines. And then if a researcher was looking for cell lines for a 20 to 25-year-old female with certain characteristics, we know who they are. Everything is de-identified, but we will be able to give researchers background information to who you are for your cell lines that are developed. So we're really excited about this. This is launching this month. As soon as we're just waiting for some IRB approval, and we're very excited. We think this is going to be a huge plus for the ocular melanoma community. We're on social media. Most of you guys know us there. You can always find us there. We do Capitol Hill Days for Rare Disease Day every year. This is a brochure that we put out with Dr. Mruthyunjaya that we have if you want any to just pass out to people as to why you need a dilated eye exam. It's a great piece of literature. And the biggest thing through all of this is that there's hope. We want you to understand there's hope. I was diagnosed in 2010. I was told I had 2 to 5 years to live. I am still here. So remember what was said earlier, that it's, there's guidelines and there's statistics, but you are not a statistic. You are your own person, and your journey is your own. So together, we are stronger. So let's all stay together, work together. Let's try to lift each other up. A Cure Insight is here behind you, and we want to make sure that you're lifted up. So if you need anything, you can reach out to me, Megan, who does our social media. Danae and Megan both do our podcasts and our YouTube channels. We've got our board members. We're easy to find. Our first name at acureinsight.org. So please reach out. We're also just a phone call away. So if you need anything, if you have any suggestions on things we could do better, we would love to hear that too. But thank you so much.
Thank you so much. With that, it's a pleasure to welcome Caroline Glavin, who is the Education Manager for the Rare Melanoma Subtype Branch of the MRF, the Melanoma Research Foundation, to talk about Cure-OM.
Well, hello, everyone. What a tough act to follow. A wonderful, wonderful presentation. But it's so wonderful to be here. I want to take a moment and thank the Fred Hutch team for having us. It's a real pleasure to be here. And a little background about myself. I come with a background in oncology social work, so it was wonderful to hear the presentations today as well and to be here with all of you. And I'm excited to share a little bit about the Melanoma Research Foundation. So the Melanoma Research Foundation was founded in 1996 by Diana Ashby, a melanoma patient who faced very limited treatment and trial options. So after experiencing her own reoccurrence, as well as loss of friends to melanoma, Diana decided to transform her frustration into determination and action, working tirelessly to drive research and new therapies. Sadly, Diana did pass away just 8 months after her diagnosis, but her compassion and vision led the foundation to be what it is today. And the organization continues to grow and be fueled by the energy of patients, families, and volunteers who carry forward her legacy of hope, advocacy, and the pursuit of a cure. And this is Diana and her husband, Captain Jeff Ashby, and he said her remarkable enthusiasm, hopeful vision, and unique compassion for others lives on in the organization she founded. And a little bit of a history and the mission behind the Melanoma Research Foundation. Diana's legacy lives on through the MRF, and our mission to accelerate research, educate patients and families, and to advocate for the melanoma community continues on vibrantly. The MRF is built on 3 pillars, as you see here: education, advocacy, and research. I personally work within our education pillar, which means creating resources, and every resource we create, we have a patient and caregiver expert who provide feedback on the information we're sorting. So really at the end of the day, it's so important that we have the patient and caregiver's voice developed and threaded through all of the research and resources we offer. We also create resources, programs to help people feel informed and supported. And while we're here today to share materials and answer other questions, I'll also be highlighting some of the educational opportunities that we do offer year-round. So our Cure OM initiative, the Cure OM was founded by a patient and his wife who felt deeply isolated after diagnosis, which I imagine is something you all can resonate with. This vision was to build a sense of community and connection for those living with ocular melanoma. What began as a support network to ensure that no one faces this rare cancer alone has expanded into a broader initiative, advancing research, education, and advocacy to better serve patients and caregivers in the ocular melanoma space. And just for those who are interested, the Cure OM stands for the Community United for Research and Education of Ocular Melanoma. And a little bit about our footprint today. We host several events all over the country. We do 19 miles for melanoma 5Ks. That's a 5K as well as a walk across the country. We have 2 signature galas, one of which is in New York and the other is in Colorado. Our one in Colorado is actually coming up in September, I believe. I believe it's the 19th or the 18th or 19th. We have advocacy days in DC, which I'll touch on a little bit later, but we have patients and caregivers meet with congressional leaders. And this is obviously hosted in our HQ, which is Washington, DC. We host 6 patient symposiums annually, including one dedicated solely to ocular melanoma. And I'm happy to share that we have a save the date for our Eye on OM. It's our 15th annual one for patients and caregivers. This will be in Miami in 2026. It will be April 17th to the 19th. So we'd love to see you all there. And we will be offering scholarships for transportation as well. And one of our pillars, as mentioned, is research. So this slide provides a little bit of a snapshot of the melanoma research that we have funded in the past and continue to fund. In ocular melanoma research specifically, we have awarded over $2.6 million in research grants dedicated to ocular melanoma research funding. And on October 25th, there will be a wonderful event that we're co-hosting, the Cure OM annual scientific meeting. It will be in Amsterdam, and this is ran in conjunction with the Society of Melanoma Research. And we're happy to report as well that we will be doing a patient-friendly recap of that event. So if you're not able to make it, as it is, I don't think right now patient-friendly, but hopefully someday, very scientific-based, but we're happy to report that we will be doing kind of a recap. So I'll mention it later, but we do have Ask the Experts, and we do a lot of recaps. We just had one for ASCO as well. So we're always trying to keep everybody in the loop. Our second pillar, advocacy. So every year we bring patients and caregivers to Capitol Hill, as I mentioned, to meet with their congressional leaders and to advocate for increased cancer, specifically melanoma research funding. And another save the date for you all, we will be heading to Capitol Hill for our Advocacy Day on March 1st through the 3rd of 2026. And if you're interested in being a part of that, I do have a card outside, but if not, you can connect with me and I will send a note to our advocacy director. And as you know, I know this was discussed a little bit earlier as well, but I wanted to take a moment to mention that with today's political climate, the MRF continues to monitor federal and state developments and engage advocates on key issues from sunscreen filter approval to research to federal research funding. It's really important to note that we are committed to working with lawmakers to advance melanoma prevention, treatment, and research. We have a solely dedicated advocacy team who is constantly meeting with legislators and doing everything they can to advocate for the patient. And if you're ever interested in being a voice or sharing your story, that is something that we like to amplify as well. So feel free to reach out to me. And then my sector is the patient education and support, which is our third pillar of education. And we offer a variety of educational opportunities, not only directed at patients, but we create education offerings for caregivers, family members, and providers. So this is a little bit of a snapshot of the educational programs that we offer. We have our educational literature, our webinars, our animated patient videos, which are really wonderful and are in partnership with experts in the field. And happy to share as well that we're in the process of developing one for ocular melanoma. We also have, as I mentioned, our Cure patient meeting. We have virtual support groups, which I'll touch on a little bit later. We have a patient forum, and then a really wonderful resource called Ask a Nurse. And this is an oncology certified nurse who is on staff at the MRF and offers her services to patients, where you can just send her a note if you have any questions or just kind of want to talk some things through. A little bit more, we have over 26 pieces of educational literature available. As you see out on the table out there, we have a whole website where all of those are listed, and they are free to order or download. Those topics include cutaneous melanoma, ocular melanoma, mucosal, acral, youth prevention, pediatrics, as well as clinical trials. So we also send these to physicians' offices, schools, health fairs, dermatology's offices all over the US. So if you're ever interested in ordering some of those educational materials for yourself, your friends, your communities, let us know. And to continue, as I mentioned, we do host Ask the Expert webinar series. We typically try to do these at least once a month, sometimes twice a month. This is a little snapshot of the ones we just recently had back in July. We had that 2025 ASCO highlights for the uveal melanoma community. We had Ask the Expert focusing on the liver. This is treatment approaches in metastatic uveal melanoma, which was extra special as we had Dr. Vincent Ma presenting with a patient of his, Paul Lynch. So it was really wonderful to see them both talk in the space. And all of these and all of our past Ask the Experts are available on our YouTube channel, and we do record them as well. So we're always recording them and putting them right up on our YouTube. So feel free to go back and watch any that you might have missed. And we also offer 2 monthly support groups. They're both virtual for the ocular melanoma community. And we've kind of switched things up a little bit to try and encompass the ocular melanoma community as a whole. And we are trialing our first Wednesday of the month group to be focused on themes in metastatic ocular melanoma. We do offer that, you know, if that's the group you always went to and you'd still like to join, you're welcome to do so. But we're trying to encompass the community as a whole and create spaces for those discussions. And our fourth Thursday one, which is in the evening, that one is just kind of ran as usual, and that's for patients, caregivers. And if you would like to join, please feel free to give us an email at cureom@melanoma.org. And those are all hosted over Zoom. And then we also offer an Eye on OM. It's a quarterly newsletter that just gives you updates in the OM space. We have our research updates, our education, and our advocacy updates. So feel free to join that. That one's a really great resource. That's another place where we'll put up our previous Ask the Experts or any upcoming ones. As well, I do have a little sign-up sheet outside for those of you who didn't have a chance to sign up, but you're welcome to also email us at curom@melanoma.org. We also have a Spotlight newsletter, which is monthly, and that is for cutaneous, as well as some of our other subtypes. So welcome to join either of those, and that's on our website as well. And then some of our prevention and awareness campaigns. We have several prevention and awareness campaigns. We're happy to share that our spokesperson for our Get Naked campaign this year is Ian Michael Crum. He's a licensed esthetician, and he's actually our MC for our annual New York Miles for Melanoma event, which is on September 13th for any of you in New York. We also lead several awareness initiatives across melanoma subtypes. We have our hashtag #IGetDilated for ocular melanoma. We have Spot the Dog for pediatric melanoma and Out of the Shadows for mucosal. And if you're ever interested in our hashtag #IGetDilated campaign, if you want to share your story or a testimonial, please feel free to reach out to us. We would love to engage with you all and have your story be shared. And then lastly, I wanted to wrap up and share a little bit about our Miles for Melanoma event. This is a nationwide series of 5K and walks that allows participants to support and raise funds for the MRF, as well as come together as a community alongside of patients, survivors, and caregivers. And excited to announce that our Seattle Miles for Melanoma 5K will be Saturday, October 4th. And this is just a little bit more information. You can go to that link to register. It's also on our website as well. So if you want to get any more information, I have a postcard out back or outside. And then if you ever want to engage in our socials, or if you go to one of our events and want to tag us, please feel free to do so. These are some of our socials. And then again, thank you so much. It's been a pleasure to be here and to engage with all of you. I'd love to get to know you all more. So if you ever want to reach out, the first one is our CureOM that I know I've shared a few times now. And the second one is my email, but I have my card out front if anyone would like to engage. But thank you all so much. It's been a pleasure to be here.
All right. The last part of the program is usually, there's a reason we do it last, because it usually is very meaningful and it really represents a tough act to follow. So we all decided to go first and then let the patients who volunteered to share their stories do so at the end, because I wouldn't want to have to go after that tough, big act to follow. So we have 2 patient stories. I know we're a little bit behind, but 20 minutes or so for each is, I think, still a very reasonable amount of time. But I'm really appreciative for people who've reached out and offered to share their story. Certainly, if after this you feel like in a future event you'd like to do so, please find one of us and let us know, and we put you on a list. I guess without further ado, I'll introduce Rob Spence, our first patient speaker.
Good afternoon. I'm Rob Spence. I've been asked to do a patient story that I call The New Normal. The journey continues. And the way I've set this up is one portion is specifically focused on diagnostics and treatment, and one that I'll just call kind of the personal component of, when we have this disease, how we handle it, and, at least in my case, how we've taken it on, my family and I. I'm going to start at the beginning. And in this case, it's kind of an unlikely hero, the Washington State Department of Licensing. And if you've dealt with them, you know that that's a really odd thing to say in the same sentence. But in this case, I had to go in to get my license renewed. When I took the eye test, I think anybody could pass, but I was troubled by the outcome. And so I went to see my regular eye doctor, only to be reminded that he had retired. And so I set up an appointment in the same practice with a new doctor, the end result of which she said, I have two concerns about your eyes. One, there was a spot, I'll call it, in one eye that is in the history, but it is grown. I think we've all heard that sometimes. The second one was no history, larger than the first one, that kind of came out of nowhere. So she recommended that I go see a retina specialist. The odd thing about that is I'm a researcher, and so I start digging into what does a retina specialist focus on, not knowing exactly where to focus, but knowing that I'd like to at least come in partially equipped. And so I went to go get my first diagnosis. To give you a rundown, and this is for patients and caregivers, this is not an uncommon process, but I started with Dr. Jones, who recommended that I go see Dr. Cleasert in Bellevue, after which I decided, this is pretty rare, let's get a second opinion. So I found Dr. Amy Scheffler, and now, as you notice, I am seeing both Dr. Scheffler and Dr. Stacey. Kind of in parallel with that, Dr. Scheffler's team, like Dr. Stacey's, has an oncology group, started with Dr. Bernica for several years. When he left to go to another state, went to Dr. Maqsood, and just recently decided to go to our own Dr. Bhatia. The summary of the diagnosis is kind of unique in that I went in, those who've gone through it, your tests, scans, photos, ultrasounds, et cetera, at the end of which, and now we kind of talk about it rather blasé, I'll say, but at the time, a lot of it was absolutely brand new. And he told me that I had a choroidal melanoma in one eye. So we talked about treatment, we talked about options. He's a big proponent of, probably shouldn't say laser, but should say beam. And he wanted to move forward quickly. I said, I want to go get a second opinion, which ended up being going to see Dr. Scheffler. And I remember distinctly, the date was January 20th, 2018. My wife and I sitting in the room after all the same battery of tests and scans, et cetera. And she said to us, I'm so glad you came in today. You're a rare one. You have choroidal melanoma in both eyes. And we looked across the room without saying a word. You know what it's like when you've been with somebody a long time. It was kind of the shit moment. And so we said, okay. And by then I had done a bunch of research. I had a lot of questions, at the end of which I said, we'd like to move forward. And she said, can you spend the weekend? We're going to get on this quickly. And we'd like to measure you for plaques Monday. So things did move quickly. This is when, that was the first trip. Since then, there have been many trips to Houston because Dr. Scheffler is in Houston. So that was January 20th, very early February. We scheduled surgery number one. She wanted to do the most difficult one first. Happens to be on my right eye, the one that didn't have any history. And so I researched everything with one exception, and I'll say I'm a little gutless here. I didn't go look at any videos related to how they put the plaque in, because I knew I was going to be out anyway, so I didn't need that trauma. So I went in, had the surgery done. Her process is put in the plaque on Monday, stay in Houston for the week. The following Monday, remove the plaque. Tuesday, go in for a post-op, catch a plane back to Seattle. At the time, I was leading a project at Boeing, and this is pre-COVID. They didn't really have much for remote work, but I kind of worked out a deal not knowing what I was getting myself into. And I said, oh, if I can work during this process, let me do that. And if I can attend meetings during that process, no video, I will try to do that. So the first one was more difficult than I guess I had imagined, but I did work some. And then immediately upon returning, went back to work full time. I certainly didn't look very good, and there was a lot of traffic by seeing who's the weird looking guy. But 6 weeks later, we did it again and did the left eye. That one really was much easier. I could work more and return to work by then I kind of knew what I was in for. And my wife was the trooper because, I didn't look great in lead glasses. So she took care of things while we were in Houston. The other thing I'll toss in, we've talked a lot today about Castle Biosciences and their results. Well, at the time, this was somewhat of a big deal, I was told, but my right eye is a 1B and my left eye is a 1A. The good news is, we heard several times today, they're all ones now. The good news is they're all ones now. So, I want to change from here, that kind of sums up the medical stuff almost, and talk about how we dealt with this from a personal standpoint, and to kind of trigger on some of the stuff Alex was talking about. It was a great lead into this. After the first diagnosis, my wife and I sat down and we made some real important personal decisions. We said, my goal was to get back to the new normal, whatever that was going to be, because I wasn't really sure, as quickly as possible. And that my approach was going to be, I was going to be positive and stay positive. So some of the things that Alex talked about, I'll give you an example. When I go into scans, whether they're abdominal scans or eye scans, my approach is the outcome is going to be good every single time. Not everybody can do it that way. In my mind, I go in with that approach. They aren't always good, but at least I go in with that mindset. And we also made a decision that we were going to live life. We weren't going to make radical changes. We weren't going to modify our lifestyle significantly. The goal was going to be whatever that new normal ended up to be. So, like I said, we didn't make radical changes. So no major changes to diet, no major changes to exercise, kind of get back to where we had been, knowing that we didn't have control over everything and we didn't know what the future was going to hold. One thing we had been planning for was retirement. I was 64 when I was diagnosed, and we kind of had a plan at around 65 that I was going to retire. I still haven't talked to my wife into retiring. I hope you're listening. And so I about 6 months or so after surgery 2, went to the consulting firm I was working for, who was treating me really well. And I said, I'm going to retire. And I said, but if I'm not good at this, because, by that time in your life, you've worked for a long time, and just stopping is a radical change. I said, if I'm not very good at this, what about if I come back? Well, they were really good about that too. And 3 or 4 months later, I called them and said, this isn't working. So to make a long story short, over the next several years, I changed from full-time to full-time, not all year, to part-time, to bunch of months off. And finally, a little over 2 years ago, I retired. That in itself, obviously, was a radical change, but the way we went about doing it, because we'd been planning about it for some time, worked out well for us. The other 2 components I want to talk about are what I call the important knowns. Now, some things, and I liked Alex's comment, some things you have control over, and some things you don't. But in my case, I would say one of the most important knowns was the family and friends and my wife. I've mentioned the coworkers that I worked with have been an amazing support group. We decided very early on we were going to tell people what was going on. We were going to tell them what we knew and in some cases what we didn't. And for us, that was something that settled us significantly. The other thing I'll say that's been a known, and I show you the litany of doctors, and there are certainly their staffs as well, that I think, number one, we've been really lucky. We made some really good choices. We've gotten some great advice, for the most part, great results. And so I will say that an important known for us is feeling very confident every time we go in to see somebody that we're getting great care. The other thing I will say is that regardless of what's happened over this crazy journey, is I consider myself healthy. Other people might not think that. And I very seldom have a bad day. My belief is, try to make the best with what you got. And so that's what we attempt to do. Like I said, not many radical changes. We still travel, we still socialize, but we do that knowing that there are a variety of unknowns as well. And we've talked about these off and on today from a variety of perspectives. In my case, I've been very lucky. Yes, I have side effects. I have radiation retinopathy, and yes, I get to go see Dr. Stacey for that. And the good news is it's been treatable. And so it's not much fun. I wouldn't have believed that what he's doing to me would ever happen, but the side effects have been manageable. But they're unknown. The next time I go, and he surprises me every once in a while, the next time I go, well, it'll be a pressure problem or God knows what, more fluid. Who knows? I've already mentioned the scan component, I guess. And in my case, fortunately for me, we started out with scans every 3 months, lots of trips to Houston, and now we're at a year. I say that I go in with a positive perspective. Same thing's true with the chest x-ray, and I'll say the same thing's true no matter how frequently I see either Dr. Scheffler or Dr. Stacey. But the eyesight's an unknown. I mean, it could, the next time I go, week after next, who knows what we'll find. And I mean, I see a lot of heads nodding because that's our life. And the last thing I'll say in terms of unknowns is these two are cancer number 5 for me. And fortunately, all the other ones have been addressed, I'll say. But who knows? I mean, maybe there'll be another one. And so that's an unknown as well. And if it happens, well, then we'll try to address it. And so that's how we've tried to take it on over the last 7.5 years, kind of the personal timeline, diagnosis, Department of Licensing, and then the first eye exam in December of 17, then a really shotgun approach to diagnosis 1 and 2, surgery 1 and 2, all done from January to March. And since then, until today, it's been, scans, like I say, the abdominal ones are now annual. I get to see Dr. Stacey about every 6 weeks, and his staff has been great. I will say one of the things that has been hugely beneficial is during COVID, I wasn't going to fly to Houston. So with some help from people in this room, I was told, go see Dr. Stacey. He took me on. Now Dr. Stacey and Dr. Scheffler are working together. That's a wonderful thing. But life goes on. So I try to manage it day to day. The journey continues. And we just try to live life. So, any questions? Fire away.
Dr. Stacey, here.
What question can you ask that you haven't asked me already?
I've asked him many. No, it brings up an interesting question for me. Could you explain to me and maybe the others here, how much does the level of anxiety, because you come to see me so often, how much does the level of anxiety when you come in to see me compare to the level of anxiety when you see your medical oncologist?
It depends on who it is. I mean,
that says nothing about Dr.
Yeah. Well, the interesting thing is, Dr. Bhatia gets a pass because I've only seen him once. So I will say, and Dr. Stacey's familiar with this, I've had prostate cancer for 14 years and fortunately go to a doctor at UW, and he's fantastic. And we've been, we heard a lot about, monitoring. Well, we monitored for a long time until we finally couldn't monitor it anymore. And so I've gone through the radiation thing more than once. Because that doctor is kind of like you, it's not unsettling to go see him. I've been seeing him so long. I feel like we have a good relationship. We talk very candidly. He puts up with my crazy research questions, and I feel very comfortable. The ones I'm probably a little bit less comfortable with, I only see my primary care physician usually once a year. I see Wendy nodding her head. Once a year, and you walk in and, they've got for me, the standard litany of Medicare stuff that they have to do, which is kind of a waste. And then he always has to get the background on what's going on with your eyes, what's going on, and all the other stuff. And his is more of a crapshoot because he's looking at everything, stuff that we aren't monitoring. And so to sum up the question, because most of the stuff that's, I'll say, active gets monitored frequently enough, I'm comfortable, other than a pressure problem now and then or something, you know. So I go in again thinking I'm healthy, and so I expected to leave, and whatever the new thing was, well, we'll figure out how to handle it. So, good question. Yeah. Yes.
Got a question in the middle there.
Thank you so much for your story. So what do you do? Looks like you're very active and healthy. What do you do to manage?
When I say active, we travel a fair amount. My wife and I, and sometimes with our kids, we have 2 boys that are adults now, and their significant others. We tend to socialize a fair amount. The other part of, I guess, activity is we just we don't stop much, and so we try to stay active. And I mean, you read all the stuff about, you know, engaging. We engage a fair amount in a lot of things, including new stuff. I also volunteer for an organization that it's called SCORE. It helps small businesses, for the most part, start. And so I've got a bunch of clients that I work with, and for me, that's invigorating and personally rewarding. And had I found that earlier in my retirement phases, I would have probably stopped long before I did.
All right.
All right,
Thank you so much.
Thanks, everybody.
So for our second and final patient story, I will introduce Nikki Doyle, who, if you were at part of the event 2 years ago, maybe you may recall, Nikki also shared story at that event. So Nikki, thank you so much.
Yeah, quick. All right, we're going to see how I do this time. I do have my readers this time, so I can read my cards. I don't know, for those of you who were here last time, I brought them, my cards, but I could not read them. So also the addition of PowerPoint, that's something new for me, exciting. I am Nikki Doyle. I was born and raised in Washington State. I have been diagnosed with ocular melanomas for 7 years now. August of 2018 is when it was found. In October is when I first had my my treatment. But first, before I go any further, I'm realizing I jumped way ahead. I got excited. I'm super excited. Let's do this. I want to talk to you today about the coping skills that can enrich our lives when we're faced with hardship, whether that's ocular melanoma, whether that's another type of cancer, whether that's another type of health issue. I have lots of family members who have lots of health issues, not cancer, but they all face hardships. I also want to start by acknowledging that the land that we're here on today is the traditional territories of the Coast Salish peoples, whose ancestors have lived and cared for these lands and waters since time immemorial. I encourage everyone to, if you haven't already, if you have the opportunity to go see a powwow, support a small business, please do so. These are very strong and vibrant communities. I also want to just acknowledge all of the care teams. We've already done this with several other people, but without my care teams, without their partnership, without their dedication and hard work, without all of our caregivers, those folks who are willing to walk along with us on this journey, these journeys that we have would be a whole hell of a lot harder. So thank you for doing that. And I want to say welcome to my fellow OMIs. We see some of your faces, and I'm super happy that you're here as well. Brief history, this is where I leapt to. Let's get back to it. So I had my initial diagnosis. I was, of course, class 2 PRAME positive, which is, as we've learned today, is not necessarily the category that you want to be in. And I did have metastasis-free for just about 2 years when they discovered that it was in the right lobe of my liver. And I underwent 1 immunoembolization before COVID hit, and it kind of descended here in King County. And I had some adverse side effects, so we opted to switch to immunotherapy, where I switched to the Ipi-Nivo combo. And I had 2 of the combo doses before I had to stop and pause due to some side effects that were quickly and promptly taken care of through steroids. And I was able to go back on nivolumab, and I continued through the end of 2020, where again, I paused due to side effects. The result of that, also in that year, the eye tumor, the original eye tumor, did start to regrow again. And we had some big conversations and a lot of late nights of not sleeping very well and evaluating with myself. Was I going to keep my eye? Was I going to let my eye go? And thankfully, I had the care of a great physician who said, you don't necessarily have to do anything about it. You're already doing immunotherapy. We can just wait and see if that's going to take care of the problem. Thankfully, it did. I not only had 3.5 years of stability from the liver tumors, and some of them did shrink, but also the original tumor in my eye, when we went to look for a 6-month visit, was not only dead, but surrounded by necrotic tissue that kind of looked like a halo. So it gave me a lot of hope. 3.5 years later, January of 2024, after having a hysterectomy, thank you, perimenopause and menopause, it was discovered that the tumors started to regrow again, and that not only were they in the right lobe of the liver, they were also in the left lobe of the liver. So back to treatment I went. I opted to follow the doctor's recommendation, and I did 10 immunoembolizations. We found out what medications were causing the side effects, and we're able to switch and find other ones that were more powerful and just as well. Those being, I was allergic to CT contrast, so there was a lot of finding which CT contrast I didn't react to as much. How do you pre-medicate for that? It was a lot of back and forth, and I'm just so grateful for the people who are dedicated to not only provide these treatments, but help us not have a shitty quality of life, for lack of better terms. They actually work with us and will partner with us to try and help get us through these with the best quality of life possible. We all know there's going to be the suck factor when we go into treatment. But it's nice to know that there's a team of people that want to work with you to try and minimize that. Love building partnerships with the care teams. I have no idea where I am on here. So let me just take a moment to get present to that. Fostering partnership. I did the 10 immunoembolizations. I still do the low dose nivolumab, which was something different that we added that wasn't an option back in 2020. And so I'm still on low dose nivolumab. I do that every 4 weeks, and I still get scans every 3 months for my abdomen MRI. I also developed 2 brain metastases that were discovered in early February. I underwent a craniotomy surgery where they were safely able to remove both tumors. And I did 5 rounds of gamma knife radiation, which that was a pickle. There was someone who talked about an MRI machine being a little loud and noisy and a little scary and daunting. Yeah, I got to really learn and practice some of the tools in my tool belt, some of those coping skills that I've had to learn over the years when addressing that one. But I'm here. And when I was first diagnosed, as Melody said, 2 to 5 years, I have outlived numerous expiration dates is what I've come to call them. Images here, that's me on the left, right after, I call that the most terrifying and the most joy-filled day of my entire life. Where the tumors were located were behind my ocular melanoma eye, which those of you who understand this side of your brain deals with the right side of your body. So with being blind in my left eye, I had no idea. I get a little touched by this sometimes. It comes up. I had no idea if I was going to be able to walk, if I was going to be able to talk. I had no idea if I was going to be able to see. And I mostly had no idea what kind of human I was going to be when I came out from the surgery. And I was so grateful to wake up not only starving, because who isn't starving when you're fasting that long before you have a surgery, but I could see, I could smell, and that was some of the best food I've ever had. Who can say hospital food is some of the best food you've ever had? But it literally was some of the best food I've had. And I was surrounded by the people who, just that inner circle of people who love me. My spouse was there, my niece was there, and our dear friend who's stood by us through multiple things was there. The center top one, that's the Gamma Knife team. These people were amazing. I really had to tap into a different part of myself in order to get through that 28.5 minutes. And they would sometimes try and shorten it to 28. And I'm like, no, it was 28.5 minutes. Each time that I was in that tube, that bottom image with my Pink Floyd shirt on, that's the mask that they had me in. I didn't have my eyes open. I had my mouth closed. And I was strapped to that table for the 28.5 minutes. How I got through that are some of the tools that I want to talk about. There's the therapy that we have to do. I had to do those therapies in order to extend my life. And then there's the therapies that we get to do. I'm going to go really quickly through this. There's the traditional types of therapy. We've heard a little bit about some of those today. The ACT and the CBT. I just really encourage people to take a look at what types of traditional or talk therapies are available and which ones speak to you, and seek out your teams and get some recommendations for those. Where I usually live is the non-traditional forms of therapy. These are the things that, you know, when I was a kid, my dad gave me a pocket knife that I could carry around in my pocket on the weekends, and I was encouraged to whittle. That's a hobby I never thought I would take up, being blind in one eye, but I've tried to make a spoon. I love whittling on sticks. I do a lot of dancing through the kitchen, a lot of singing through the kitchen. I love music, so I explore all different types, all different formats on multiple platforms. I also do EFT tapping. I get a lot of animal therapy when I'm out on the hiking trails, getting in some nature bathing, visiting with other people's animals. Probably the few things that really helped me through my treatments is mindfulness, meditation, and visualization. When I was in that tube for that 28.5 minutes, my visualization techniques really, really helped me. So packing our tools, depending upon the job. The luggage on the left is what we bring to the hospital. That's what we found has helped us. But this is more a metaphor of what sort of tools do you pack? What sorts of things help bring you joy and help you find peace and will help sustain you through a cancer diagnosis and all its ups and downs and all its challenges? What gets you unstuck? What inspires you to get out and to live your life? Art therapy. Journaling, yes, I did journaling. I did gratitude journaling. I didn't necessarily enjoy it, but I found the benefit in it. And what I ended up doing is, rather than journaling about things that were happening, I turned it into a love story. I wrote journals for my family. I wrote journals for my spouse. These are legacy things that later they'll get to fight over who gets to read what and when. I thought it would be fun to take up watercoloring. I really don't have the patience for watercoloring. But I tell you, it's a lot of fun sometimes because I don't like writing on white paper. So sometimes I'll just pull out my watercolors and play with color itself and just paint things that later I go back and do journaling on or poetry writing. I do still take lots of writing classes. not because I enjoy the art of writing, but it's interesting what it can pull out in me. Some of the things that I'm bumping up against, that my natural way of being is to avoid those conversations, avoid those thoughts, avoid those fears. And the writing classes kind of pull that out of me. And so it gives me an opportunity to process, to work with my therapist about, you know, this really came up this time. So I think it's time to dive into it. After my craniotomy surgery, I did have a tremor. I did struggle with walking for a little bit. And so I couldn't journal, and I didn't really want to do art. But when I finally calmed down after being home for a few days, in the middle of the night when I couldn't sleep because I was on a really high steroid, I just pulled out all my markers and a blank sheet of paper. And the number one thing I could do was scribble. And it was so therapeutic. I could scribble away as hard as I wanted, or as gentle as I wanted, or as fine as I wanted. This was the first thing I did. This was my first scribble. And the goal of art, as Alfred says, was the vital expression of self. In this moment, I had a very out of body sort of experience in just expressing everything that had just happened. It helped me process as I went. Next up, mindfulness, cultivating joy, being in the here and now, finding peace, maintaining your center, and choosing intention. I've done a lot of ontological work in my life, going from the why is this happening to what is this trying to teach me, to choosing who I'm going to be in the face of all of it. I choose to cultivate joy. I choose to find moments to laugh and to giggle. These caps, man, I've put those caps in all sorts of ways. And I don't sit on the bed while I'm waiting for procedures. I make them give me a path that I can walk. And I try and get people to laugh and giggle. And we were celebrating my wife's 51st birthday while we were still at the hospital. They hadn't released me quite yet. I dragged my friends, my family, and my people out onto the hiking trails. We got to celebrate the birth of one of our great nieces. I had to think if she was a great because I do have those, but this was my great niece. Gathering with friends and cabins for visiting. I got to see and kiss some family that I haven't seen for 3 years. That was incredibly, what a wonderful way to spend the summer months. Circle back around to visualizations. Family is a great way to visualize that. When I think about when I was in that tube, the only place that I could escape was to the places in my mind. One of my favorite places was sitting on the beach and the feel of the sand between my toes, how it was hot on the top, and if I wiggled my toes beneath, it was cool. The sound of the seagulls and the wind blowing and the feel of the sea breeze on my arms and my skin. So take a moment, sit for a second. See if you can't visualize one of your favorite places. Visualize your favorite camping trip, the sound of the crackling of a fire. What are those things for you? Seize the opportunity to seek beauty. I love visiting pea patches. The bottom one with my shaved head, that was when we were just released from the hospital. And we were on our way home and there was these beautiful poppies and lupins. My wife screeched to the side of the road and we just sat and took pictures. I just encourage all of you to find ways to seek your joy, to seek your peace, to stay present in the moment, to seek out to your communities, whoever they are, however you need to make that happen, whether it's seeing them in person, dragging them along with you out for adventures, finding them on weekly Zooms. They're out there. It's not just our groups, but there's free resources all over the place. Talk to your social workers. They've got lots of resources. That's all I've got.
All right, and you can see why we end with that. But, you know, I think a couple of very moving patient stories. Thank you to Rob and Nikki for sharing. So we're done. I think I'd like to say a few thanks before we part and encourage you to fill out the feedback forms. I often forget that, so I'm not going to forget that this time. So we really look at these every time we plan the next event. So if there's something that you'd like to hear or angle or a topic that you'd like to touch on that we didn't, please suggest that on the forum. Tell us what you liked, tell us what you think we could do better. We want to improve and make each event better than the last. And we really take those feedback forms quite seriously. I'd like to thank, again, Ritu and her whole team. Meredith, Alana, and Sarika were also here supporting today's event. Tremendous amount of planning goes into this to help us host this event, get the word out, and have everything run smoothly today. So many thanks to them. I'd like to thank my co-chairs, Drs. Bhatia and Stacey, for helping organize today's symposium. I'd like to thank our patient advocacy organizations for supporting the event. Special thanks to Ocular Insight for helping support the funding to allow us to have lunch to feed you all during today's marathon program. And lastly, I'd like to thank you all and everyone who attended online. You know, we have this event for you, and I think to me, it's like chicken soup for the oncologist soul. Like, I find it very rewarding and gratifying to be here and to see the enthusiasm, the dedication, and the community that's present at events like this. And so that only happens because you all are interested in coming and come. So I just want to thank everyone who participated today, patients, caregivers, their loved ones, in person, online, everybody. Thank you so much. All right, class dismissed.